Hello, testing. Hello, mics. Hello. Ladies and gentlemen, we will begin shortly. Kindly occupy your seats and settle down comfortably. Our seminar will be commenced in a few minutes. Thank you for your cooperation. To begin today's academic journey, may I respectfully invite Dr. Ruben John, consultant psychiatrist, KMC Hospital, Chengannur, to deliver the welcome and introduction.
Hello. Good morning, everyone. Thank you so much. We are sorry for the delay. We were waiting for other delegates to come. But there's some delay from their side, but we have to start because of time constraints. I request any delegates who are still waiting and standing to come and join us. So we're going to start. My role today is to introduce the hospital, to introduce our CME, and also to welcome all of you who have come, who have painstakingly taken the time to come so early in the morning to join us for this seminar. So at the beginning was 2021. That's when the hospital was started, and the next year 2022 is when we started the department here. I still remember when I joined in Jan 1st, 2022. It was just the OPD, and the 7th floor was just being constructed. So I remember walking among the cement packets and all the building materials, and having that idea of how we want this to be done, how the room should be done. And so I feel that it was a big honor to be there from the thought conception itself, and to see how far we've come today over the past 4 years. Our focus at the hospital has always been my approach called biopsychosocial bio. So in psychiatry, we always say biopsychosocial. But here, when I say bio, I mean first is we take the situation and we stabilize. We try to just relax. But the main focus is always to talk, to listen, to see what kind of psychological supports we can provide, to see what kind of social supports we can provide. And after that, if required, medications. So that's how it comes to biopsychosocial bio. So active listening and identifying treatment goals. Sometimes I see that the biggest problem is you just you're treating the diagnosis, but sometimes it's more important to have treatment goals. What are we trying to actually achieve here? Because sometimes I was talking to my friend who's a child psychiatrist. She says that even our guidelines say that, even Maudsley say that diagnosis is not important. You want to treat the suffering in front of you. That's more important than just the diagnosis. And another important part of the hospital focus is mental health awareness, destigmatization. That's one thing that we do very passionately and we take very seriously. So obviously for a biopsychosocial bio model, I cannot do this alone. I've never done this alone. We are a team. And every member of the team is involved. So this is our psychiatry team here at the hospital, our nurses, OP staff, and our counselors and psychologists. And it's a joint effort. Every patient is a joint effort. And as I say that, I realize, especially with this CME, that it's not just our department. The hospital is a team, starting from our board of directors, Shri P.M. Sebastian, from our beloved MD, Dr. Father Alexander Kudarathil. The fact that we as an institution is conducting a psychiatry and psychological mental health CME is something that makes me proud to be a part of the institution. Because I know institutions that try to suppress mental health. They don't want people knowing that there is a psychiatry department here, that mental health or psychological disorder patients are being treated here. I know doctors who have told me that hospitals have tried their best not to promote that department. So to be here, where we are not just promoting the department, we are shouting out loud that we have this department, and organizing a CME funded by the hospital, because everyone knows that psychiatric department is not about the money. We don't have surgeries, we don't have procedures. What we have is to take a person who is stigmatized, who is discriminated against, and give them a voice. So, so the fact that the hospital has given us this much of a voice in the public, in social media, everywhere, called all of you, invited all of you, makes me proud. And also the Chief Operating Officer, Dr. Rebecca, the Chief Financial Officer, the Chief Nursing Officer. It's a team effort, not just from psychiatry, from the entire hospital. The minute the patient comes in, the security team, the OP team, the IP team, everybody has a role to play in the betterment of our patients. Like I said, our mental health awareness is a big thing for us. We go to schools, we take, our MD has allowed us to cut off one of our OP days. We don't see OP. We are, obviously, when you're talking about a hospital, you're losing revenue there, but he doesn't care. He wants us to go out and destigmatize the population, destigmatize the public. So we go to schools. So this is us during anti-drug abuse drive in Chinmaya Vidyalaya. We are graced to have the principal, Preeti Madam, here with us today. The photo at the lower part is their Vimukti Club, which they take very seriously, and that was something that made us all very happy that day. We asked who the Vimukti Club is, and a lot of students came forward and took the pledge with us that day. We go to colleges around the institutions that we have around here. We spread awareness about, especially in Kerala, the anti-drug campaign by the government itself is very high, and we have done our part to make sure that the message gets out as much as possible. So all the colleges that we coordinate with in our area, we are doing them one by one. All of this is an ongoing process, and we have done around 25 to 30 till date, and we continue to do one every month. Even religious institutions and societies, on Sundays, our team accepts the invitations to go to religious institutions. The NSS, Nair Service Society invited us. We take this that seriously that we go on Sundays, our one day off, to make sure that we can spread as much of the message as possible. ATPP is accident treatment with public participation. This is predominantly about law enforcement and industry workers. The basic goal is to teach them BLS, basic life support, and CPR. But they have given us an opportunity here to talk about post-traumatic stress disorder and mental health destigmatization as a part of the ATPP program. That also, there is no, if you look at it in one way, there's no need for you teach them CPR, come back, you've done. This is, they don't get any additional points for this. We do this because we care. We care for mental health. We care to get our message in at any possible point we can. And moving with the times, our marketing team, Mr. Nebu and team, our hospital care promotion team, Mr. Prince and team, they work day in, day out to make sure our messages are heard. And it's more important because we need to get it out in the local language. We need to make sure that people understand. So whatever it is, whatever they can get their hands on, they make sure that we get it. And this all is in the background. They're not celebrated for this. They work in the background day in, day out just to get us these programs, just to take these videos. They stay up till 1 in the night editing these videos so that we can get them out. So they are unsung heroes for us. Then we have our international collaborations. So the Consul General of Maldives, Her Excellency Aminat Shifana, will come today to join us as a show of their dedication towards our collaboration. This was when the Minister of Homeland Affairs of Maldives came and visited us to sign an MOU for treatment of patients from Maldives at our hospital, because they have a very serious drug problem there, and they are very serious about the treatment as well. So they're looking at all avenues, and we signed an MOU with them to coordinate with the government of Maldives for the treatment. And other international collaborations involve a seminar that we do for, this one was Navodaya, Australia, about parenting. But the reason I bring this up today is because we talk about a lot of diaspora in the Middle East, in the Western countries, in Australia, UK, Germany, everywhere, and we always see them as, they obviously, I'm just going to put it out there, the currency exchange is really good. We think that they're having an amazing time. But mental health wise, to see a psychiatrist, it takes 3 months. To get an ADHD assessment takes 5 years. I was talking to a doctor from UAE yesterday. She's referring patients to India because her single consultation is 10,000 rupees. A psychological assessment in the UAE is 75,000 rupees. We do it for free here for our IP patients. So there is a need to reach out to the diaspora. I said Keralite because that's how I reach out to. But even if it is Karnataka, even if it is Andhra, there is a need to reach out to them because they are silently suffering. So this is something that we have also identified, that they are silently suffering. They do need our support, and it's a part of our international collaborations as well. Also, now I'd like to move to the welcome. Our chief guest, there's an inauguration also as a part of it, and I'll be welcoming them again. But Dr. C.T. Aravinda Kumar, our Vice Chancellor, MG University. He was gracious to accept our offer to come. Also, Her Excellency Aminat Shifana, our Chairman, Shri P.M. Sebastian, our MD, Dr. Father Alexander, and also like to thank Dr. PSVN Sharma. Sir is my professor, he's my guru. And so it's a privilege to have you here, sir. Also, Dr. Varghese Punnus, he's the HOD of Kottayam Medical College. I'm a kid. One call and he said yes. So that means a lot. Dr. Suma Udupa, in the scientific committee, if you read in our scientific committee, it is written that, I am the scientific committee and few other names. Dr. Suma is my scientific committee. Dr. Sharma sir gave me the directions, but I sat with Dr. Suma. She is amazing. She is so happy when you take the phone. She doesn't mind talking to you. She first told me, don't worry, I'll give you the list I'll go through the current research and tell you what is currently going on. Out of the kindness of her heart, it's then that she realized that most probably she'll be doing all the work. So then she said, Ruben, you will also have to help. So that's the kind of person Dr. Suma Udupa is. Dr. Radhika, unfortunately, couldn't come today because there's a major chaos going on in the aviation industry. No flight took off from Kolkata. Dr. Manju P. Vidambaram, madam is, we all, even doctors, we have families, we have crisis. So to have someone to hand over our patients to in that time, someone you can depend on. Sorry. That's what Dr. Manju is to me. She's an elder sister. Also, Dr. Sister Joanne C., Principal Trada, she accepted our invitation. Dr. Jayashankar, thank you so much, sir, for joining us today. Dr. Anup ji, I want to thank him wholeheartedly. I could not meet him today morning. Yes, okay, sir. Radhika had to cancel, and Dr. Anup, last minute he had nothing to say, but yes, not even what the topic was. He didn't want to. He was like, okay, fine, whatever. I don't care. I'm coming. So it's these kinds of friendships and collaborations that make me proud to actually, be back in Kerala, stay back in India. Psychologist Priya Varghese, she is a prominent psychologist in Tiruvalla. Sri George Matthew, he's a prominent family therapist in Tiruvalla as well. They do amazing work. They really, Dr. George Matthew spends 5 hours minimum with his clients in a single go. And that is the level of dedication that we should all aspire to, even though the time may not allow. Also, all the delegates that as I said in the beginning, all the delegates that came today, with us today, we're waiting for more. Thank you so much for coming. Last but not least, my mom, my dad. My wife and her parents. Definitely would not be here without their support. A lot of doctors ask me, they're very happy with the theme. They said that the theme is, really good, really relevant. I was talking to Dr. Suma. I was like, I did not think of anything else. I just saw my patient profile and I was like, what do I do here? Addiction and borderline is such a difficult experience for both the patients, not both, for everyone, for the patients, their families. Thank you. For the patients, their families, and even us physicians. A horrible experience. The relapse rates are so bad, they just don't listen, poor coping skills, poor frustration tolerance, unable to accept the diagnosis, unable to accept the stigma. It's a major challenge, and everything we do is to try to prevent a relapse, try to prevent this patient from again being an IP patient. So it became a major challenge, and I realized that this is something that we do need to talk about. And every time I called a colleague of mine, they're struggling with the same. So I thought it was time because addiction is a major challenge in Kerala at least, and comorbid borderline personality makes that challenge even worse. So, like I said, we take our launch, sorry, our mental health action project very seriously, to the point I'd like to call upon Miss Gayatri Ganesh Kumar, who is the creator of our new logo, which we are launching today. Oh, wait. Just press. No, just have to. Yeah, it's on the screen. Make activation.
Hello. It's nice to be here. Thank you for this opportunity. It's a little nerve-wracking because this is my first time doing anything like this. But I really wanted to help with this when I heard about it. I wasn't sure, and then suddenly I got an idea of what the new logo could be. And I decided that um, I wanted like sorry.
It's okay. I'm here.
Yeah. I wanted to represent our journey of healing our minds through and going through this entire process by our having it represented by blooming flowers in a bouquet. The flowers I picked especially forget-me-nots, sunflowers, peonies, and jasmines, and I wanted to pick them because they were representative of either good mental health or mental strength, and I hope everyone likes it.
I'd like to invite our principal madam, Mrs. Preeti, principal of Chinmay Vidyalaya Chengannur, to felicitate Gayatri. I'd also like to invite the creator of our old logo, Reverend Father Bibin, to gift Gayatri with the cash award.
Thank you, Doctor, for setting a warm and meaningful tone of today's seminar. Dear all, here we begin our first scientific session. May I respectfully invite the chairperson, Dr. J. Sangarji, and the speaker, Dr. Sumati Udupa, to kindly come forward to the stage. Dr. J. Sangarji is a consultant psychiatrist at VSM Hospital, Mavarikala, Kerala, with MBBS and MD in psychiatry. He is experienced in comprehensive psychiatric care and is a part of the multidisciplinary team at a well-established multi-specialty institution serving Central Travancore. His practice integrates careful diagnosis, pharmacology, psychopharmacology, and psychosocial support, offering mental health service to diverse populations, including patients with chronic illness, comorbidities, and family-based mental health needs. His work reflects commitment to community psychiatry, holistic patient care, and mental health awareness. Sir, we warmly welcome you. It is my honor to introduce Dr. Sumati Udupa, Associate Professor in the Department of Psychiatry at Kastura Medical College, Manipal, part of the esteemed Manipal Academy of Higher Education. Dr. Udupa holds MBBS followed by DNB and DPM in psychiatry, and her academic commitment extends beyond clinical care to medical education, training, and research. Her research interests are and clinical expertise include bipolar disorder, addiction psychiatry, delirium, and teaching learning process in psychiatry. Among her significant contributions are publications on workshop-based education and case reports in psychosocial health and dissociative disorders. She is also a faculty member of the Medical Education Unit at KMC Manipal, contributing to shaping future generation of doctors, balancing clinical service, academic instruction, and evidence-based psychiatric research. Ma'am, we warmly welcome you. Dr. Suma, you may kindly begin your presentation.
Next forward.
Good morning, everyone. So, the topic of my presentation today matches with the theme of the CME. So, addiction and borderline personality disorder, the crossroads. Not sure if we can call it as crossroads, if they're parallel roads, or if it's the same road too. Okay. So, as we all know, addiction, of course, it's a chronic brain disease, and one of the most important character of calling it as addiction is the loss of control associated with persistent use despite harmful consequences, diminished recognition of problems that are related to the use. Borderline personality disorder, it's one of the most severe personality disorder, mainly characterized by unstable self-image and interpersonal relationships, emotional dysregulation, impulsive acts, And what we are more worried about is the suicidal and the self-harm behaviors. People with personality disorders often experience substance use related problems and do meet the criteria for substance use disorders. And similarly, people with substance use disorders often struggle with challenges that are related to personality dysfunction. This co-occurrence is the one which leads to a lot of negative consequences, poorer treatment outcomes. There is higher severity and chronicity of both disorders compared to when they are independent. A brief outline of my presentation today. So this is how I'll be going. So do they actually co-occur? Why do they co-occur? What is the result of their co-occurrence and how to manage this? So first, do they actually co-occur? So most of the prevalence studies do say that they do co-occur. Approximately, looking at patients with borderline personality disorder, approximately half of patients with BPD had at least one substance use disorder. Current and lifetime prevalence being around 45 to 75%. Alcohol, of course, is the most common substance that was seen, followed by drug use disorders. Lifetime prevalence of nicotine was around 50%. Men more than women had substance use disorder. Men with borderline personality disorder had more comorbid substance use disorder. And this is not just in the adults, this starts right from the young adolescents, youth. Moving on to the prevalence of borderline personality disorder in substance use disorder. So as we all know, community prevalence of borderline is around 1 to 6% with marked female preponderance. All of us know that. When we look at BPDs in substance use disorder, this estimate goes up to around 12 to 35%. There are some studies which have even quoted more than 50% too. So prevalence of borderline personality disorder in patients with alcohol use disorder, this is what we see more often here, is around 12 to 17%. Here, compared to men, women with alcohol use disorder had a greater likelihood of BPD. Multiple substance uses obviously increase the risk of co-occurrence of BPD. Very few Indian studies. So, National Drug Use Survey saw that around 14.6% use alcohol and dependence is around 2.7%, and men had significantly higher rates than women. So 27% men and around 1% women. Looking at personality disorder and alcohol use disorder comorbidity, this was a study which was done again in southern India, and it was done only in men. So antisocial was the most common personality disorder that was seen, and actually borderline personality disorder was the least common. Okay, but there was a very small study that looked at only females diagnosed with alcohol use disorder. The sample size was very small, around 35. And the only personality disorder they diagnosed in this group of female patients with borderline personality disorder was borderline personality disorder. So that was the only personality disorder that they saw in females. Next, why do they co-occur? So there have been a lot of theories that have been put forth, right from it being a chance occurrence, it being overlap of diagnostic criteria. We know that in DSM-5, one of the diagnostic criteria is impulsivity, which they rate by substance use. So the overlap of diagnostic criteria or one disorder leading to the other, or both of them having the same etiology. So there are a lot of theories that have been put forth. 4 major co-occurrence models that have been discussed is predisposition or vulnerability model, the complication or the scar model, the exacerbation model, and the spectrum model. I'll speak about each of them. So first is the predisposition model. This is one of the well-studied one. So this says that the existing personality disorder leads to certain environmental responses, maybe interpersonal or occupational, which provoke the onset of substance use disorder. Again, they have described 3 pathways. One is the behavioral disinhibition pathway. Example, impulsivity, which increases the risk of substance use disorder. Stress reduction pathway, where self-medication to handle certain stressful life events. And the third one is the reward sensitivity pathway. So here, this we see more in dissocial or antisocial personality disorder, where high substance use because of high novelty seeking or reward seeking. There have been studies which have looked at impulsivity and negative emotionality, which is actually predicted the new onset of alcohol use disorder too. Next comes the complication model, or it's also called as SCAR. What they mean by this is that the substance use disorder related scars the personality. So we all know about neuroadaptation that happens in addiction. So due to excessive alcohol consumption across time, there is increased impulsivity, there is increased negative emotionality. So we know that as people become more dependent on alcohol, the negative reinforcement takes place. So withdrawal symptoms lead to negative emotions, and to cover up the negative emotions, they use more alcohol. So the cycle continues. So neuroticism increases as a person moves from pre-alcoholic stage to a actual clinical alcoholism stage. Chronic heavy drinking adolescents exhibited short-term increase in impulsive behavior. So this is just, of course, it's a very short-term follow-up study, but they found that as the adolescents used more alcohol, their impulsivity also increases. Next is the exacerbation model. BPD adds on to or modifies the substance use disorder profile of a patient. We all know this also because BPD does increase the chronicity of alcohol use disorder or any substance use disorder. It also increases the dysfunction or the impairment that is seen in a person's life. All these 3 we spoke of, we consider borderline and addiction as 2 different disorders. Whereas this model, the spectrum model, speaks about 2 disorders that share common etiology. Personality disorders and substance use disorders are not distinct, and they come up together mainly because of a set of common etiological factors. Genetics. Impulsivity is one of the heritable factors that is seen both in substance use and personality disorders. Traits like affective instability, impulsivity, they underlie the development of both of the disorders, and both BPD and SUD, we know that they have early adverse life experiences. Of course, I haven't gone in detail about the neuropsychological profile, the anatomical profile of both the disorders, but the research in that also does agree with this model of sharing common etiology. Next, so what if both of them co-occur? What happens? So, course and outcome. So, substance use disorder patients with BPD have an earlier onset of substance use problems. And now with now we can diagnose personality disorder even in adolescent age group, whereas earlier 18 was the cutoff. I think we'll see more and more research in this area also. So earlier onset of substance use problems, more severe problems, frequent relapses, very short abstinence periods, frequent hospital admission, more frequent use of other substances, and poor social functioning. Risk of self-harm and suicide also increases when both these disorders co-occur. This is something that we also see in our day-to-day practice. the therapeutic relationship, the problems that arise in the therapeutic relationship, which can lead to a lot of non-adherence issues, poor motivation to change, more frequent dropouts from the treatment, which can be both from the patient side or the client side, the physician side also. Rates of substance use and BPD patients over time start reducing. Rates of substance use in BPD patients, like in general population, the rates start reducing. Patients with BPD and comorbid substance use are less likely to remit. So the course of substance use disorder in patients with borderline comes down over time, like in any general population. But course of borderline personality disorder who have substance use disorder is going to be slightly poorer. So they are less likely to remit, show greater impulsivity, and have poor prognosis. This study, of course, has a contradictory study also. There was one study done pretty early in 2010, which looked at about 100 patients with, of course, all of them were females. They divided them into borderline personality disorder with alcohol use disorder, without alcohol use disorder, and control groups. So 3 groups were there, and when they followed them up, the presence of current or lifetime substance dependence was not associated with any escalation in their impulsivity or affect regulation. Similarly, the self-harming or the suicidal attempts, including any other externalizing behaviors, did not change, were not different in both the groups. And similarly, overall severity of the borderline personality symptoms also did not differ between people who had substance use and who did not have substance use. There are a few studies showing contradictory findings. One study that followed up patients with borderline personality who had substance use disorder. They followed them up. Actually, the one I have quoted is the 10-year follow-up. They have recently released the 24-year follow-up data also. So this showed that prevalence of substance use, any substance use or dependence, declined by around 84% after around 10 years follow-up. And of course, for both alcohol, drug use, for both of them it declined. Around 90% of them experienced remission. They described remission as at least 2 years period where they were completely off substances. So at least 90% of them experienced remissions during this 10-year follow-up. Around 40% of them had a recurrence, which again was similar to the data that was there in the general population. 24-year follow-up, also the results is almost similar. Remission is seen very often and recurrence is similar to the data that is seen in general population with alcohol use disorder. One more follow-up study, 18-year follow-up study which looked at smoking amongst borderline personality disorder. This is something that we are seeing very often in our day-to-day practice. So here, recovered by borderline patients had a significant decrease in the use. Similarly, rate of decline was faster in recovered borderline patients compared to non-recovered. And alcohol abuse was one of the factors which predicted that they may continue smoking. So multiple substance use increases the, worsens the prognosis. I think most of you will be more interested to know this, how to manage this co-occurrence. The answer after all this also is I still don't know. So assessment of personality disorder should always be done after the patient has been detoxified and he's out of his withdrawal symptoms. As much as possible, collect information from others who are, in close relationship to the patient also. Risk assessment is compulsory. Okay, especially for comorbidity, it is compulsory to do a good risk assessment. Lot of tools have been proposed. IPD is something which we have been using since quite a few years. Borderline symptom list, again, it's a self-reported scale. The next one has both the versions, the clinician-rated version and the self-reported version, and then screening instrument. There are quite a few other instruments also that have been used to diagnose borderline personality disorder. When you're seeing patients with borderline personality disorder, it is very important to ask them about any substance use. Most of them do have substance use, and quite a few of them may have multiple substance use also. So eliciting the history about that also becomes very important. So what is the recommendation? The general recommendation is psychotherapy. So that is the primary treatment. Pharmacotherapy is just an adjunct, and even then it is for a very short period of time. Again, treating both of them together is very important. You can't say that, I'm going to treat only the substance use disorder. I'll see later on, maybe I'll, think of targeting the borderline personality disorder. No, you have to address both of them. In severe withdrawal, you will have to take care of that first before you start speaking about the personality, but addressing both of them is very important. Polypharmacy should be avoided at any costs, and as much as possible avoid using unsafe drugs. Most literatures, what they have included as unsafe drug is benzodiazepine. Time in treatment, the more you can engage them in treatment, the more positive the outcome is going to be. Psychotherapy, I'm not going to be speaking in detail about it because we have other speakers who are going to come and cover about it. So 3 psychotherapies which have evidence in patients with this co-occurrence of borderline and substance use is, one is a version of DBT. We all know DBT. So along with that, it has been modified for people with comorbid substance use disorder. Dynamic deconstructive psychotherapy and dual focus schema therapy. So these are the 3 therapies which have evidence, of course it's just level 2 evidence, in comorbid borderline and substance use disorder. Psychoeducation about the diagnosis. So most of us, I think we do hesitate telling our patients that, this is the diagnosis that you have. Dr. Ruben and I were discussing about this also yesterday. So we are not very confident of, speaking about this diagnosis to the patient. But the literature says that psychoeducation about the diagnosis, the expected course, the risk factors and the treatment options does help in retaining the patient for long-term follow-up and of course in positive outcome. One more, GPM or General Psychiatric Management. So this is a very brief module which focuses on mainly psychoeducation, medications, and even how we can discuss about medication and comorbid disorders with the patients. And this has been found to improve the quality of life in a patient with borderline personality disorder. There are a lot of transdiagnostic approaches that have been spoken of: ACT, unified protocol therapy, mindfulness, integration therapy. So all these are more of transdiagnostic approach. I think we'll hear about this later more. Moving on to the pharmacotherapy. So substance use disorder, of course, needs both pharmacotherapy and psychotherapy. So pharmacological treatments of substance use disorder prevents relapse, to the same degree like how it would prevent relapse in a patient who has only alcohol use disorder. So again, management of substance use will not lead to remission of personality disorder. So treatment of alcohol use disorders, all of us know, anti-craving agents like acamprosate, naltrexone, off-label medications like topiramate, baclofen, so there are a lot of anti-craving agents that are used, and disulfiram, again, supervised is a better option. Similarly, opioid substitution therapy, nicotine replacement therapy, so all these have to be done in any patients with co-occurrence of both the disorders. Pharmacotherapy for borderline personality disorder, no medications have been approved till now. There are enough studies which show that medications do not change the outcomes, whether it is self-harm attempts or whether it is improvement in the social functioning or any of it. Most of the studies do not give any evidence for the same, but we do continue to use medications for treatment with for borderline personality disorders. Mood stabilizers and antipsychotics, more matching the specific symptom presentation, especially the affective lability. Naltrexone, found to be useful as anti-craving agent also. It's also known to reduce the impulsive behavior domain and thereby reducing the self-injurious thoughts. Again, if you ask me for, does it have robust evidence? No. Dr. Ruben requested me that, something about how to manage borderline personality disorder, pharmacological management. So this is something that is there in our psychiatry textbook, so I have put it up here. Again, this is more based on the symptom domain that we see more often. So emotional lability, mood stabilizers like lamotrigine, valproate, even low dose of antipsychotics do help. Aggression or even impulsivity, lithium can be used. SSRIs again has some evidence and contradictory evidences also. Anticonvulsants, not just valproate, even carbamazepine or even oxcarbazepine can be used. Lower dose of antipsychotics. In people who have more of anxiety, then yes, SSRIs, again low dose antipsychotics, valproate. Avoid benzodiazepine in patients who have anxiety. Buspirone probably is a better option. For people who present with sleep disturbances, that group of drugs are better choice rather than benzodiazepine. So again, avoid benzodiazepine. One reason is because of the disinhibition it causes. Again, comorbid substance use and benzodiazepine is not a good option. Risk of overdosing also is high. So all these are the reasons where everywhere it speaks of avoid benzodiazepines. For comorbid borderline personality and substance use disorder, the options, topiramate does reduce craving also, and also has been found to be slightly efficacious in decreasing the anger intensity in patients with borderline personality. Lamotrigine again has some evidence for craving and also for decreased impulsivity, anger, and aggression. Atypical antipsychotics, very low dose of aripiprazole or olanzapine, quetiapine, have been associated with impulsivity change, but alcohol-related outcomes are mixed. What is beneficial in patients with borderline personality disorder is what we call it as stepped care approach. So it's an adaptive approach, so you will have to evolve as the patient's need change over time. So it's a flexible treatment plan, can have intensive short-term in-person therapy like how we do it in crisis intervention, then maybe telephone-based care, medications if needed, and individual long-term therapy. So it has to be a multidisciplinary team that treats these patients. This has been found to be associated with positive outcomes, and of course the longer treatment engagement also. A few tips when we are treating patients with borderline personality disorder. Yes, we know that it can be demanding. You should not set your goals too high. There is no quick fix for non-suicidal self-injurious behaviors. Hospitalization most often may not be needed. Even if it is done, better be just a very brief IP care. Take the patient's experience seriously. Name the feelings that the patient has, at least what you think the patient has, before focusing on the facts. Avoid being provoked by the patient's disturbing behavior. This is something that we need to remember. Give regular time-limited appointments. Make exceptions only if there is any new onset of illness. Work with limit setting. Right in the beginning, set limits and stick to it. You will have to discuss with your, other team members regarding the treatment. Avoid polypharmacy. Set limits to histrionic and pushy behavior without judging the patient. I'm not very comfortable with this histrionic and pushy behavior because that itself is somehow judging the patient and their action. You need to remember that the patient always is responsible for their own action, except for the psychotic patients. Rest of them, you need to remember that they themselves are responsible. Do not reward disruptive behavior by giving increased attention. Then you will start setting a precedence with it. Manage them by offering regular appointments that do not depend on these disruptive behaviors. This is actually part of the, the guidelines that the IPS has set up for treating borderline personality disorders. There are a lot of newer modalities that have come up. Endoxifen, the magic drug, the wonder drug, which everyone speaks of, does seem to have some, reduction in impulsivity, emotional stabilizing effects. Again, we will need more research to say how effective it is going to be in patients with borderline personality disorders. Neuromodulation, again, a wonder treatment, magic treatment. So both TDCS and RTMS, there are studies that have been going on for both addiction and for borderline personality disorders also. Interestingly, TDCS, specific areas like left dorsolateral prefrontal cortex targets the emotional regulation, whereas right targets the impulsivity, and right ventrolateral prefrontal cortex targets the rejection sensitivity. So there are studies that are going on with these for borderline personality disorder. RTMS, we are also using this for substance use. We use this a lot for borderline personality disorder patients who have depression, and it has helped them. Psychedelic assisted psychotherapy, I'm not sure about this status of this in India, but this is something that is being spoken of in Western countries quite often. So this is about the treatment options for patients with co-occurring borderline personality and substance use disorder. Briefly about behavioral addiction, because I think we'll be seeing more of this in the future days. They are more likely to have problematic gambling or gambling disorder, 5 times more likely to have compulsive buying disorder, social media addiction, internet addiction. So the rates of these are all high in patients with borderline personality disorder. Management strategies, whatever I could find, again speaks of DBT only. Okay, so that is what they speak of. We may get to see more research in this area as we go ahead. Concluding, co-occurrence of borderline personality disorder and substance use disorder is common. There is no other way out of it. The reason for the same is not yet very well established. It's a long, waxing and waning course, but most of the follow-up studies have shown that the borderline personality disorder patients do remit over, I think 5-year follow-up rate was around 40% of them were recovered and around 60% of them had remitted. So that gives us hope that yes, things will settle down. Treating both the disorders is a must with combination of both pharmacological and psychotherapeutic methods. Transdiagnostic approach is something that we may have to focus in the future, looking at only impulsivity, looking at maybe only affective regulation. So this is something that we may have to look in the future. Thank you. I would like to thank Dr. Ruben and the organizing committee for giving me this opportunity to talk about this here. Thank you.
Thank you, Dr. Suma, for a profound, clinically rich and evidence-based presentation. May I now invite Dr. Chengannur to share his reflections and to lead the session.
A very good evening to all. First of all, I would like to thank the Department of Psychiatry, Cherian Hospital, Kallisheri, and the leadership of Dr. Ruben, and the whole team behind this thing to take up such a topic which is so relevant and often being neglected or being shunted away due to the very fact that, as Madam said, we are not sure about anything. And taking this topic and executing this thing at this level means it's a great thing. Congratulations to the whole team. And I'm proud and I am deeply honored to chair this session and to have chair with such an eminent speaker who told us about borderline personality. And as she rightly said, this is not like Crossroads, it's always like a parallel road. I just remember this thing as if anyone has visited Alleppey town, it's just like Alleppey town. You always have all these parallel roads and each and every road will have a intersection every few kilometers. And you will see the same person as you reach another 2 kilometers. It is the same thing with borderline personality disorders and substance use disorders. And as Madam told, it's often challenging for the family and the treating team, and this requires targeted and integrated care. And she has rightly pointed on the importance of non-pharmacological intervention and some of the major newer interventions, as she said. And I hope that you have thoroughly enjoyed and you have gained more knowledge about this personality disorder and the substance use disorders. And with that thing, this is open for discussion. Can I ask the audience if you have any doubts or any comments regarding this session, please.
The participants, now the floor is open for discussion. You can raise your questions. If you have any doubts, you can ask now.
മലയാളത്തിൽ ചോദിക്കാം, എല്ലാവരും രാവിലെ ഇരുന്ന് ഉറങ്ങിപ്പോയോ? Something that has to be discussed because, as I said, this topic is often neglected, and I hope that this kind of attendance is due to the fact that this topic is often neglected. Feel free to ask your queries or any suggestions, any experience sharing, please do ask.
So I'm going to. Hello. So I'm going to support my colleague here. We have so many prominent psychiatrists. We have so many. So if not questions, your opinions about the topic. I'm definitely going to make this a very interactive session. So I'm going to start calling names. So it's better if anyone is interested, they can, Manju madam, ഇങ്ങോട്ട് നോക്കുന്നില്ല ഞാൻ അങ്ങോട്ട് വരുവാ മാഡത്തിന് just a few words.
Good morning, everyone. I thought gaze avoidance would work. It didn't. Madam, it's a doubt, but not really what you had to present. How would you advise we manage the therapist or the psychiatrist frustration levels when we deal with these patients? I know it's not easy, as you said, and we have to take one patient at a time, but any practical pointers?
Hello.
I think one thing that you need to remember is set your goals low. Okay, so, most of the frustration comes from that.
Our expectations.
Yes. So set your goals low. Take each session as okay. He's come back to follow up once. Okay, take it as a positive, because the focus here is to keep them in the treatment loop. Let them be regular for follow-up. You should become a support where, when there is a distress, rather than opting to a self-injurious behavior, he should be feeling free enough to come to the hospital, tell them that, I'm in distress, I need help. Okay, so if they are able to come to that stage in itself, I think is an achievement. So focus should be on keeping them in the treatment setting. Very often what happens is we set our goals to, no, we need to change. We need to change this person. We should, he should, no, that is not going to happen. Okay, so I think setting your goals right would reduce a lot of the frustration that we have.
Thank you, ma'am.
Thank you, Dr. Manju. So now, is there anyone who would like to give their point of view? Otherwise, I'm going to call one more person and then we're going to go to the next session. Okay, so we had our senior consultant and now we're going to go for a student. We have with us our co-trainees from inMind Thrissur, Miriam. So, Miriam, it's your turn. You have to ask a question.
So thank you, ma'am, for that wonderful presentation. So in our hospital also, like you said, we try to find what kind of personality it is by doing a personality assessment. But one difficulty that we have found is that nobody likes to be diagnosed as a personality disorder. So most of the people, they try to manipulate the test. So is there some way in which we could get rid of this or handle the situation better?
I think the stigma in general is for all psychiatric disorders, so not just personality disorder. Probably, projective tests, of course, will not, manipulating a projective test like Rorschach is going to be very difficult. We have, assessments which can find out if they are, very favorable responses that they are giving. So we have such assessments also. But you can collect information from their close people also. You don't have to focus and collect information only from the patient. So that also helps. Okay, so collecting, if you look at IPD also, IPD is not just interviewing the patient. IPD can be done with their caregiver also. So that will probably help you collect more information.
Yeah. Thank you so much.
Thank you, Dr. Mariam. So we just got word that our Vice Chancellor is going to be a bit delayed, so I don't know if it's good news for all of you or not, but I'm going to be asking a few more questions and there'll be more people. But one thing that I can do is, me and Dr. Suma Uthappa, we were discussing yesterday about, what can we do? Like Madam asked, I was like, Madam, what are we going to do? So she's like, like she just said, the aim is to keep them in the treatment setting. So sometimes that involves us thinking differently. So there was a patient that I was discussing with her. She had taken treatments from multiple centers, just kept cutting herself. And her wrists and her hands were all just full of marks. So she came and the only thought that I had is, the first thing is that we have to do something different. If you're going to just repeat the same medicine, repeat the same discussions, she's already been psychoeducated about borderline personality. How much more are you going to tell her? She's come from 5 different hospitals. What are you going to tell her more? What I did is I just took a pen from my pocket and I told her, see, there's something called harm reduction. The next time you feel like hurting yourself, just take this pen which I'm giving you right now and use this. It will give you some pain, but you'll be safe. She's never cut herself again. I'm not saying it's because of my brilliance. I'm saying it just worked. But the idea is you have to also think differently. You're dealing with someone who is very vulnerable, there's a lot of emotions, and they're usually functional and functional as in they may be going for jobs, they're educated. You can't just keep giving them the same thing over and over again. You have to start, that's what I said, treatment goals, see who is in front of you rather than just following a guideline repeatedly. See what you can do, see how you can personalize this to the person in front of you, and keep trying and never give up. And keep your expectations to this much that they keep coming to you, they keep trusting you. They do not feel judged.
Just to add on to it, I think having a non-judgmental attitude becomes the most important thing. Quite a few of them do come back and, tell us that, you can make out that, they are labeling. And that is why like how she asked, most of them don't want that tag because they feel they are going to be judged because it's a personality. Okay, so I think that non-judgmental attitude when you're talking to them becomes very important. Listen to them and make them feel heard also, not just that you are listening to it. They also should realize that you are listening to them. So both becomes important.
Just one more thing. Just when Ruben told that he was using this pen, did anyone get any kind of analogy with your past experience with any kind of movie when he said about this pen? You have to be innovative, right? This very old Manichitradadi, the doctor's son, he was so innovative to treat all this dissociative things using those pujas and all. It's just like using that pujas to treat that dissociative thing. You have to think out of box to treat that impulsivity thing. Wonderful idea, Dr. Ruben, to share that with us. And frankly speaking, during the initial phases of my practice, I just used to shun this thing. Anything with a cluster B or emotional instability, if I got a little bit of hint means I'll just like, okay, fine, I'll just sit like anything and I'll just shun the patient to somewhere. And that was the thing. And over the years, I got some confidence. And this is how we practice. So that's it. So can we end this session? Can we end?
Yes, sir. We can end the session.
So thank you all. Thank you, madam.
Sorry. Okay. Yeah. Thank you, madam, for volunteering.
I have a client who's about 21 years of age, who's graduated and doing a post-graduation. Has done post-graduation in counseling. Now, I've been seeing her for the past 3 months or so, fairly regularly for once in a week. I wanted to ask you people about possible dependence on a therapist. There was a time that I was away for about 10 days and the client went away. I'm a psychiatric social worker by profession. I forgot to tell you that. And when I went away, the person did not come back to the hospital, not even to see the psychiatrist for 2 weeks or 3 weeks. And then when she came back, she told me that there was an suicidal attempt that she had made. serious one. Fortunately, a friend of hers with whom she engaged in. Now, this is one thing, I don't know whether all the patients do it. She engaged in conversation with her till she went to sleep because it is very difficult. They use a certain word. I forget the word, but you know, the friend keeps the phone on, this girl keeps the phone on, and they keep on conversing with each other till one of them goes to sleep. And they know that they have each other because this particular person did not have anybody to speak to. There are plenty of ACEs. There's loss of mother at 1.5 years of age. There is sexual abuse by a cousin, you know, all kinds of things like that. So when she came back to me, we continued, and again I was away for one week. The weekly session I was away. The next time I had her speaking to me was with the noose round her neck. This was about maybe 10 days back, with the noose around her neck, and she is hyperventilating and she isn't able to, you know, sort of, it took me about 40, fortunately I was free at that time because one client had dropped off, so I had the time, my phone was on. So over the phone for about 40 minutes I had to work with her just to tell her to breathe, you know, just breathe, you know, that kind of a thing. It went on. And in 40 minutes time, she was okay. And I did not want to ask her what had triggered it, but she was wanting to tell me about it. And I said, have you had breakfast? So she says, no, I've not eaten since yesterday. I said, I'd like you to eat something first before we talk. I'm willing to wait for you. She did not have any resources. Then I told her, can you get some, I told her to release the noose, which she did, and she had water to drink, and after that she wanted to tell me the story. Now, if you have seen people over a period of time, I'd like you people to tell me whether this could be dependence. You know, that's one thing. I have not discussed it with her, but I have dealt with the lack of resources problem because a father was giving her 2,000 rupees per month. He lives abroad, giving her 2,000 rupees per month to manage her life for a month. But otherwise very, you know, comes from a well-off family, etc. So what I've done right now is, she's very talented, exceptionally talented. Poetry, painting and stuff like that. So finding avenues for producing stuff, giving her materials and getting it sold. And journaling that he's speaking about, Dr. Ruben was speaking about, yes, that's something that she's doing, it's helping. There's another technique that I'm using with her, which I learned from my cosmic healing journey. It is to identify a predominant negative emotion in you. You know, it could be guilt, it could be self-hatred, it could be anything which is very, very painful for you. And this girl had great visualization capabilities. So it is like imagining a sea in front of you. There's a massive sea in front of you, and the sea is capable of absorbing any amount of nonsense that you put into it, the negativity that you put into it. It's not like a small, tub of water or whatever. So to imagine that you have a sea in front of you and identify one single emotion that is most disturbing for you and, scoop it out of your heart. You show them how you do it, just scoop it out of your heart and you pour it into the ocean. Let it all go. You take it out again. And this particular technique appears to be helping her a great deal. It's helping out my other people who are diagnosed with OCD also. So this is my sharing. And if you can comment a little bit on, if you have that experience of seeing somebody long-term on dependence and what it is that I can do to, slowly withdraw. But I think if I withdraw too soon, there can be more damage. And the fact that she's trusted when she was dying to call is, something that's, I look at as positive. She's living and she's smiling right now. Yeah. Thank you.
I mean, I don't know about the dependence part of it, but yeah, we see this quite often because we end up seeing, ours being a university town, we end up seeing a lot of students who are there till they finish their course and then they have to go back to their hometown. So when we have to terminate and, we have to refer them to someone else, that is where we see this problem. Most of them are not very comfortable going to a new person, starting the therapeutic relationship again, and they come back and tell us that, we are not comfortable. Is there any way you can see us online and, all this. But I don't know if we can call it dependence. I think it's more of a relationship that gets built up between, exactly. And of course, transference, countertransference are things that have been spoken of in patients with borderline personality disorder. Now, how to handle that is a big, so, thank you.
Thank you, Dr. Jayashankar and Dr. Suma. As a gesture of our appreciation, may I call upon our Chief Operating Officer, Dr. Rebecca John, to present mementos to Dr. Jayashankar ji and also Dr. Suma ji T. Udupa. Thank you, sir, and thank you, ma'ams. This concludes scientific session 1.
So as we are waiting for our Vice Chancellor and also we are setting the stage for the inaugural function, I'd like to take this opportunity to thank a lot of institutions that supported us and by coming today. For example, SB College, Chengannur, thank you all, students and faculty, for joining us for this session. KE College, Mananam, Giridipam College, Christujodi College, St. Thomas College, Koni, NSS College, Koni, Trada Kottayam, Assumption College, Chengannur. All these institutes have taken the pains to send their students for us to attend the session. I thank you so much to all the the leaders of these institutes, the people in charge for taking this seriously, for sending your students, for encouraging them to come and be a part of this session today. We also have students from Pushpari Medical College, Believers Medical College. Thank you so much. And Vidyadhiraja College, Karanagapalli. I thank you so much, these institutes as well, for sending their students. Also, we have like I said, we introduced Dr. Miriam, core trainee from inMind Thrissur. Also, again, please, when you go back, please tell your professors, thank you so much for sending you guys over. We also have Dr. Richa from BrainWorks Neuropsych. She's also a core trainee there. I think she's here. Okay. Thank you. And I will talk to Dr. Joby. I'll tell him thank you. So now we also like to appreciate our Reverend Fathers, our Reverend Sisters, psychologists, practicing psychologists, all my colleagues, psychiatrists, for coming here, for filling up this auditorium, validating all our efforts. Thank you so much. Now, just a few moments, we'll be inviting our the Vice Chancellor, Dr. Arvind Kumar of MG University. He'll be our chief guest today, and also Her Excellency Amina Shifan, who will also be joining us as our guest of honor.
जनगण मन अधिनायक जय
Dear all, here we begin our inaugural session. എല്ലാ പാർട്ടിസിപ്പൻസും ദയവേത് നിങ്ങൾക്ക് ക്രമീകരിച്ചിരിക്കുന്ന സീറ്റുകളിൽ വന്നിരിക്കണമെന്ന് പ്രത്യേകം ഓർപ്പിക്കുന്നു. നമ്മുടെ ഉദ്ഘാടന സമ്മേളനം ഇവിടെ ആരംഭിക്കാൻ പോവുകയാണ്.
May I request all participants to please be seated. We'll now begin our inaugural session.
Good morning to one and all. With immense joy and heartfelt gratitude, we welcome you to inPSYght 25, the National Seminar on Addiction and Borderline Personality Disorder, Crossroads. Today is more than an academic gathering. It is a collective commitment to healing, collaboration and strengthening mental health care in our communities. We are honored to have eminent psychiatrists, psychologists, clinicians, clergy, mental health professionals, students and advocates from across the country, all united by one purpose. We warmly welcome each one of you. Before we begin, let us seek divine guidance. May I invite the KMC choir to lead us in prayer.
സ്നേഹസ്വരൂപനാം നാദാ നീയല്ലാതാരാണാലംബം പാപങ്ങൾ പോക്കും കാരുണ്യമേ പാടി നിന്നെ വാഴ്ത്താം സ്നേഹസ്വരൂപനാം നാദാ നീയല്ലാതാരാണാലംബം പാപങ്ങൾ പോക്കും കാരുണ്യമേ പാടി നിന്നെ വാഴ്ത്താം.
Thank you. Please be seated. Thank you for the meaningful invocation. I now invite Dr. Ruben John, consultant psychiatrist, KMC Hospital, to deliver the welcome address.
On behalf of Dr. Cherian Institute of Medical Sciences and the organizing committee of inPSYght 25, it's my prestige and honor to welcome each and every one of you today to our inaugural ceremony. First, I'd like to welcome our chief guest, Honorable Vice Chancellor of MG University, Dr. C.T. Aravinda Kumar, Thank you, sir, for honoring us with your presence today. Sir is accompanied by syndicate member of Mahatma Gandhi University, Advocate P.V. Sadish. Thank you, sir, for joining us today. I would also like to welcome our guest of honor, Her Excellency Aminat Shifana, for accepting our invitation today. Her coming is a cementing of the relations between Cherian and the government of Maldives further, and our MOU for the treatment of drug addiction. Thank you, madam, for coming today. Next, I'd like to welcome our beloved Managing Director, Reverend Father Dr. Alexander Kodarathil, for gracing us with his presence and for his support to our department and his commitment to mental health. Thank you, sir, for your support, and thank you so much for coming here today, sir. I'd like to welcome my Guru and Professor, Dr. PSVN Sharma, for taking the time for traveling, for coming here today, sir. We welcome you. Dr. Verghese Punnus, Professor, Principal and Head of Department of Psychiatry of Government Medical College, Kottayam, has taken time off his busy schedule and teaching responsibilities to come here. I welcome you to this function, sir. I welcome my colleague, close friend, Deputy Medical Superintendent, Dr. Pooja Raghunath, to this program. Thank you for your support during this program. Next, I welcome my family, the speakers, all delegates and colleagues who have joined us in making this program a success today. I welcome all of you, and I hope you have a memorable experience. Thank you.
Thank you, Doctor, for your inspiring words and for setting a thoughtful tone for the seminar. With great respect, I invite Reverend Father Dr. Alexander Kodarathil, Managing Director, Department KMC Hospital, Chengannur, for the presidential address.
Good morning and greetings to everybody. Respected Vice Chancellor of Mahatma Gandhi University, Dr. C.T. Aravinda Kumar, His Excellency Aminat Shifana, Consul General, Consulate General of the Republic of Maldives, Thiruvananthapuram, Dr. PSVN Sharma, Consultant Psychiatrist, Kasturba Medical College, Manipal, Dr. Verghese Punnus, Principal of Government Medical College, Kottayam, Dr. Ruben John, our Consultant Psychiatrist, and Dr. Pooja Raghunath, our Deputy Medical Superintendent, and Advocate P.B. Sadish Kumar, Syndicate Member, Mahatma Gandhi University, and Mr. Koshi, Trada Administrator, and Reverend Fathers, Sisters, and all doctors, social workers, students, and the KMC staff. It is indeed a great pleasure for me to be here, and also I am very much happy for your participation and gathering. Dr. Cherian Institute of Medical Science is a multi-specialty hospital catering of all walks of life. Under the noble leadership of Sri P.M. Sebastian, UAE-based industrialist, he is the chairman of this institution and run by 15 members of board members. Around 13 departments and more than 100 consultants are working here under the full support guidance of 1,500 staff. Dr. N.V. Pilla is the professor of the Philadelphia Thomas Jefferson University, is the clinical advisor of our oncology center, and a center is under construction for 12 floors that will be completed next year itself. We have a de-addiction center here. Last 5 years running very well under the noble leadership of our clinical consultant psychiatrist Dr. Ruben John, and we also have clinical psychologists, family therapists, and family counselors. And every month we are conducting Alcoholic Anonymous meeting also. My keen interest in the hospital management, in addition to that, I am also serving as a counselor and therapist. Not only this center, last 30 years I was working in Perimala Center, and I started DAD Center there under the spiritual leadership of then His Holiness Basilius Marthoma II. And I took my training from Rada Institute of Social Science under the magnanimous principalship of Reverend Sister Dr. Jovan Chunkapara, and she will be here in the afternoon section as a chairperson. Alcoholism, as you know, substance abuse, is a social problem, is a disease, not only is a personal disease, but also a family disease, a social disease also, and coexists with the borderline personality. The struggle is much greater. Last 5 years, more than thousands of patients are taking treatment from here, and out of this, 50% of the patients are borderline personality disorder, and also 25% of the patients are coming for relapse cases. And follow-up, within 6 months, 60% of the patients are coming here. And within 1 year, 30% of patients are coming here. So we are in frequent touch with these patients. The presence of the Consulate General of Maldives here, very happy because last 2 years we are in collaboration with the Maldives, not only the clinical aspect because we are already started a clinical center in Maldives, and also in tie-up with the Maldives government, we are going to start de-addiction centers in Maldives because substance abuse is much greater in Maldives also. So it is our duty. This session, this national seminar, we have to find and express our thinking and our knowledge to evacuate this problem and bring these patients into the mainstream of our life. And our duty is like that because we are running a research and development department last 2 years. Our outcome is like that. Their social, genetic, and economical problem we are searching. The output is much greater because we have to bring them from this problem or struggle into the mainstream of our life. So I wish you all the best. May God bless you. Thank you very much.
Thank you, Father, for your visionary leadership and deep commitment to mental health and healing ministry. Let us now illuminate the spirit of knowledge and hope. May I request the Honorable Vice Chancellor, Dr. C.T. Aravinda Kumar, and all dignitaries on the dais to kindly come forward for the lighting of the lamp. Thank you, esteemed dignitaries. Please be seated. It is now our honor to welcome our chief guest, Dr. C.T. Aravindakumar, Vice Chancellor, Mahatma Gandhi University, Kerala, to deliver the inaugural address.
എല്ലാവർക്കും നമസ്കാരം. The President of the session, Reverend Father Dr. Alexander Kudarathil, esteemed Her Excellency Aminat Shifana, Dr. V.N. Sharma, Professor Varghese Spinoz, Dr. Pooja Raghunath, Dr. Robin John, other distinguished delegates, and my dear friends. On the outset, I thank the organizers for inviting me to be here in the morning to inaugurate this very important session. Now, this hospital bears the name of Dr. K.M. Cherian, the legendary medical figure credited with groundbreaking achievements in India's heart care history. This legacy helps inspire trust among patients and motivates younger medical professionals and students to aim for excellence. This institution stands as a symbol of advanced, compassionate medicine in this region. Now, for Kerala, especially Central Travancore, having a hospital like this is a major asset. It elevates healthcare standards locally, reduces urban-rural inequality in access to advanced medical care, and brings world-class treatments within reach. I applaud the service of this hospital to the people of Kerala and beyond. Now, medical science is a dynamic, ever-evolving field. What we know today may not hold true tomorrow. New diseases emerge, diagnostic tools advance, treatment protocols evolve, and research continuously reshape our understanding of the human body. In such a rapid changing landscape, learning cannot remain static. In such rapid field of science, and this is exactly where seminars prove invaluable, and this is what is happening today here in the morning. Now, addiction, coming to the subject, affects millions of individuals and families around the world. Addiction is about a struggle with pain, a struggle with emptiness, emotional storms, and a desperate search for relief. When we speak about borderline personality disorder, BPD, we are talking about a condition rooted in emotional vulnerability, trauma, and difficulty regulating intense feeling. What we understand, and at least what I read from the literature, that BPD is a condition of extremes. People with BPD feel emotions more intensely, more deeply, and for longer than others. Their relationship can feel like a roller coaster, filled with fear of abandonment on one hand and overwhelming attachment on the other. Their sense of self may shift rapidly. Everyday stress can feel like a breaking point. Addiction often becomes a coping mechanism. For some, substances or compulsive behaviors offer brief moments of relief, a sense of control, or a pause from emotional pain. But that relief is fragile and temporary, and the consequences can deepen feelings of shame, guilt, and self criticism, creating a painful cycle that is hard to escape. It's very important to remember that recovery is possible for addiction and BPD. To support individuals facing both addiction and BPD, we must replace stigma with understanding. Too often, people with BPD are labeled as difficult, manipulative, or beyond help. These labels are not only inaccurate, they are damaging as well. They discourage people from seeking treatment and deny them the compassion they deserve. Now, validation, skill building, consistent support are some of the protocols associated with healing process. People with BPD can build stable relationship, develop strong identities, and live fulfilling lives. People struggling with addiction can break free from dependence, regain control, and rediscover hope. When these challenges overlap, recovery may require time, effort, and compassionate care, but it is absolutely within reach. And to all of us, family members, friends, clinicians, educators, we have the power to change the narrative. Let us offer understanding instead of judgment, support instead of criticism, and hope instead of despair. When we choose compassion, we help rebuild life. When we choose education, we dismantle stigma. And when we choose to stand together, we make recovery possible. Now, wishing you all the very best for this national seminar. Make use of the opportunity. I request the delegates to interact vigorously with the experts. And finally, I declare that this seminar is open. Jai Hind. Thank you.
Thank you, sir, for your powerful visionary message and for inspiring our gathering. It is our privilege to welcome Her Excellency Ms. Aminat Shifana, Consul General of the Republic of Maldives in Tirunelveli, to address the gathering as guest of honor.
Thank you very much, Chief Guest Dr. C.T. Aravind Kumar, Vice Chancellor of Mahatma Gandhi, Father Alexander, dignitaries on the dais, senior management of KMC Hospital, ladies and gentlemen, a very good morning to you all. Let me begin by expressing my heartfelt gratitude to the KMC Hospital for the invitation to attend this important function. It is an honor to be here today at the National Seminar on Addiction and Borderline Personality Disorder. This seminar, organized by KMC Hospital, holds considerable significance as it addresses one of the most pressing global challenges of our time. It could not be timelier to hold such a seminar as the world, more specifically in South Asia, addiction and personality disorders signify growing public health challenges that strongly affect individuals, families, and communities. At the outset, allow me to highlight some key findings from the World Drug Report 2025, published by the United Nations Office on Drugs and Crime. According to the report, an estimated 64 million people suffer from drug use disorders. Among these individuals, only 1 in 18 women and 1 in 7 men receive treatment. It is universally acknowledged that drug use disorders impose a heavy burden on individuals, families, and communities. The WHO has reported that almost 1 billion people suffered from mental health disorders in 2019. Following the COVID-19 pandemic, rates of common mental health conditions increased by 25%, with substance use disorders being identified as one of the major contributing factors. Numerous barriers hinder the provision of effective treatment and care for drug use disorders. Chief among them is the very limited availability of evidence-based services. Many people with drug use disorders do not recognize their need for treatment, while others are reluctant to seek help due to the fear of discrimination. Many often remain misunderstood or stigmatized, leading to suffering in silence. Women often face additional and disproportionate barriers such as double stigma, societal expectations about their social roles and responsibilities, fear of legal sanctions, lack of childcare support, and fear of losing custody of their children while undergoing treatment. As countries continue to develop and societies become more complex, the need for comprehensive mental health strategies becomes increasingly urgent, critical, and important. KMC Hospital has established a Center for De-Addiction and Counseling staff with specialized psychiatrists, psychologists, and de-addiction experts to provide comprehensive, tailored care to patients, ensuring they receive the specialized support they require. I am pleased to acknowledge, as Father also mentioned, that in April this year, the Maldives National Drug Agency signed an MOU with KMC Hospital to establish drug rehabilitation centers across the Maldives. Similar to many other countries, Maldives also has a significant portion of its population struggling with drug addiction. We have seen how substance use issues can undermine the social fabric and hinder the potential of our youth. Similarly, many personality-related disorders require specialized, compassionate, and sustained care. Addressing these concerns is not only a clinical responsibility, but also a common imperative and a cornerstone of human development. It is our sincere hope that with the assistance from KMC Hospital, we will be able to provide access to effective treatments for those in need. One of the most important aspects of the seminar is that it aims to clarify the diagnostic framework, identify target areas for intervention, and emphasize a collaborative approach to treatment that involves not only patients but also their families. I applaud KMC Hospital and its dedicated team for fostering dialogue that transcends bond and discipline. Your commitment strengthens regional health partnerships and provide a platform to support our collective pursuit of resilient, healthier societies. I am confident that by the end of today's deliberations, all participants will have reached a shared understanding and consensus on how best to advance the objectives of this seminar. Let us think boldly, question openly, and collaborate meaningfully so that our shared insights can translate to productive solutions and brighter future for those who are in need. Let us keep working together with commitment, compassion, and determination to eliminate the scourge of addiction from our communities. While taking this opportunity to wish the seminar huge success, I also wish each of you the very best in your important work, and may your efforts bring everlasting positive changes to the lives of those you serve. I thank you.
Thank you, Your Excellency, for your gracious words and for reminding us of the value of international collaboration, friendship, and community care in mental health. With great honor, I invite Dr. P.S.V.N. Sharma, consultant psychiatrist and former professor at Kasturba Medical College, Manipal, to deliver the keynote address.
Presenters view. Oh. Correct. You didn't change it. Okay. Reverend Father Dr. Alexander Kudritil, Dr. C.T. Arvind Kumar, Her Excellency Amina Chifana, Professor Varghese Punnos, Dr. Pooja Raghunath, and Ruben. It's a great privilege to come to an institution that is named after such a great medical person as Dr. K.M. Cherian, the renowned surgeon who worked mostly in the railway hospital in Chennai and elsewhere also. And I thank the Department of Psychiatry and also the administration of this institution for giving me this opportunity to dwell briefly on the topic of addiction and borderline personality disorder at the Crossroads. Well, I'm stuck at the crossroads. It's battery. I'll do here. Oh, this doesn't work.
It's okay, sir.
Yeah. Now
Yes, we can just use this.
Yeah. Thank you, Ruben, for helping me move from the crossroads. Dr. Suma has already dealt to some extent with the problem, the clinical problem of borderline personality disorder co-occurring with substance use disorders, but it bears some sort of repetition. Mostly the Western population initially, or Western studies, talk about a 1 to 2% of general population having this combination, and roughly about 3% of adults have a borderline personality disorder. This is, of course, the most prevalent personality disorder that is being diagnosed today. And amongst non-clinical people, again, the percentage is about 3% of the general population, which probably suffers the condition of borderline personality. If you look at psychiatric inpatients in inpatient services abroad, 15% or 1/9 of the patients have, 1/6 of the patients have borderline personality disorder. And amongst outpatients, around 8% of psychiatric outpatients probably suffer from borderline personality. Overall, personality disorders, 51% of psychiatric outpatients with personality disorders have this diagnosis. That means roughly half of the personality disorder diagnosis is borderline personality disorder today. And interestingly, 75% of those diagnosed with borderline personality are women. There is, of course, some criticism about this in terms of how the diagnostic criteria seem to be skewed to picking up women, but that's a debate for another day. Roughly speaking, anywhere between 25 to 75% of people with borderline personality disorders have substance use disorders. When you look at alcohol use, anywhere between 28 to 63% of people with borderline personality have alcohol use disorders, so which is fairly common occurrence. And the highest occurrence with borderline personality is substance use disorder. That's followed by anxiety and depression disorders. Then co-occurrence with other personality disorders, and then of course other psychiatric diagnoses. This combination of borderline personality and substance use contributes to substantial levels of impairment in the individual. There are high levels, as mentioned by Dr. Suma, of self-harm, and most importantly for any hospital healthcare service utilization. if you look at Indian studies, there are a few studies. One study looked at university students. Around 22% of students in an online survey fulfilled the criteria of borderline personality. And this study also showed that there is a waxing and waning course, which we know is documented in the literature. Another Indian study talked about personality disorders in the population as 10 to 15%, of which the majority are firstly borderline and secondly dissocial or antisocial personality. And another study from India suggests that anywhere between 35 to 70% or 73% of people with personality disorders have substance use disorders. And as I said earlier on, most of those personality disorder diagnoses are borderline. So the inference is that, as in the Western data, there is high levels of substance use disorders amongst Indian borderline personality disordered individuals. And the rates of drug use disorders is higher than alcohol use disorders in Indian studies. Now, there are other addictive disorders in borderline personality disorder. There is internet addiction, which is fairly common. There is social media addiction. There is a compulsive buying disorder, and there is also other addictions. This compulsive buying disorder occurs in roughly a quarter of those who suffer with borderline personality. The contingent self-esteem is highly predictive of compulsive buying in borderline personality, especially in women. The question of addictive personality also comes in, because some people believe in this concept that there is a personality itself which is prone to addiction. This is perhaps a myth. We have no definition, no vulnerability data, and addicts may be addicted to different classes of substances, and reciprocal addiction is also known. So addictive personality is probably a bit of a stretch. Now, why do borderline personality and substance use disorders commonly co-occur? Dr. Suma also spent some time on this. The first thing is that the core features of BPD are risk factors for substance use also. For example, as mentioned, impulsivity, affective dysregulation, childhood trauma leading to poor attachment, that leading to borderline personality, and that leading to substance use disorder. Then alcohol use disorders occur in about 41% in all personality disorders, with 12-month prevalence of 51% in borderline personality. Drug use disorders occur in 38% in all personality disorders, but the 12-month prevalence of 15% in borderline personality disorder. So, is there a causal linkage between substance use and borderline personality? There is a primary substance use model which says that the substance use contributes to the borderline personality. There is a behavioral disinhibition pathway, which Dr. Suma also talked about. The pathway leads to lower threshold for substance use disorder in borderline via traits such as dissociality, impulsiveness, thrill seeking, low constraint on conscientiousness, and so on. So there is a lower threshold for both substance use and borderline. Then there is the stress reduction or the self-medication pathway, where people self-medicate to relieve their anxiety and depression, and those features are quite high in a borderline individual. Then there's the reward sensitivity pathway, where the pathway works through the positive reinforcing properties of substance use as motivating factor for borderline personality. And finally, there is the common factor model, which suggests that BPD and substance use disorders have a common cause because they share certain characteristics. Now, the question of co-occurrence and comorbidity is especially relevant for students and for practicing psychiatrists. Co-occurrence of borderline personality disorder and substance use disorder is where the two syndromes exist together at the same time without an etiological association. whereas comorbidity is when there is co-occurrence and covariance of the two syndromes at the same time, suggesting a link. True comorbidity is difficult to establish due to our limited understanding of the etiology of both these conditions. Next is the question of dimensionality and borderline personality and substance use disorders. We have talked in classification about categories and dimensions for a long time, but it has really entered into a classification of late. So borderline personality and substance use are often referred to as categories. However, they show evidence of dimensionality. So you can have a borderline personality where certain traits are more present or less present. That is a dimension. You can have substance use which can be different in different individuals in terms of extent. That is again a dimension. The maladaptive variants of general personality traits such as high neuroticism, antagonism and disinhibition arising from the 5-factor model of personality provides the strength or provides the emphasis on the dimensionality coming into play in both borderline and substance use disorder. The current trend is towards dimensional understanding of personality traits. If you look at the DSM-5 additional information or you look at the ICD-11, we find traits have been clustered into groups. So you have a negative affectivity, detachment, disinhibition, dissociality, and anancastia. Each of these are dimensions. Now when you look at these dimensions with reference to borderline or with reference to substance use disorder, you find that the relationships that can be established with them are much stronger than with individual personality traits that we were talking about as personality disorders till now. Managing borderline personality with substance use disorders, there are of course higher levels of substance use which predicate greater psychosocial, psychopathological, physical impairment and suicidality and poorer outcomes with people who have borderline personality disorder. Negative attitudes of the healthcare workers can lead to a fracture in the doctor-patient relationship and so poorer outcomes. In primary care, what you need to do is look after anxiety, depression, suicidality, physical effects of substance use, crisis intervention, psychoeducation, and referral to somebody who has experience in handling this combination. In the secondary and tertiary levels, we find that it's extremely important that the central role of the therapeutic relationship should be understood. This is what there was a discussion about in the previous session. There should be a highlighting of the potential for change and for hope. There should be flexibility while maintaining boundaries. That means you need to maintain boundaries, but then also be sensitive to the way the client interprets your boundary keeping. Empathy, compassion, curiosity, collaboration, respect, openness, all of this should be there as in any other therapy, because there's a tendency when we deal with people with personality disorders to reduce the levels of empathy, compassion, etc., basically because we feel uncomfortable with them. Education of the patient and of the supporting individuals regarding the condition is a must. Give the condition a name and talk about what it constitutes. One should be always able to recognize negative transference when it is occurring. It's important because it determines the course of the treatment. Focus on underlying needs of the patient. Contracting the treatment is very important. And remember that it is long-term therapy, and often there has to be availability of care 24/7, especially when there is a frustration, there is an impulsive attempt or any such crisis. And co-occurring disorders will be there almost invariably, and we need to be able to address them, whether they are depression, anxiety, and so on. Furthermore, we need to acknowledge the patient's feelings. Just because the patient says, one day he says that I'm feeling sad, the other day he says I'm feeling angry, does not mean that he does not feel them. So we need to acknowledge that. Tolerating appropriate behaviors is a must. Discouraging inappropriate behaviors is also necessary. and maintain therapeutic neutrality throughout the course of the therapy. As Dr. Suma was mentioning, medicine should be prescribed with caution, especially those medicines which can be abused or which can be used for suicidal attempts. There should be a regular scheduling of appointments. Again, this came up in the discussion that followed in the last session. There should always be crisis management plans where your team should be aware of what the plan is and the patient also should be aware of what the plan is. And communication should exist between all service providers. So the nurse who is going to be managing the condition, the doctor, the junior resident, everybody should be in the picture in terms of how the therapy will go on and how crises will be attended to. Peer support of the therapist is a must, and this is the thing which will determine really whether the therapy is successful or not and whether the therapist will take such patients up in future or not. Finally, in conclusion, identification of the cause-effect relationships of borderline personality and addictive disorders can be difficult. Co-occurrence of borderline personality and substance use disorder is common, needing vigorous long-term treatment. And the reasons for occurrence of dual disorders may be many and will have to be found out in the given case. Treatment may be long drawn out with ups and downs, and the doctor should be, or the psychologist should be prepared to face those ups and downs. Psychotherapeutic skills are as important as somatic treatment skills. I would say that they are more important than the somatic treatment skills. Effective treatment can reduce impairment and improve quality of life in most, if not all, people. Thank you for a patient hearing.
Thank you, Dr. Sharma, for your scholarly and deeply moving address. As a mark of our profound respect and affection, grounded in Kerala's rich tradition of hospitality, we now have the privilege of honoring Dr. PSVN Sharma. Sir, may I humbly invite you to kindly come forward to receive this honor. May I respectfully invite Reverend Father Dr. Alexander Kodarathil to kindly come forward and present the Ponnada to Dr. Sharma. Thank you, Reverend Father and Dr. Sharma. This traditional honor reflects our deep appreciation for Dr. Sharma's lifelong contributions to psychiatry and medical education. May I now invite Professor Dr. Varghese P. Punnus, Principal and HOD, Department of Psychiatry, Government Medical College, Kottayam, to offer the felicitation.
Good morning, President of the meeting, Reverend Father Dr. Alexander Kodarathil, Chief Guest of the Day, Professor C.T. Arvind Kumar, Vice Chancellor, Mahatma Gandhi University, Her Excellency Aminath Shafana, Consul General of the Republic of Maldives, other dignitaries on the dais, dear colleagues and friends. I am extremely happy that I am in KMC again. KMC, I was just telling Sharma sir that KMC here is Cherian Hospital. For me, it is Kottayam Medical College, and for Sharma sir, it is Kasturba Medical College. So all the KMC confluence is here. So that is something, a coincidence which I noticed, which I was sharing with Professor Sharma sir. See, this year, one of the things which really made me really interested in this CME was the topic of selecting personality disorder, borderline personality disorder, as one of the, or perhaps the major focus of discussion. Dr. Sister Joan Chungapara is here. Just a couple of months ago, this Mental Health Day, again I was speaking in the Catholic Mental Health conference, National Catholic Mentor on personality disorders. So this particular area, which has been by and large neglected in academic discussions, is slowly coming to focus. And there it was the entire the spectrum of personality disorder, and now it is focused to borderline personality disorder. Regarding the subject, I will speak when the time comes, but this kind of personality disorders, though they may come to a clinical attention only when there is a self-harm or when it is presenting with substance use, but how it affects the lives of the persons and how it affects the lives of the persons who are living with them. We are just talking in the sidelines, like the effect on the marital lives, the effect on the professional lives, the effect on the functioning in whichever areas we are functioning. So very unrecognized area which usually falls in the blind spot of our mental health profession. So these effects should definitely loaded. Another thing which, again, when we want to focus beyond the core psychiatric disorders like schizophrenia, bipolar disorder, you look at the UN Sustainable Developmental Goals. The Sustainable Developmental Goals, goal number 3, which is aimed for the year 2030, one is the wellness. The good health and well-being is one of the important criteria. Our own Niti Aayog, the planning body of Government of India, is giving a lot of focus on this concept of good health and well-being rather than focusing on morbidity alone. So the personality disorders are rightly placed to address this UN Sustainable Developmental Goals as India is progressing towards in the group from an underdeveloped country to a developing country to the set of developing nations. So out of the 17 Sustainable Developmental Goals, 4 or 5, if not more, are associated with mental health. Even in a hospital, Cherian Hospital, which is one of the pioneering hospitals in Kerala, look at the population it serves. Central Travancore, for many reasons, the health parameters are compared to the Western statistics, sometimes even better than the developing country statistics. But the paradox of the Kerala's mental health achievements lie in the area of mental health, whether it is suicidal rates or whether it is divorce rates or any parameter concerned to mental health. When that is compared to the parameters in the general health, there is a huge contrast. So that is because we are not addressing the mental health issues properly, and being a general hospital with multiple specialties and super specialties, so ingraining the mental health services, psychiatry, psychology, social work, all these things together in a hospital. Mental health problem seldom comes as a pure psychiatric problem. Most often it comes to the gastroenterologist as a functional bowel disorder. It comes to the rheumatologist as a fibromyalgia. So all these problems should be addressed. And again, happy that this audience is not comprised only of psychiatrists and psychologists. A lot of students of psychology and social work are here. I extend all my felicitations to this great initiative and appreciate it. Particularly thank you, Father Alexander, Father Bibin, and Dr. Ruben for inviting me and involving the medical college also in this function. Thank you very much.
Thank you, sir, for your valuable words. To conclude the inaugural session, may I invite Dr. Pooja Rikunath, Deputy Medical Superintendent and Consultant Microbiologist, KMC Hospital, to deliver the vote of thanks.
A very warm good morning to one and all. On behalf of Dr. K.M. Cherian Institute of Medical Sciences and the organizing committee of inPSYght 25, it is my privilege to propose the vote of thanks for today's inaugural ceremony. First and foremost, we express our heartfelt gratitude to our chief guest, Dr. C.T. Arvind Kumar, Honorable Vice Chancellor of Mahatma Gandhi University, for lighting the lamp and inspiring us with the inaugural address. that sets the tone for a day of meaningful learning and reflection. Sir, your presence has truly elevated this CME. We are deeply honored by the presence of our guest of honor, Her Excellency Aminat Shifana, Consulate General of the Republic of Maldives, Thiruvananthapuram. Thank you, Your Excellency, for joining us today and for your encouraging words that remind us of the broader global and humanistic context of mental health. Our sincere thanks to Reverend Father Dr. Alexander Kudarathalachan, our respected Managing Director, for delivering the presidential address. Father, your steadfast support and vision continue to strengthen every academic endeavor of this institution. I would also like to thank Dr. Ruben John, consultant psychiatrist and the organizing lead, for the warm and thoughtful welcome address that opened today's event with clarity and purpose. A special note of appreciation to our keynote speaker, Dr. P.S. V.N. Sharma, consultant psychiatrist and former professor of Kasturba Medical College, Manipal, for delivering an insightful and thought-provoking keynote. Sir, your experience and clarity truly enrich the CME. We also thank Professor Dr. Varghese P. Punus, Principal and Head of Department, Psychiatry, Government Medical College Hospital, Kottayam, for his gracious felicitation and for honoring this occasion with his presence. I would also like to thank Dr. Givarghese K. Matthew, our Medical Superintendent and Cardiothoracic and Vascular Surgeon. He could not be with us today as he had to attend to an emergency surgery. Thank you, sir, for your continued support in all our academic activities. As we look forward to the enriching sessions ahead, I would also like to place on record our sincere appreciation to all the resource persons who will be sharing their expertise throughout the day. Your willingness to contribute your time, knowledge, and clinical insights forms the backbone of the CME, and we are deeply grateful. A warm note of appreciation is also due to the organizing committee, faculty, administrative and technical teams whose collective efforts have made today's event possible. Finally, to every participant, thank you for taking the time to join us. Your enthusiasm and commitment to learning strengthens the spirit of inPSYght 25. And we invite all of you to remain with us for what promises to be an enriching academic experience for the rest of the day. Thank you all once again.
Thank you, Madam, for your gracious vote of thanks. May I request everyone to kindly stand for the national anthem. Thank you. Please be seated. With this, we officially conclude the inaugural session of inPSYght 25. Please proceed for refreshment before we begin the next academic session. All participants are kindly requested to proceed for refreshment, which is being served in the tents arranged right in front of this venue. You may use this space at your convenience.
അങ്ങനുണ്ടോ?
May I kindly request all participants to please be seated. We will now begin our next session. We will commence our next session shortly. May I kindly request all participants to please be seated. We will commence our next session shortly. May I kindly request all participants to please be seated. Dear all, here we begin our scientific session 2. May I respectfully invite the chairperson, Dr. PSVN Sharma, and the speaker, Professor Dr. Varghese P. Punnus, to kindly come forward to the stage. Dr. PSVN Sharma is a distinguished consultant psychiatrist and former professor at Kasturba Medical College, Manipal. His academic journey, clinical depth, and mentorship over decades have shaped the careers of many psychiatrists across India, including our own HOD, Dr. Ruben. With his wealth of experience in medical education, psychiatric research, clinical care, and ethical practice, he continues to be a pillar of excellence and a guiding light in modern psychiatry. Sir, we warmly welcome you. Professor Dr. Varghese P. Punnus is Principal and Head of the Department of Psychiatry at the Government Medical College, Kottayam, a leading academic institution in Kerala. With decades of clinical practice, teaching, and mental health advocacy, he has significantly contributed to psychiatric training, research, therapeutic clarity, and public mental health policy in our state. His academic leadership and compassionate clinical approach inspire confidence and hope. Sir, we warmly welcome you. Sir, you may kindly begin your presentation.
Good afternoon, I should say, because it's 5 minutes past 12. I am reminded of sitting an experience maybe 30 years ago, sitting in front of Professor Sharma sir for the MD examination. I'm reliving that experiences way back in 1996. In Calicut Medical College. So I became a bit nervous, but probably sensing that today morning we had some conversation and that put me at relatively at ease. Anyway, the examination was a great experience for me, great learning experience as well. The topic has already been exposed, the borderline personality disorder, in a very beautiful manner by Professor Suma. And now in this presentation I will be focusing mostly on the self-injurious behavior which characterizes borderline personality disorder. So before that, since I came to know from Dr. Ruben that many students are attending in psychology and social work. So this simple mental exercise, read it. Imagine that you are a lay person carefully reading criteria from DSM-5 on various types of personality disorder. Try to visualize the person whose characteristics are described in criteria laid down for each PD. Obviously the answer is, I think it should be borderline personality disorder. Because we know that in other criteria, if you go by the criteria approach, not the dimensional approach to which Professor Sharma alluded in his talk. Even with dimensional approach, if you look at the criteria for antisocial personality disorder or narcissistic personality disorder, anancastic, whatever, you get the picture. The picture is very clear. But when it comes to the visualization of borderline personality disorder, for example, when you see a criteria like the first one, frantic efforts to avoid real or imagined abandonment, nobody is going to come with such kind of a complaint. So it might be with a life experience which might reflect this particular problem. So rather than the descriptive approach apart from the descriptive approach in DSM or ICD, starting from DSM-3 onwards or ICD-9 onwards, this particular problem of borderline personality disorder is slightly different. Again, you look at the criteria number 7 or criteria number 3, identity disturbances, markedly and persistently unstable self-image. Very unlikely, unless somebody, the Gen Z people reading about borderline personality disorder, they make the self-diagnosis and comes and tell you that I have a problem with my identity, self-image, etc. Otherwise, it is something which you have to presume from the clinical presentation, like chronic feeling of emptiness, etc. So out of this 9 criteria, criteria number 5 stands out as something which is very visible and something which is very tangible, that recurrent suicidal behavior, self-mutilating behavior. So this is a hospital setting, a general hospital setting where patient might come with self-inflicted wounds, and that is a pass to consider, or that is one of the red flags to consider the diagnosis of borderline personality disorder. Just like Dr. Suma was mentioning, addictions and self-injurious behavior are the most visible reasons or the presenting complaints where we finally reach the diagnosis of borderline personality disorder. To look at the basics, what is the borderline in BPD? Maybe students, if you are okay, you can even respond. What is borderline? See, the terminology borderline is very confusing. When we talk about intellectual disability, the borderline is different. So people are confused. So it has got its roots in the psychoanalytic thinking, referring to something in the border of neurosis and psychosis, to bring in some old terms. So there is a fragmented sense of identity from the psychoanalytic terms, and the reliance on primitive defense mechanisms like splitting, we will come to that later, and the difficulty in regulating emotions which become more descriptive. The first 3 ones are mostly, maybe the first 2 ones are mostly psychoanalytical. So difficulty regulating emotions and difficulties in managing sexual and aggressive expressions. And altogether, you get a feeling that the person is in the border between neurosis and psychosis with an intact reality testing, but which is very fragile. So this is where others like Hock and Platin, the famous description of the pseudoneurotic schizophrenia in 1940s. So that is about the history, and again the object relationships theory is a theoretical premises from where the concept of borderline personality organization was developed. That means the early emotional relationships. So they are represented as objects in the developing mind. So these early object relationships, their stability determines the adult emotional expressions and relationships. That may be somewhat simplification of the object relationships theory, but this internal incoherence of not having a permanent or a stable object relationships is the theoretical premises which lead to emotional dysregulation, which makes a patient's emotional reactions very intense, unpredictable, and difficult to manage. So just to give this theoretical premises is important because, especially for the people who are in training, remember it is important to understand that how these concepts emerge. The trio of the object relationships theory, we can identify Melanie Klein, Winnicott, and Kernberg. So now the primitive defenses, I made a reference to the primitive defenses in action. Mostly the most familiar defense mechanisms, the splitting, the projective identification, primitive idealization, devaluation, and denial. So if you look at the criteria, or if you look at the conceptual description of borderline personality disorder, you can see the reflections of these kind of defense mechanisms. And this results in a dissociation of emotions from cognitions. And this results in the excessive use of these primitive defenses hinder successful cognitive processing and lead to behavioral manifestations which are characteristics of the person with borderline personality organization. So having made some references to this basic theoretical concepts, now we look at the core features of BPD. My topic given is to speak on the self-injurious behavior, but I thought that would be comfortable if we just have a glimpse at the historical origin and the conceptual clarity on what constitutes BPD. So these core features: emotional difficulty with emotional regulation, impulse control, interpersonal relationship, and self-image, and the 9 criteria which are given by the DSM, and similarly the borderline pattern which is described in ICD-11. So we are all familiar with this. And out of this, as I mentioned a couple of minutes ago, the standing out phenomena which can be easily picked up, especially when you are working in a clinical setting, is the self-inflicted harm. Self-inflicted harm. So that is very visible. So whenever we come across, we start thinking about that, triggers the thoughts about possibly we are dealing with a person with borderline traits. So the trainees are here. Your professor or your supervisor will definitely ask you the question whenever somebody presents with a self-inflicted harm. Did she really wish to die? So what is the intent? So this is one question which is always a problem when we assess a person with deliberate self-harm, the so-called self-harm. The supervisor is always worried whether the candidate really assesses the intent. Even though we try to put intent as plus or minus, present or absence, all of us who practice in clinical scenario, we know that it is not a null or none phenomena. It is a continuous distribution with a coexistence of suicidal and non-suicidal motivation, and there is no clear-cut dichotomy. And this is particularly true with patients with self-injury in case of a person with a borderline personality organization. And before we get into the proper thing, again, certain terminologies again become confusing. And these changes in terminology reflect some of the changing concepts as well. For example, the attempted suicide, the term use of terminology changes to parasuicide, and then deliberate self-harm. Deliberate self-harm was the preferred term till recently, and then self-harm, less theoretical or theoretically neutral descriptions like self-injury, and now the evolution of the phrase non-suicidal self-injury, which is abbreviated as the NSSI. So we know on the remarks side you can see that why attempted suicide is not that favored, because many people who do self-harm do not wish to die. Their real wish to die or intent to die is not very clear. Even parasuicide, which refers to deliberate acts of self-harm which mimics suicide but not resulting in fatal outcome. Again, the implication, the suicide word can be slightly confusing. The prefix deliberate in deliberate self-harm is again judgmental, so it's not preferred. And self-harm, self-injury, the advantages are these terms can be used, as I said, in a neutral fashion, irrespective of any implication or any indication on the motivation. So, the very basic question, why should one hurt oneself? That too repetitively, when the intention or the motivation is not there consistently. So, there should be an explanation. It usually defies the normal logic. Why somebody should do that, unless there is a wish to die. So, there are many explanations. A very simple explanation is physical pain may be helpful to remove unbearable emotional pain. So the physical pain caused by self-injury can take away or dilute or diffuse the negative emotions which the person might be feeling, so resulting in a sense of relief or calm. So when emotional pain becomes overwhelming, the self-injury can provide a way to experience physical pain which is more tangible and easier to handle. So that is a very understandable explanation why someone should resort to inflicting physical pain to deal with a more severe or unbearable emotional pain. So if you have experience with the persons who are doing that, most of them, if allowed to speak, they will describe a sensation of a release of pressure or a momentary escape from the unbearable emotional pain. So what happens because of this relief they experience, it can, if you apply the behavioral principles, any behavior which can relieve distress or pain can become reinforcing, and that can serve to the repetition of the act. So that is one explanation. And to put the same thing, almost similar, to put it in another catchy phrase, externalization of the internal pain. Many patients with borderline personality disorder, they describe their emotional experience as a numb one, a numbing of emotional experiences. So to feel live or alive, something has to be done. So in order to escape from the feeling of feeling numb, a person engages in self-harm, inflicting pain. So self-injury becomes an acceptable way to feel the pain which they are not allowed to feel emotionally. And a controllable entity versus an uncontrollable emotional pain, which may probably have its root in past sexual abuse or sexual neglect. So look at this particular picture, how a deliberate self-harm which results in temporary relief can happen. An emotional trigger, a high emotional intensity, and in a person with a borderline personality organization, resulting in self-harm. So in order to make sense out of a situation which is very difficult to understand, we can make postulations like this. The purpose and meaning of a self-injury without a suicidal intent the purpose can be understood as a coping mechanisms to deal with the intense fear of abandonment, rejection, and shame. So very at the core of borderline personality organization, this fear of abandonment, fear of rejection from a relationship, and the shame they experience. So a coping mechanism, the self-injurious behavior may emerge as a coping mechanism, and this may even help to distract a person from problems which are ongoing problems, apart from the impact of a triggering factor, ongoing issues in relationship problems, financial troubles, work environment. So this becomes a pattern of behavior which may help a person to distract, and this particular self-injurious behavior can become a part of the clinical expressions of a person with borderline personality disorder. And we, many a time, a very judgmental approach to, especially from people who are not that adequately trained in psychiatry, when people with borderline personality attend a medical or surgical emergency department, a lot of derogatory comments or comments with prejudices like it is a manipulative act, or it could be a desperate attempt to draw attention, etc. So it could be an attempt to draw the concern from others, the usual cry for help which we mentioned. And in fact, this could be an attempt to regain control or cope with feelings of powerlessness, defeat, and entrapment. So the non-suicidal self-injury can reflect the problems with affect regulation, interpersonal communication, could be a coping against dissociation. It could serve us as punishment, self-punishment, etc. So this, what we need to understand, that it need not be necessarily manipulative. So in the previous session, during the discussion, that issue was brought up, and there were some discussions also. So we, even with psychiatric training, we tend to develop a lot of negative counter transferences when our own clients, or maybe when we deal with patients who repeatedly present with self-harm. And we have to deal with the surgeon or the physician who is dealing with the self-injury. So this has to be tackled. So the message we may need to transmit to others is that the struggles are real, and support should come with understanding and not shame. So very important. Otherwise, a lot of discriminations can happen. The intra-institutional discrimination, I am talking from a general hospital psychiatric practice point of view. People who present with self-injury often may get a delayed treatment. Some kind of subtle discriminations are very likely to be there. So we need to reassure ourselves. We need to convince our colleagues also that all these kind of self-injurious behavior need not be manipulative always. It could be resulting from psychological factors which are genuine and real. So self-harm behavior in borderline personality disorder, the NSSI statistics widely vary. That's why I did not quote any particular reference, but this is some total of different statistics drawn from different articles, literature. Professor Sharma, he has shown some very interesting literature about BPD in general, and look at this statistics is particularly pertaining to the NSSI aspect. 17% of the adolescents and 6% of adults in general population. That is the NSSI prevalence in general population. And when it compared to the borderline personality disorder, it is as high as 95 or something in the 90-95 range. And even the non-suicidal self-injury, the word itself, the phrase itself is non-suicidal. Death by suicide also is definitely higher. 52-fold higher death rates. So when the statistics also teaches us that an early detection of individuals at the risk of developing BPD is the self-harm behavior. I was having some chat with Sister Dr. Joanne Chungapara. She was also mentioning that when these kind of problems come up early in life, especially in children or adolescents, this should be taken as warning signs that could be the harbinger of an evolving borderline personality disorder. So the etiopathogenic tripartite model, is it always resulting from childhood trauma? In the social media, always childhood trauma is blamed as the single and the main factor for the emergence of borderline person. But we should realize that it is one of the important components of this tripartite, the three T's: childhood trauma, the vulnerable temperament or the personality, and the triggering factors. So these three T's operate together to form the behavioral pattern of what characterizes borderline personality disorder. And also the role of epigenetic factors are important. This particular article I found very interesting. That is the reason why I am mentioning the neurobiology of suicide, where the role of epigenetic factors are very important. There's a lot of discussion why non-suicidal injuries are really on the rise. So there are biological underpinnings, genetics, mostly related to the serotonin regulation, stress response and emotional progression, the neurotransmission, which involves at least three major systems: serotonin, dopaminergic and opioid systems, which may have an implication on the pharmacological when we discuss the pharmacological management of self-harm, the endorphins and the pain perceptions, the HPA axis dysfunction and the elevated cortisol response in response to stressors, and the brain structural and functional impairment, which mostly the areas of interest identified, the amygdala, the prefrontal cortex, and the anterocingulate gyrus. So these are the key areas involved in emotional regulation and control. So I don't want to dwell deeper into, but remember that these biological factors at the genetic level, at the chemical level, at the neurotransmission level and endorphin level, and the neuroendocrine level, the HPA dysfunction, and also at the brain structural and functional brain imaging, how short the biological factors are very important. So it is not the childhood trauma alone. It is the vulnerability, the biological vulnerability, which gets reflected in the temperament, and also the problems like impulse control, emotional dysregulation. All these are having definite biological impairment. So the typical clinical scenario where the young person, who is more frequently a female, presenting with self-inflicted wrist cuts. The context is very familiar, very stormy interpersonal relationship problems, breakups, past history of such acts are also usual. So the situation where the resident, usually the seniors will be very comfortably discussing the case the next day only. So the brunt of the situation has to be faced by the junior resident or the senior resident who is attending. And the frustrated informant, the informant might be quite fed up. The ED team, which is they have to look at the stroke, they have to look at the serious, the so-called genuine condition, and somebody is here maybe appearing manipulating. So this typical clinical scenario with this background, when we assess the NSSI, the non-suicidal self-injury, these are some quick points. First of all, to ensure quiet, private and safe physical space to examine when a patient. So remember that I am talking more on the SIB, self-injurious behavior, not the borderline personality disorder who comes with a marital conflict in the relaxed environment. The SIB usually comes to the emergency settings, in the hospital setting. It's important to find out a quiet, private and safe physical space to interview the patient. And obtaining care for the physical problem in a non-discriminatory way is very important. As I mentioned before, there could be a lot of negative countertransference or negative kind of subtle hostility to patients who present with self-injury. So it is the part of a mental health professional, a psychiatrist or whoever is attending, it's important to take care of that aspect too, so that their injuries or their medical problems get proper attention. And non-judgmental listening and reflection is very important for building the rapport. Assessment of the intention, assessment of the risk of repeating the act, because many a time admissions may not be feasible. So when we classically teach, we say that any suicide attempt, it is better to admit on the safety count. But we know when we talk about BPD, it may not be advisable even from a therapeutic way, the frequent hospitalization. So it is very important to assess the intention. We have already seen that even though it is non-suicidal self-injury, the death rates overall is higher in patients with borderline personality disorder from suicide. So assessment of intention and assessment of risk for repeating the acts is important. Look for substance use. The morning session, we know that addiction and substance use is the entry ticket for. So one entry ticket is substance use, other entry ticket. But many patients will have both the entry tickets. So the addiction, substance use will be present along with, and of course the medical comorbidities like bipolar, mood disorder or anxiety disorders are very common. And we need to decide then and there whether to go for the outpatient care or the inpatient care. Extremely important to support the caretaker who is burned out or frustrated or even overtly hostile to the person, and very important to plan and link to the interventions. We need to plan and we need to link. It may not be always possible. Sometimes we may have to link even with the legal systems or the law enforcing authorities. So these are the quick things. And to bring back the 3 T's in the reverse order, we talked about trauma in the childhood. temperament and triggering factor. But when we assess, that is theory, but when we assess practically, we have to focus on the triggering factor first, and then the personality styles, the coping strategies, the thinking styles, the intrapersonal, borderline personality or dynamics, etc. And the trauma in the child never take up in the first visit or in the emergency setting. So that has to be taken up very wisely, very judiciously, very sensitively later in the assessment part. So the risk factors for repetition and suicide in borderline personality disorder, the statistics again are interesting. The non-fatal repetition, 16% of the patients are likely to repeat in the first year. And if you have the follow-up for the 5 years, it can be nearly a quarter of the patients will be repeating. And the suicide rates, 1.6 at 1 year and nearly 4% at 5 years. So the 4 risk factors which researchers have identified to be very important are past history of self-harm, intent clinically or by, you may use intention scale, or comorbid physical conditions, and male gender, even though the prevalence is much more in female gender, male persons will have this. So the 4 risk factors, remember, past history, high intent, physical illness, and male gender. And when we focus on the treatment of non-suicidal self-injury in the BPD context, 4 stages. One is the crisis management and stabilization. For crisis management and stabilization, then second is we go to the psychotherapy part. Thank you. So the awakening of positive perspectives and personal values, and then the other-centered, the metacognitive awareness, and finally the integration of reason and emotions. So remember that these are not mostly focusing on the NSSI part of BPD, not the entire treatment of BPD. So the BPD psychotherapies, we are going to have a separate session today afternoon. But when we focus on the non-suicidal self-injury, crisis management and stabilization, positive perspectives and personal values, the metacognitive awareness about the self-injuring act, and to prevent repeat acts, very important to have an integration of reason and emotions. So in the crisis management and the stabilization phase, the question comes of whether to treat with drugs or not. We all know that there is no drug of choice, but pharmacotherapy is not a sin either. We may have to use pharmacotherapy, especially in the crisis phase or in the stabilization phase. But never take it from me that it is the pharmacotherapy is the first line, because we are talking about non-suicidal self-injury, which can form a crisis and which needs an import. So 4 categories of medications can be important. One is the mood regulators. Anxiety, depression can be tackled by selective serotonin reuptake inhibitors or SNRIs. And the behavioral discontrol and aggression, impulsivity, lithium, anticonvulsants. In the morning session, there was a mention on endoxifen, the protein kinase C, the PKC inhibitors also may have a role in the behavioral discontrol, even though the evidence base is not that very, as far as I looked up, but it is again promising. Endoxifen may be promising in the second domain, which can be targeted by pharmacological agents. And social and emotional detachment, which is not that uncommon in the background of NSSI. Low dose atypical antipsychotics, maybe a small dose of aripiprazole, and psychotic symptoms. See, we know that there could be transient psychotic episodes, conditions bordering from dissociation to transient psychotic. Perceptual disorders may be there. Delusional thinking may be there, which can occur. The so-called micropsychotic episode, if I am permitted to use the old terminology, atypical antipsychotics. So all these agents may have a role in the management of the critical first few days And as already mentioned in the previous presentation, benzodiazepines are avoided. If at all we want to use benzodiazepines, go for the long-acting, the long half-life ones, not the short half-life ones like alprazolam, which unfortunately is a therapeutic, is a misadventure, because for three reasons. One is, it can further worsen the behavior discontrol. Second thing, they can be used for self-harm. Or third thing, they can be, it is making them more prone for substance misuse. For these three reasons, benzodiazepines are better avoided. And there could be a specific role for naltrexone, which acts through the opiate mechanism, which since we do not have the time for that, so endoxifen or naltrexone could be promising in treating certain aspects of the self-injurious behavior. And ultimately, the final thing is the psychotherapy. We know that strict cognitive CBT in its strictest sense, or psychodynamic therapy in its classical form, may not be ideal to address the core issues of borderline personality disorder. We know even though we do not have the time, look at the criteria for selecting a person with the typical classical CBT or psychoanalysis. A person with borderline personality disorder do not fit into that. So psychotherapy is tailored to address the borderline personality organization needed, the DBT mentalization. So the best evidence base for reducing non-steroidal self-injury is with the dialectical behavior therapy. And then of course the mentalization therapy, schema therapy, transference focus therapy. So since we have a separate session on that, I don't want to just to name them only. The dialectical behavior therapy to target on the emotional regulation, interpersonal effectiveness, distress tolerance, and mindfulness. So for these four areas which are tackled by the DBT, has fairly good evidence to reduce the non-suicidal self-injury in BPD. Mentalization-based therapy, the ability to become aware of one's own mental states as well as the other person's mental state. Understanding how this mental state influences. So MBT, schema-based early maladaptive schemes, we had a mention on that in the previous session also, and the transference focus therapy. So these are the psychotherapies which could be useful in NSSI associated with BPD. So remember that to summarize, all modes of psychotherapy, irrespective of the mode of psychotherapy we choose, all of them target the affective instability or the emotional dysregulation, as well as the impulsivity, which are the final common pathways for the non-suicidal self-injuries. Cochrane review reports, systematic meta-analysis, summarize the evidence to support the conclusion that specific forms of psychotherapy are efficacious, just the Vice Chancellor mentioned in his speech. So we should not pull ourselves into a position of therapeutic nihilism. This is personality disorder, this is BPD, nothing can be done. So that kind of a therapeutic nihilism should not be there. There is evidence base that psychotherapies specifically designed for BPO can be effective. So irrespective of the model, they attempt to teach the patients to stand outside their emotions, to self-reflect, and to develop a better understanding of the interpersonal conflict. So I am concluding, self-injuring behavior of BPD. It goes with the territory of borderline personality, and it is perhaps the most common clinical presentation of BPD. It can be considered as a behavioral marker which aids early diagnosis. We should be aware of the three T's. That means the triggering factor, the temperament, as well as the childhood, the trauma. And interpersonal factors are deeply rooted in early development. Crisis management should be a skill of every person in mental health professional, irrespective of your specialty. And of course, that should be followed by evidence-based psychotherapy. So we need to look at ourselves that it can be quite draining for the therapist. Already discussed in the previous session, we need to Dr. Manju was particularly asking that question which was there in the mind of every person. So it is very draining and exhausting. And to the youngsters, my suggestion is to get trained in psychotherapies rather than getting away, running away from difficult problems. Get trained and collaborate with the psychologist. So that is my suggestion, and thank you. Some of the, I think this slide will be shared. Achan has, Bibin Achan has asked me, so this need not worry about these references. Some of them seems good to me, and thank you very much.
Thank you, sir, for such a valuable and insightful session. May I now invite Dr. P.S. V.N. Sharma to share his reflection and lead this discussion.
Let's start with any questions that especially the students would like to ask. Restrict yourself to this topic. Or should we start asking you questions? Anybody? Yes. There.
Hello? മലയാളത്തിൽ സംസാരിക്കാൻ കുഴപ്പമില്ലല്ലോ. മലയാളത്തിൽ ഓക്കെ. ഫസ്റ്റ് ഓഫ് ഓൾ ആണെങ്കിൽ നമ്മൾ ബി പിയുടെ കാര്യം വരുമ്പോൾ പ്രോഗ്നോസിസ് ആണെങ്കിൽ അത്രമാത്രം ഉണ്ട് എനിക്ക് തോന്നുന്നില്ല ആക്ച്വലി ഇപ്പം പറഞ്ഞ പ്രസൻറ്റേഷൻസിലൊക്കെ. അപ്പം അതുപോലെ തന്നെ ട്രീറ്റ്മെൻറ്റ് മെക്കാനിസംസ് ആണെങ്കിൽ ഫാർമോതെറാപ്പിയൊക്കെ അത്രമാത്രം എഫക്റ്റീവ് അല്ലെന്നാണ് ഇത്ര പറഞ്ഞത് ആക്ച്വലി. ആകെയുള്ള നമുക്ക് DBT അതുപോലെ കുറച്ച് തെറാപ്യൂട്ടിക് ടെക്നിക്സ് ആണ്. അപ്പം പണ്ട് ഇത് ബോർഡർ ലൈൻ സ്കിസോഫ്രീനിക്കായിട്ടൊക്കെ കൺസിഡർ ചെയ്ത സ്റ്റേറ്റിൽ നിന്ന് നമുക്കിപ്പം BPD എന്ന ഡയഗ്നോസിസിലോട്ട് വരുമ്പോൾ വി ക്യാൻ സേ ദാറ്റ് ഇറ്റ്സ് റിലയബിലിറ്റി കൂടുതലാണ് ഈ ഡയഗ്നോസിസിന്. പക്ഷേ വാലിഡിറ്റി ഉണ്ടോ, സയൻറ്റിഫിക് വാലിഡിറ്റി ഉണ്ടോ, അല്ലെങ്കിൽ ഇപ്പം നമുക്ക് DSM-6 പോകുന്ന ഒരു കാലഘട്ടമാണ്. അപ്പം ഹിസ്റ്റോണിക് പേഴ്സണാലിറ്റി അതുപോലെ തന്നെ ബോർഡർ ലൈൻ പേഴ്സണാലിറ്റി പോലുള്ള ഡിസോർഡേഴ്സിന് ഡു വി ഹാവ് എ റിയൽ വാലിഡിറ്റി? നമുക്ക് അത്രമാത്രം ഡയഗ്നോസിസ് അല്ലെങ്കിൽ ട്രീറ്റ്മെൻറ്റ് മെക്കാനിസംസും ഇല്ല. അപ്പം നമ്മൾ ആളുകളെ ഇങ്ങനെ ജസ്റ്റ് ലേബിൾ ചെയ്യുന്നതിലൂടെ ഹൗ മച്ച് ഇറ്റ് ഈസ് ഹെൽപ്പിങ് ആക്ച്വലി. അതുപോലെ തന്നെ ഒരു കാര്യം ചോദിക്കാമെന്ന് വെച്ചാൽ ഇപ്പം ഫീമെയിൽസിന് ഇത് കൂടുതലാണെന്ന് പറഞ്ഞു ആക്ച്വലി, പ്രിവലൻസ് റേറ്റ് കൂടുതലാണ്. അപ്പോൾ ഈ ഒരു കൾച്ചറൽ ഫാക്ടേഴ്സ് അല്ലെങ്കിൽ ജെൻഡർ സ്റ്റിഗ്മ ഒക്കെ ആണെങ്കിൽ ആക്ച്വലി മെയിൽസിലാണെങ്കിൽ ആക്ച്വലി ഈ ഒരു ഡിസോർഡർ ഉണ്ടെങ്കിൽ കൂടി അല്ലെങ്കിൽ ഈ ഒരു പാറ്റേൺ ഉണ്ടെങ്കിൽ കൂടി അപ്പോൾ എക്സ്പ്രസ് ചെയ്യാനുള്ള ചാൻസ് കുറവല്ലേ? അതുകൊണ്ടാണോ അല്ലാതെ എനി കൈൻഡ് ഓഫ് ബയോളജിക്കൽ മെക്കാനിസംസ് ഉണ്ട് ഇത് ഫീമെയിൽസിൽ കൂടുതലായി കാണാനുള്ളതിനെ പറ്റിയും കൂടെ ഒന്ന് ഒപ്പീനിയൻ പറയുകയാണെങ്കിൽ നല്ലതായിരുന്നു.
താങ്ക് യു. വുഡ് യു ഇൻട്രൊഡ്യൂസ് യുവർസെൽഫ്?
എൻ്റെ പേര് ഫെബിൻ എന്നാണ്. ഞാൻ ഇപ്പം MSc സൈക്കോളജി സ്റ്റുഡൻ്റ് ആണ്. ക്രിസ്ത്യോദി കോളേജിലാണ് പഠിക്കുന്നത്.
I think you should first ask questions relevant to his talk, and then if there is time we'll address your doubts. Okay? So his talk is about self-harm and what should be done clinically in a situation of self-harm. So please restrict yourself to that. Okay?
ഈ രണ്ട് ചോദ്യങ്ങളാണ് പിന്നെ അഡ്രസ് ചെയ്താൽ മതി.
But still I will respond. Okay. Thank you. ചോദ്യം ചോദിച്ചതിന് ആദ്യം നന്ദി. ബിക്കോസ് യു ആസ്ക്ഡ് ദ ക്വസ്റ്റ്യൻ മലയാളം, സോ ഐ ക്യാൻ ഓൾസോ. രണ്ട് ചോദ്യം, ഒന്ന് വാലിഡിറ്റി, ഒരു ഡയഗ്നോസ്റ്റിക് വാലിഡിറ്റിയെ പറ്റിയുള്ള ഒരു ചോദ്യമാണ്. ബിക്കോസ് എ സൈക്കോളജി സ്റ്റുഡൻറ്റ് വറിയിങ് അബൌട്ട് ദി വാലിഡിറ്റി ഈസ് ക്വൈറ്റ് അണ്ടർസ്റ്റാൻഡബിൾ. നമുക്കതിൻ്റെ ഒത്തിരി തിയററ്റിക്കൽ പെർസ്പെക്റ്റീവ്സിൽ പോയില്ല. സി ഇറ്റ് ഈസ് അബൌട്ട് ദി പേഴ്സണാലിറ്റി ഡിസോർഡർ ആസ് എ ഗ്രൂപ്പ്. ദർ ഇസ് എ ക്വസ്റ്റ്യൻ ഓൺ ഹൗ വാലിഡ് ദി കൺസെപ്റ്റ്സ് ക്യാൻ ബി. അപ്പോൾ നമ്മൾ കാറ്റഗറി ഡയഗ്നോസിസ് ഡയമെൻഷണൽ അപ്രോച്ചും തമ്മിലുള്ള ഒരു ബേസിക് ഡിഫറൻസ് വരുന്നത് തന്നെ സ്റ്റാർട്ടിങ് ഫ്രം ദിസ് ക്വസ്റ്റ്യൻ, ഹൗ വാലിഡ് പേഴ്സണാലിറ്റി ഡിസോർഡേഴ്സ് ടു പുട്ട് സംബഡി ഇൻ ടു റിജിഡ് കാറ്റഗറി ഗ്രൂപ്പ്സ്. അപ്പോൾ അതിൻ്റെ ഒരു പ്രശ്നം അവിടെയുണ്ട്. ദാറ്റ് ഈസ് ദ റീസൺ വൈ ബോത്ത് DSM-5 and ICD-11 are shifting towards dimensional approaches to understanding personality in general and BPD in particular. Validity issues are still there, but clinical problem, very clinical utility, when somebody presents with a clinical problem, for example, ഇവിടെ നമ്മൾ ഡിസ്ക്രൈബ് ചെയ്ത സെൽഫ് ഇഞ്ചൂറിയസ് ബിഹേവിയർ, അതിനെ നമ്മൾ മനസ്സിലാക്കാനായിട്ടും അതിനൊരു ട്രീറ്റ്മെൻറ്റ് കൊടുക്കാനായിട്ടും we need to use certain terms, diagnostic terms. So the philosophical question where all human miseries? Is it right to label all human miseries and predicaments in terms of a medical label? അങ്ങനെയുള്ള ഫിലോസഫിക്കൽ ഡിസ്കോഴ്സിലേക്ക് നമ്മൾ പോവാതെ ഒരു പ്രാക്ടിക്കൽ അപ്രോച്ചിൽ നോക്കിക്കഴിഞ്ഞാൽ it is a valid construct, clinical construct, where we need to treat. The second part of your question was? Women, the gender difference. Okay, the gender difference വരുമ്പം നമ്മൾ ഏത് കണ്ടീഷനാണെങ്കിലും മാർക്കറ്റ് ജെൻഡർ ഡിഫറൻസ് വരുമ്പം there is a lot of bias. For example, another example is ADHD. ADHD is much more 5 times more common in boys. But now that is not longer accepted. Gender differences in the way in which the symptoms are expressed, there could be a lot of cultural prejudices, stereotypes, which could influence the gender differences. But still, again, it's a clinically relevant fact that more females come with this particular pattern of behavior in the clinical settings. Male gender stereotypings are very common. For example, in the case of conversion and hysteria and dissociation, some gender bias, the same. I was always wondering what happened to all the conversion disorders, dissociation disorders. Now the prevalence has come down and the prevalence of diagnosis of borderline personality disorder is going up. Some patterns are common, the gender preferences, etc. അപ്പോൾ അങ്ങനെയുള്ള കാര്യങ്ങൾ, these are sources for further research and etc. Why there is it a true difference in gender presentation, or is it an artifact of our cultural expectations and stereotyping, etc. So these are valid questions, but again, I think I don't think I can give a very solid, concrete answer for questions which are more of at the conceptual level and which may need more research. Thank you.
If I may add to this, I'm sorry, I'll speak in English because my Malayalam is not great. Any classificatory system that you look at, whether it's ICD-11 or DSM-5 or anything else, it lists out certain characteristics and usually does not demand that all the characteristics should be there in that condition to diagnose the person with that particular disorder. So it might say 6 out of 9 should be present and so on. The second thing is that if you look closely in the personality disorder section, there are certain traits which are common across disorders also. You might find impulsivity not just in bipolar, borderline personality disorder, but also in what we call as adult antisocial personality disorder. Okay. Now, that means that there is certain overlap, but relying on one trait becomes difficult in terms of predictive validity. When you take a cluster of traits and put them together and you are able to produce predictive validity, that gives some substance, some theoretical substance to that diagnostic condition. And if you take the universe of traits, then what Sir was saying makes sense, because as research progresses, you find a reordering of those traits because we see pictures more clearly. So trait A, which belonged to illness 1, may now be in illness 2 rather than in illness 1, because maybe the population sample is bigger, maybe because you have cross-cultural validation. There are many ways. So certain amount of validity is present, and the current move of dimensionality is where you don't look at one trait or 2-3 traits to make a diagnosis. You have renamed them into clusters of dimensions. With that, there is a better likelihood of validation. Ultimately, of course, this is validity which has to be supported by biological and other methods of classificatory systems also. But these are workable hypotheses with which you can say, okay, this person is borderline PD, so the chances of DBT working in her are better than the chances of supportive psychotherapy working in her. Okay, so you are doing another exercise of predictive validity, right? So I think it's a work in progress, I agree, but we are moving forward. Okay.
So thank you for that presentation. Just one thing regarding not exactly to that NSSI, but regarding the preventive aspects. I was thinking, because recently I got a case of this NSSI in a child with 12 years old child presented to the casualty with drug overdose. So at that point of time, I was thinking, just like we have some methodology to screen children with LD or learning problems right from the age of 8 years, just like that, is there anything that we can advise the school authorities or make them screen these children, such children who shall develop this self-injurious behavior in the future, and help them in some sort of preventive measures so that they don't venture into this thing, especially after this COVID era, where these children are more limited to that internal solitary space, and they are so frustrated when this that sense of gratitude is being broken. So is there anything that we can advise to the school authorities, or they can screen these children? Is there anything?
Very difficult, but valid but difficult thing to, but I will give some reflections on that. Last year, we had a series of self-injuring behavior from a particular school. So in fact, almost like a contagion. One girl child in 8th standard, she had a self-inflicted injury. And following that, within the next 2 weeks, 4 children in the same school had self-injurious behavior and they were brought to for help. So it's almost like a contagion. But the teachers from, in fact, we wanted to report and we wanted to, but the ethical committee did not give permission for reporting because of the fear of further increasing the contagion factor. Anyway, so these kind of behaviors, what I wanted to convey is that nowadays, it's not actually even the age group in which self-injurious behavior, the non-suicidal self-injurious behavior is coming down. Children in 7th standard, 6th, 8th standard, it's not an uncommon situation to come with. But regarding, I'm a bit apprehensive whether to focus on a particular kind of, from a public health point of view, from an epidemiological point of view, it may not, I'm afraid, it may not make much sense to screen the entire students for a particular disorder rather than the general children, like for example, the common neurodevelopmental disorders like ADHD or SLD screening. Even that is fraught with so many ethical issues, practical issues. We attempted some of these things to be screened. So going for a specific screening for a condition like the future emergence of a borderline personality disorder in children, theoretically it sounds well, but practically it can definitely run into problem. So what my thinking is that we should be focusing more on the preventive aspects of mental health, screening for not only self-injurious behavior, generally the neurodevelopmental disorders, emotional disorders in children. So that should be a part of the school health rather than focusing on a particular problem.
I think I would like to add one thing though. There are certain childhood risk factors which are strong predictors of adult or adolescent borderline personality disorder. So teachers and schools should be sensitized to the fact that if such risk factors occur in a child, that child should automatically be dealt with as somebody at risk. Just like you have at risk for psychosis programs. Similarly, undergo psychological intervention which might be corrective in and normalizing in the development. That those interventions exist. The whole problem, of course, is that you have a huge number of children, a huge number of teachers, and training for those sort of interventions is quite complex. So in that way, it's limited, but that can be done. It is being done for other things. It is being done for epilepsy, for example. So similarly, it can be done if a child has been subjected to CSA, for example, or has suffered some sort of trauma like loss of a parent or anything which can, affect. Having a sort of a system where automatically expert intervention happens, if that is feasible, then that will be wonderful. And we can even then really study what percentage of those children who have been intervened with do not versus do develop, and that would be a validating factor for that particular therapy.
Thank you. It's fortunate to have a very learned person like sir as the chairperson, so he can.
So I'd also like to add, for Dr. Jayashankar, the entire next session is about this. Dr. Manju and Dr. Radhika, Dr. Radhika is a child specialist. The entire session is about childhood indicators of borderline personality and addiction. So, but I'm really glad that you asked the question because we could get Dr. Sharma and Dr. Verghese Punus's perspective. And even the previous question about prognosis and all the answers were really good. I think a lot of people benefited from that. So thank you both for asking the questions.
Oh, there's one hand there. The last question.
Hello, sir. I am Anuja, and my doubt is that how can a professional can differentiate whether the person shows NSSI or a real or acute suicide tendency?
Practically, so very closely pertaining to the topic at hand, if you had noticed one of the slides in the assessment of non-suicidal injury, one of the most important steps in the clinical assessment is the intent of suicidality. What is the motivation or what is the intent to die? So there are clinical methods as well as psychometric methods to estimate or to make a judgment on the intention. So intention can be, in the beginning of my presentation, one of the problems which I highlighted was to classify the issue with the training, whether to classify somebody as having no intent or another person is having high intent. Actually, it is a spectrum. So a person with borderline personality disorder or any person, forget about borderline personality disorder, any person with self-injury can have intention lying from anywhere in this spectrum. So one method is to assess clinically with regard to the intention as well as the lethality of the method used. And second thing is psychometric assessment, like there are several scales, like the intent scales, the Beck suicidal intent scales like that, to quantify the intention. So it's a clinical exercise. It's a clinical exercise as well as psychometric exercise to assess the suicidal method. And with regard to the self-injury in borderline personality disorder, it is important to understand that it can again fluctuate. It's a repetitive act. In one of the actions, the suicidal intent can be minimal. It can be only an expression of the distress to get a relief. But in the next instance, maybe sometime later, the same person can have a high intent and may use a highly lethal method with an intention to die. So, we should not be fooled by a previous intent assessment. Okay, this person repeatedly comes, just like the Pazhaya Katha, so one day it can come. So it can happen. So even just because that the intent was low, in some of the instances it could be high. So in the take home point is that every attempt we do this assessment of intent and the lethality in its own merit as if we are assessing it for the first time. So that is a very relevant question. Thank you for that question. Thank you.
The number of cases that I've seen with BPD, the entire presentation helped me see it in a different perspective altogether, while identifying what has been useful and what more could be done. It's a brilliant presentation. Thank you very much.
Thank you, sir. May I now invite our head of the department, Dr. Ruben John, to kindly present the mementos to Dr. PSVN Sharma and Professor Dr. Varghese P. Punus as a token of our respect and heartfelt gratitude. I also warmly invite Mrs. Shalini Sharma to graciously join us on stage to receive our token of respect. She is an active psychiatric social worker, completed her studies from prestigious Roshni Nilayas, Mangalore. Thank you very much, sirs. This concludes scientific session 2.
No, wait. Shalini madam. So, Dr. Shalini Sharma is a big part of our family at Kasturba Manipal. We feel that she is one of the main reasons which keeps our Dr. Sharma in line, and it's a big thing for us and it's a big honor for me to felicitate her with the Armla Kannadi, a traditional and very close part of our heritage.
Thank you very much, sirs. This concludes scientific session 2. We will commence our next session shortly.
Dear participants, I know all of you are actively following the slides and are eager to receive them for your own reference and study. Each presentation contains important documents, research findings, and valuable clinical insights. We are grateful to our esteemed speakers who have kindly agreed to share their slides. Therefore, after the seminar, PPT slides from all sessions will be shared with all participants through the email ID provided at registration. Thank you for your enthusiasm and your active participation. And dear participants, we are pleased to inform you that 4 valuable books authored and co-authored by Reverend Sister Dr. John Chunkapura MMS, one of our esteemed resource persons today, are available for purchase near the seminar registration counter. These titles published by Trada Kottayam include: first one, Pragashathinte 12 Padigal. Second one, Lehari Chigilsa, co-authored with Reverend Dr. Chakochan Kalapuril CMI. Third one, Counseling Children and Youth, co-authored with Brother Dr. Matthew Chalivarambal SD. And fourth one, Treatment Models in Addictions. These books are present rich insights into addiction treatment, counseling approaches, and therapeutic frameworks, making them highly beneficial for clinicians, counselors, students, and anyone passionate about mental health and recovery. We encourage you to visit the bookstall and make use of this opportunity to explore these excellent resources. Thank you.
Dear all, here we begin our scientific session 3. Due to the cancellation of Dr. Radhika's flight, she will be joining us online from Kolkata to deliver her presentation as the speaker. We also have Dr. Manju Pidambaran with us as the chairperson for this session. May I request chairperson, Dr. Manju Pidambaran, to kindly come forward to the stage. It is my honor to introduce Senior Consultant Psychiatrist Mavelikara. With more than 22 years of dedicated service in Kerala Government Health Services, including 7 impactful years as Nodal Officer and Psychiatrist Mental Health Program in Alappuzha. She brings rich clinical wisdom, community psychiatry experience, and a compassionate approach. Currently running her private clinic in Mavelikara and serving through institutions such as Srikandapuram Multi-Speciality Hospital, Carecraft Hospital, and RCPM Hospital. She is also the founder and CEO of thebetterpsych.com, a platform for mental health awareness and support. Beyond clinical work, she leads as chairperson of Vaima Mavelikara, serves as a master trainer for the IMA Committee for Promotion of Leadership and Communication Skills, and is known for her love for literature and humane, holistic psychiatry. Ma'am, we warmly welcomes you. It is also my privilege to introduce Dr. Radhika MS, consultant psychiatrist, Andhara Psychiatric Hospital, Kolkata. She holds DNB in psychiatry and a postdoctoral fellowship in child and adolescent psychiatry, and is an alumna of Manipal. Her clinical and academic work focuses on childhood and adolescent mental health, developmental disorders, emotional and behavior problems, psychiatric diagnostic, therapeutic interventions, early screening, and family-based therapeutic involvement. Her long journey from Kolkata to be with us reflects her deep commitment to mental health education and collaborative learning.
So, addiction and borderline personality disorder, they are very frequently co-occurring. In fact, their co-occurrence is so much that studies have been done to see if they have shared common etiological processes, reinforcing the importance of researching these disorders from a divergent and transdiagnostic perspective. I've been hearing the previous speakers who mentioned that categorical approach is not right because they share so many common dimensions and common traits, which is true. In fact, their maximum comorbidity or occurrence is during adolescence, 14 to 18 years of age is when borderline personality disorder and substance use disorder maximum co-occurrence has been observed. We have to remember that adolescence is as such a vulnerable period, and also it doesn't suddenly pop up, any personality disorder or even substance use disorder. It is a dynamic and transactional play between vulnerabilities, inherent vulnerabilities which are genetic, and also the environmental factors which then lead to maladaptive variants of their personality. So how do we explain this co-occurrence? There are theoretical models, there are shared liabilities, etiologies, and there is also something called causal models. These are how we explain. So let's see at the shared liabilities or etiology first. Before that, this is a brief outlook of how we are going to discuss. First, there's a genetic vulnerability which could be because of family history of mood or dysinhibitory psychopathology like substance use, which causes a neurobiological vulnerability to both borderline personality and substance use disorders. Also, then there comes the environmental factors, the interplay between these two help in the development of the disorders and also sustenance or maintenance of both these disorders. These two traits that you are seeing, the affective instability and impulsivity, are important. We'll be discussing them in detail. So, shared etiology. The more studies I was looking at, the more it almost looked also be affected. They could also be considered as phenotypes of both these disorders. And there's a neurocognitive model where executive function disturbance is seen because we know prefrontal cortex is affected in patients with borderline personality and substance use disorder. How we will see further. What happens is there is neurobiological vulnerability, and then when there is chronic or repeated stress, there are neuroadaptations which happen in the brain of both reward systems and nervous systems, which lead to the co-occurrence of these disorders. So, genetics, how do we know? Substance use disorders are also the most common psychiatric diagnosis in programs or relatives of those with borderline personality disorder. Evidence from new studies indicate that they have shared genetic influences. Between border, especially more correlations is seen between borderline personality traits and substance use among young adolescents. There was a study which proved that regulation is a common trait which shares genetic material across the spectrum. But the important thing to know, comorbidity observed, it has been found out that it's mostly because of the shared environmental effects. But after 18, it has been found that the genetic component takes over, and that helps in maintaining the disorder into young adulthood. So, causal model, which came first, chicken or the egg? It depends from time to time which way the scientists are thinking. Initially, there was a model called complication or SCAR model where they believed that substance use disorder happens first, and because of repeated substance use, it causes changes to their personality irrevocably. It's also called as SCAR model. But these days, people are moving towards the predisposition vulnerability model, which I've explained, because temperament and personality traits occur in a child or an adolescent well before there is substance use. So people think that initially there's a personality disorder, then substance use occurs, then they maintain each other and they coexist with each other. So there are three major neurological pathways affected. The behavioral disinhibition pathway, where the traits that are seen are high antisociality, impulsivity, low harm avoidance. They are associated with a higher risk of drug and alcohol use. And as you can see, impulsivity is a main trait in borderline personality disorder also. Then there's a stress reduction pathway, which suggests that anxiety and stress reactivity, which are seen in borderline personality patients as young adults, they are also more prone to substance use. And then there's the reward sensitivity pathway, which includes novelty seeking, reward seeking, and urgency, where even despite risk, they repeatedly end up doing an act. So what are all the genes involved? The reward sensitivity pathway, which is the brain dopaminergic system, substantia nigra and ventral tegmentum, gene D2 is responsible. The dopamine receptor or the dopamine transport genes are involved in low constraint, that is the disinhibitory pathway, where prefrontal cortex, basal ganglia can be involved, and the stress reduction pathway, repeated stress affects HPA axis, the serotonin receptor and serotonin transporter 5-HTT gene responsible genes are involved, rostral ACC, VMPFC, and there's a decreased control of amygdala, which is why we use SSRIs, and good effect also is seen in borderline personality disorders because their serotonin transport and everything is affected. And it also reduces impulsivity in alcohol use disorders also. So to reiterate, these are again the areas of the brain which are involved. Now we come to the temperamental vulnerability. So what is temperamental vulnerability? What are the traits? As someone had asked previously, is there anything we should be looking for in a child or an adolescent? So we should be looking out for signs of impulsivity, emotional dysregulation, disinhibition, antagonism and neuroticism. But impulsivity and emotional dysregulation we'll be speaking about in detail. Again, these neurobiological vulnerabilities are pre-existing. It doesn't mean that if they have a risk for being too impulsive, they will develop borderline personality disorder. This is where environmental factors come into play. So what can impulsivity look like? The important thing to remember is not just impulsivity, but a component of it called impulsive aggression. When impulsive aggression is seen outwards, it comes out as externalizing symptoms. They could be temper tantrums, head-banging behavior. But when impulsive aggression is inwards, as we see in borderline personality disorders, there is more risk of self-harm,
or in a case of an adolescent or a child also these days, non-suicidal self-injurious behavior. So if we are observing this, that particular child should be given attention to see where it goes to. So emotional dysregulation. What does emotional dysregulation mean? It's a maladaptive variant of emotional regulation. They are unable to use healthy coping mechanisms, socially acceptable methods, or methods which are beneficial to them to control their emotions. We get a little angry. That is not emotional dysregulation. If we break our hand in anger, throw something, repeatedly are continuing the same thing whenever we get angry, that is emotional dysregulation. Emotional dysregulation can occur from a very young age. We'll see why it can occur, what are the environmental factors affecting it, and then we'll see how to identify it in a child. So, now that we've covered the neurobiological vulnerability part, let's talk about the environmental factors. Childhood starts from parenting. Parenting, especially emotional neglect, has been shown to increase risk of substance use disorder and borderline personality disorder. This was going to be an interactive slide where I ask everyone which parenting style you think would be more involved, but I'll go ahead with it. So the uninvolved parent, where they don't care, rather than the permissive or authoritarian, which are more involved with substance use alone. But the uninvolved parent or the chaotic parent, one day they are reacting well, the other day they are not reacting well, excuse me, that kind of parenting is more risk for a comorbid borderline personality and substance use disorder. So, maltreatment. Maltreatment includes neglect and abuse. Abuse could be physical abuse, emotional abuse, or verbal abuse. What happens is, chronic maltreatment is a major factor. One day or twice a child is yelled at or a child is mistreated once or twice, which should not happen, but that doesn't lead to the co-occurrence of this comorbidity. But chronic maltreatment, which has been going on for years or continuously in a repeated pattern, it affects the emotional regulation. The brain formation itself is affected. We have to remember neuroplasticity is a thing, and your prefrontal cortex keeps responding to how your emotions, when you're sad as a child, if someone's hugging you, your brain forms a pathway on how to deal with sadness. But no one's hugging you, everyone's ignoring you, or they're yelling at you. There will be a different pathway which is formed, which leads to emotional dysregulation. Attachment quality, we'll come to it later, even that is affected by chronic maltreatment. Child victims of maltreatment have shown disruptions in peer, familial, romantic relationships, impulsivity, attentional difficulties, dysregulation of affect, and disrupted representations of self. If we look at it from a psychodynamic point of view, identity confusion, when unrealized, when there is no clarity of identity confusion in adolescence, it could lead to distorted self-image, which sounds a very common symptom of borderline personality disorder. And also, identity confusion is a precursor for all these poor coping skills, unhealthy coping skills, which is seen in substance use disorders also. So this is where the identity confusion comes from. Chronic maltreatment, where a child is not sure what his or her place is in the world or in his along with his family members. So, how do we know these risk factors? It's not just me saying it. There have been studies done where they studied people with comorbidity of borderline personality disorder and substance use disorder on just substance use disorder alone. So, the risk of having experienced physical and emotional neglect was 2.8 times higher among substance use disorder and borderline personality patients than for substance use alone. And family violence and abuse, which is severe childhood traumatic experiences, they were more frequent in the comorbidity or co-occurrence part than substance use alone. The demographic details to keep in mind were more women were found to have this comorbidity or co-occurrence of substance use and borderline personality than men. And as substance use and borderline personality patients were younger than patients with substance use only, this could be explained that borderline personality disorder or borderline personality traits are much higher during adolescence, and slowly into young adulthood, they might stabilize a bit. What is childhood adversity? As you can see, it could be physical abuse, sexual abuse, verbal abuse, emotional neglect, physical neglect, and there are patients or family members who have alcohol and drug problems. Adults, by that I mean parents who have mental health problems. So they may, if they are untreated, they may not be able to take care of the child or provide the emotional comfort and safety that a child requires. When there is domestic violence, the child doesn't have to be directly physically hit. Even repeated exposure to scenes of domestic violence affects the child's development. And when there are parents who've spent time in prison, who've been absent, as we had previously discussed, neglectful parenting is more harmful. And parents who have separated. So what happens is, childhood adversity causes early stress, and repeated stress affects the HPA axis, and there is a hyperactivity of the sympathetic nervous system, and it also leads to impaired prefrontal cortex. This hyperactivity of sympathetic nervous system, even small issues they might see as a threat, or they go into adrenergic overdrive, which explains how they react or how they explode when they face even the slightest difficulties. So it leads to increased stress sensitivity and a reduced self-regulation capacity. So this is just to sum up what we've seen so far. Invalidating factors. All this could be explained as an invalidating environment. We learn emotional regulation from childhood through modeling how our parents are emotionally regulating, by seeing peers, and we also learn how to control or manage our emotions based on how a parent is responding to our emotions. So if we are not shown a healthy mechanism, or if the child is not shown the right way or guided or dealt with care, then they develop a negative emotional regulation or the emotional dysregulation, because they are not sure what to do with their emotions or how to deal with their emotions, and it comes out as outbursts or self-injurious behavior in the most uncomfortable of times. Childhood traumatic experiences, maladaptive parenting, and when it comes to adolescence, even invalidating peer relationships. All these affect the self-regulatory mechanisms of emotions and behavior. So now, what do we look for in a child? Temperament. Temperament is just assessing the behavior of a child based on different dimensions like activity levels, socializing, and how he is responding to strangers, and how he is reacting to an emotional stimulus. The temperamental dimensions of emotionality, activity have been maximum associated with what could be impulsivity and emotional dysregulation. Emotionality is how a child responds to a negative situation, whether they respond well or whether they become withdrawn or whether they have an anger outburst. Whether it sustains is the most important part. One and done incidents never indicate the temperament of a child. If it's something the child repeatedly does, then it's a temperament. Increased activity levels, as we know, are associated with impulsivity also. So that's an adolescent. Externalizing symptoms. Any symptoms associated with ADHD, conduct disorders, ODD, these children should be kept in mind that they are at a higher risk of developing borderline personality and substance use disorders. There are many studies where untreated ADHD has been shown to be a risk factor for substance use disorders. Along with these, there's something called a developmental trauma disorder or attachment disorders also, especially the disattached and sudden, how they, I'm so sorry, how they're extremely attached one day and then the other day they are not attached. These kind of attachment issues are risk factors for borderline personality and substance use disorders. Attachment style, like I mentioned, anxious attachment or an insecure attachment where they don't know how to have a healthy relationship because they are scared if they have a negative emotion, the other person is going to go away, or they are going to hit them, or they are going to get angry. So they are always unsure about how close to get to a person or how far to stay away from a person. Insecure attachment has been shown to cause difficulties in emotion regulation and greater severity of a combination of borderline personality and substance use symptoms. What to look for in a child? So what exactly are we looking for? What are the childhood indicators? Temper tantrums, head banging, impulsivity. They are disturbing the class, they are constantly disrupting the class. If they hear no, they immediately start throwing things, they start banging their head, they start biting themselves, or they even hit the other person in front of them, or unhealthy eating behaviors. They're emotional eating, like when they become angry they are eating, when they become sad they are eating. And again, it has to be persistent, it has to be a pattern of these behaviors to call it a maladaptive variation. So if you look for all these things in a child, and if the teacher notices this, and if there is history of other environmental factors like the ones we've discussed, especially maltreatment, any of the childhood adversity we discussed, then we should know that these children are at a higher risk of developing borderline personality and substance use disorder. Non-suicidal self-injurious behavior, there was a whole session about it previously. Unfortunately, I've started seeing cases of non-suicidal self-injurious behavior in children as young as 8 years old or 9 years old. There are additional stressors now. The risk of anxiety, risk of depression has become much higher in younger children because of how scholastic difficulties are there, or how much pressure there is in school. So these things also should be studied to see whether they are also leading to borderline personality and substance use disorders. But not enough studies have been done, neither in the Western world or in India, where our entire education system is kind of different, and there's a lot of pressure to perform well and come first and participate in everything. There are no self-soothing, self-regulatory skills. The kids aren't learning how to calm themselves. They are immediately given a mobile phone these days. There's so much mobile addiction. So the minute we give them something external, they don't understand how to calm themselves down. That itself could lead to emotional dysregulation. So non-suicidal self-injurious behavior is a part of the impulsivity spectrum, where the impulsive aggression is directed inwards towards a patient. So what is different in adolescence is, it's important to remember that the age of the first time patient used a substance shows how severe their borderline personality and substance use will be. The earlier they use a substance, the more severe their comorbidity could be. There's an evolutionary approach to looking at borderline personality disorder and substance use disorder, which I found a little interesting while I was reading. Apparently, there's something called slow lifestyle people and fast-paced lifestyle people. Slow lifestyle people, they settle slowly. Their romantic relationships occur at a much later age. They have children at a much later age. They are more goal oriented. This is a slow lifestyle. But fast lifestyle, why it happens is, they are not sure about tomorrow. As children, they weren't sure if their parent will hit them today, feed them today, what will happen tomorrow, will they go to a foster home, are they going to go somewhere else. So they want everything to happen today. So they want to have fun or enjoy the nice things while they are happening, which is why they end up having romantic relationships earlier. They are at more risk for teenage pregnancies, more risk for substance use. All these comes from, as we've said, it's a dynamic and transactional play, where one thing is maintaining the other and the other thing is maintaining this, and it's a whole circle. So environmental factors play a major role in kickstarting this kind of a lifestyle change in adolescence, because if the entire childhood has been uncertainty, when they have even a little bit of control over what they can do, they end up doing things like this, which are of high risk, and negative effect makes them urgency, response inhibition, all these impulsivity traits which they have inherently makes them do this repeatedly, and there the comorbidity or co-occurrence of borderline personality and substance use start. Peer issues, again, peer rejection or peer pressure more for substance use, but when there is peer rejection, there's more risk of non-suicidal self-injurious behavior, there's more risk of anger towards oneself, and they get insecure attachments over and over again, which is how they end up in early romantic relationships. Externalizing symptoms here, it also includes conduct disorder. So lying, stealing, truancy, not going to school, substance use, these are all high risk for a comorbidity of borderline personality and substance use disorder. Why is it important? Why are we looking at it right from the childhood? Temperament, personality, these all occur even before there's a full-blown disorder. These are all risk factors. Maladaptation of temperament and personality traits in adolescence. And we know that borderline personality disorder and substance use disorder combination has a poorer prognosis and they are at more risk for suicidal behavior, which is why it's important to notice these symptoms in the childhood itself. So, early intervention, there could be parent child intervention, school based interventions which can be done, and treatment of underlying disorders like ADHD, ODD, or any underlying depression, or sometimes even eating disorders, which could be a sign of poor distress tolerance or impulsivity. If identified early and if treated early with the proper interventions, then we could avoid the development of this comorbidity. What are the future considerations is, all the studies I read for this particular presentation, it almost shows like there is still a tug of war between which came first, which maintains which, and so much yet to be understood about the bidirectionality of it. How whichever one comes, the other definitely crops up at some times, and then they start maintaining each other. So we have to do more nuanced studies, and all the literature I found, most of it was Western. There are not many Indian studies on comorbid borderline personality disorder and substance use disorder. So we need to study a trait, not a categorical thing, but there needs to be a transdiagnostic approach to see what spectrum, whether it's impulsivity spectrum or emotional dysregulation spectrum, what spectrum these fall on. Thank you all very much. I hope you understood what was going on, and I conclude the session. Thank you.
Thank you, Dr. Radhika, for the insightful and enlightening session. May I now invite the chairperson, Dr. Manju Pitambaran, to share her reflections and lead the session.
To unmute for some reason, so I can't hear what's going on.
She can't unmute, so she can't hear what's going on. A question
No.
answer session will be difficult.
I can now. Yeah. And sorry about my giant floating head at this point.
Good afternoon, everyone. Now we can see Dr. Radhika very clearly. Hi.
Hi, ma'am. Good afternoon. Nice to be there, if virtually.
Yeah. It's a privilege to be here today. And I thank Dr. Ruben and the management of Dr. K.M. Cherian Hospital for inviting me to be part of this national seminar today. Blessed by the presence of stalwarts like Sharma sir, Suma madam, and our very own Varghese Punnu sir. I hope you students know how lucky you are today. Happy to have reconnected with old friends and made new acquaintances and friendship with a vibrant younger generation. Please do bear with me while I take a moment to acknowledge the tremendous work that has gone into making this conference possible. Events like Dr. Jayashankar mentioned, events of this scale don't come together by accident. They happen because of countless, endless hours of effort, teamwork, and commitment. And the packed hall, filled with a diverse audience, is testament to the relevance of the topic. And my personal opinion is, I believe, more so to the efforts of my friend and colleague, Dr. Ruben. Thank you, Dr. Ruben, and your entire awesome team for the heart, the precision, and the passion you have brought into organizing this event. It's been a pleasure to be part of something so well crafted. The number of messages in the CTPS WhatsApp group was evidence to your persistence. Okay, now coming to Dr. Radhika's talk today, it focused on a topic that sits at the heart of developmental psychiatry, the early life determinants of addiction and borderline personality disorder, how childhood temperament and adversity ranging from neglect to abuse, and neurobiological factors shape long-term trajectories. So it's an area where understanding the roots truly help us to transform the outcomes, I hope. As you have all realized, very late that is, it was a surprise that Ruben planned to spring on you. Our speaker was unable to travel to the conference in person due to unforeseen circumstances, but we're very glad that she's been able to join us virtually all the way from Kolkata. Thanks to the flexibility of the format, the incredible IT team, and definitely Dr. Radhika's commitment. She has been calling Dr. Ruben non-stop. She called me yesterday. She really wanted to be part of this.
We are privileged to have her here, and she brings her deep clinical and academic experience to this subject. And we had the pleasure of listening to an engageful and insightful session. Thank you so much, Dr. Radhika, for joining us virtually despite the last-minute travel disruption. Okay, we will now proceed to the discussion and the Q&A segment. I would request the attendees, whoever wants to answer a question, to raise their hands. The mic will be brought to you. Please place it close to your mouth. State your name and your institution clearly so that she'll be able to hear the question. Dr. Jayashankar had a very relevant question in the last session, and I think she answered most of it, right?
Hi, thank you, ma'am, for the wonderful presentation, first of all. My name is Dr. Richa. I'm a trainee in psychiatry. My question is, during the, when we evaluate children, what are the, usual, we have known that non-suicidal self-injurious behavior is usually cutting themselves or overdosing. What are the other NSIs, like if there is any skin pricking or hair pulling? This can be also considered as NSSI, or can you share some insight about this?
Sure, definitely. It's an interesting question. Skin picking, hair pulling and all, they actually come under the compulsivity spectrum. So when these things are noted, we have to keep in mind and look out for other obsessive compulsive symptoms. Most of the non-suicidal self-injurious behavior in child is usually it involves cutting. These days, unfortunately, because they are smoking also at quite an early age, it also involves burning themselves. But excoriation, skin picking, hair pulling, we have to look more towards compulsive disorders than consider impulsivity based and non-suicidal self-injurious behavior. We have to watch out more for the OCD spectrum of disorders when such behaviors is seen and do a thorough workup.
Thank you, ma'am.
Dr. Richa also had a question she couldn't ask earlier. So if you have, she asked about 18 to 19-year-olds, but even from, so that's like almost, say 15 to 18, 19. So when they come with self-harm or they come to you by themselves, what about confidentiality there? So in children and in adults.
So confidentiality is very important, but when I notice a teenager especially, or even children, the younger children who come to my OPD or clinic and there is self-injurious behavior, I explain to them how confidentiality works. Right away I tell them, this is a safe space, you can tell me anything, but there are only 3 times where I might end up breaking confidentiality. And children do understand. I tell them that if you are hurting yourself, I'll inform your parents that there is such an issue happening, but the why behind it, I will not disclose to your parents unless you are willing to do it. So when they understand that part of it, the why of it, whether it's because of a relationship or some other issue or underlying distress they are having, when they know firsthand this is happening, then they are more willing and they even give permission to share it with the parent. Because lethality is always a thing, like sir had mentioned in the previous thing, non-suicidal self-injurious behavior doesn't always stay non-suicidal self-injurious behavior. So we have to keep in account lethality, and which is why any child, when you're taking any history, it's always important to discuss with them what will stay confidential and what will not stay confidential. We will tell them that they are at risk, they are at harm, to keep an eye on, we'll inform the parent to keep an eye on the child, and we will also inform the child that any medication we give or anything will stay with the parent only, and they'll be given supervised medication. Most of the teenagers, because we do build a good enough rapport at that point, they are quite open to this as long as the why of it is not shared with the parents freely. It got stuck. Can you hear me? Yeah, I'm so sorry, it got stuck for a while.
So me and Radhika, we are actually, she's my junior from Indlas Hospitals. And we have another junior here as well, Dr. Uday Lakshmi. She's a senior resident at Travancore Medicity. So I already warned her that this would happen. So we can have a small alumni session here.
Thank you, ma'am, for this insightful session. I'm Dr. Uday Lakshmi, working as senior resident in Travancore Medicity Medical College, Kollam. First of all, I'm feeling very grateful for participating in this event, conducting by Dr. Ruben sir and Dr. Radhika ma'am being the speaker, because I have completed my post-graduation from Indlas Women's Hospital, from which both Ruben sir and Radhika madam have completed their post-graduation. And today, on this occasion, I'm feeling very proud being both of yours junior. Ma'am, I have a question for you. During our post-graduation, our mentor, Dr. Vishal Indla sir, used to say that, yeah, definitely it's a bit challenging treating borderline personality disorders, but he used to say that the more the consultant or the more the treating psychiatrist or the therapist is confident on the patient, without losing the hope, without giving up on the patient, the more chance for the patient to improve clinically. So from my personal experience for the past 2 years, I felt that when we explain the scientific basis, the neurobiological basis, the predisposing factors, the contribution of parenting style or the childhood trauma, I felt that I found that it was helpful for the patient to come back for continuing the treatment, and they definitely feel validated. So ma'am, is there anything particular we can do during the initial visits once we diagnose borderline personality disorder? Ma'am, any tips from your professional expertise and experience? Thank you.
Hi, first, so nice to see you there. It's really nice to have a mini reunion there. And it is true, what you said is true. Especially these days, adolescents and young adults, they're previously, even when I was doing my PG, when you give any kind of psychiatric disorder, people wouldn't really be okay with it, despite of their educational status or everything. Accepting the diagnosis took time. But now there is so much awareness about mental health, and they are so involved in their mental health. Even when we are giving a diagnosis like borderline personality disorder, most of them are relieved to know that something is wrong with them, and like their family members or other people might have told them, you're just making this up, or you're just acting a certain way, you just need to get your act together. So when they get a diagnosis, they are quite relieved about it. So what happens is empathy and building a rapport comes first. I've had a borderline patient who sir only had allotted to me when I was first year PG, and I continued follow-ups with her till I finished my fellowship in child and adolescent psychiatry. So nearly 4.5 years she used to come, and we used to do DBT sessions and everything. Such good improvement she had that her family called me during COVID to say she took care of all of them and they couldn't believe this was happening. She had non-suicidal self-injurious behavior, but along with medication, she was willing to put in the work, and she was very happy that someone was actually listening to her. So we just need to validate their feelings in the initial sessions, even afterwards. But in the initial sessions, that is the most important part. Not validating their actions, that we have to tell them what they've done is wrong, but validating their feelings and emotion is very important. And it's a good first step in building a good rapport with the patient. Once the rapport is built, once they know that the doctor is trying to help them, they do come for regular follow-ups, they do continue treatment, and that helps in the prognosis of the disease.
Hello. Ma'am, I'm Aparna Sunil. I'm a final year psychiatry resident at Travancore Medical College. So thank you, ma'am, for a very insightful session. So I would like to ask one question. Often, especially in case of childhood, borderline personality traits, especially in childhood, this impulsivity part and all, it's very, as a psychiatry resident, I often found that, of course, the case itself is very challenging, but it's even more challenging to inform the parents and to inform their guardians and all regarding these things, especially the parenting part. Often the parents do have, as you mentioned in your wonderful presentation, the parenting style all do have a role. So how do we approach them? How do we talk to them about this whole condition? And how, I mean, I know it's a vast thing, but especially the initial sessions, how do we go about breaking the news to the parents and the informants about the prognosis, and how do we tell them what to do in these conditions, especially the parents and guardians? Thank you.
Thank you for that question. I'm still learning, to be honest, because parent to parent, there's a huge difference. We never know which parent reacts which way. So there is no one person answer that I can give. It's tailor-made for each parent. But most of the times, even if the parent's getting angry at a diagnosis, it's mostly because they are blaming themselves at some point, or they're worried that they might have caused this, or they have their own family baggage where someone is trying to understand why this disease happened. So when we inform the parent that not just genetics, sometimes there is no reason, that studies are still being done, why a certain trait develops, why a certain illness develops. So however we psychoeducate them for disorders like autism, like you did not do this, we are not sure exactly which factor causes this. The same works for externalizing disorders also, like ADHD, ODD, anything to do with impulsivity. It's important to have the initial sessions, therapy sessions for both the parent and the child. Maintaining that balance is very important. Obviously, we are always advocates of the child, and the child's health and well-being comes first, but we should also take into account parental fatigue and frustration that have come till point, and any underlying anxiety or depression parent has developed because of this. So talking to the parent, psychoeducating them that there are methods, there are therapies, there are medications which we can give to the child, that there will be good improvement. Reassuring them, psychoeducating them goes a long way. And in child cases, therapy is always the first step. But if medication is required and if medication is indicated, we should prescribe medication. We should discuss the risk with the parents and prescribe medications, because once they see even the smallest improvement, their involvement with therapies also improve. We are all very hesitant when it comes to child patients, even if it's indicated, even if it's severe ADHD, child is 8-year-old. I know many doctors, even sometimes I hesitate to give medication because how will a parent react when there is any side effect and all. But giving medication is also very important. If we show smallest of improvements also, parents become more involved in the therapy process and are more understanding.
We are actually we are honored to have a very senior psychiatrist here with us. ഇപ്പോൾ ഈ ചെങ്ങന്നൂർ സൈഡ് അല്ലെങ്കിൽ കോഴഞ്ചേരി സൈഡിൽ ഏതൊരു പേഷ്യൻ്റ് വന്നാൽ നമ്മൾ അവരിങ്ങോട്ട് ഞാനൊരു ഡോക്ടറിനെ കണ്ടിട്ടുണ്ടെന്ന് പറഞ്ഞാൽ അങ്ങോട്ട് ഞാൻ തന്നെ ചോദിക്കും, പ്രതിഭ മാഡം അല്ലേ? യെസ്, പ്രതിഭ മാഡം തന്നെയാണ്. സോ മാഡം ഡെഫിനറ്റ്ലി മാഡത്തിൻ്റെ ഒരു പോയിന്റ് ഓഫ് വ്യൂ കൂടെ ഒന്ന് പറയണം.
Thank you, Ruben, and also thanking both the chair and the presenter. Both were excellent. Actually, your presentation was excellent. I do like the session very much. Several doubts even I do have, even if I am the senior most, as Ruben said. But I do have certain doubts, and all of them you try to clear within a very short span of time. Thank you. Thank you, Manju, my dear friend. And also thank you, Ruben, for inviting me. Thank you all.
Thank you, ma'am. I wish this could go on, but it's time to wind up this session. And that was the last question. Once again, Dr. Radhika, thank you so much for your clarity, your depth, and your willingness to adapt so that we could keep this session on track.
I want to thank all of you for making this so easy a transition, ma'am. I really wanted to be a part of this. This is something Ruben sir is organizing, and he's been my senior and my friend and a brother since so long. So I'm really glad to have been a part of this, and it's been amazing to watch it since morning today.
Thank you, attendees.
So much,
thank you, attendees, for your participation and your attentiveness in this slightly unusual hybrid format. Thank you so much.
Thank you, ma'am. As a token of love and gratitude, may I request Dr. Pooja Raghunath, Deputy Medical Superintendent and Consultant Microbiologist, KMC Hospital, to come forward and present the mementos to Dr. Manju Pidambaran. And I request Dr. Ruben to come forward and receive the memento for Dr. Radhika MS. Thank you, Madam and Dr. Ruben. This concludes scientific session 3. The lunch is now served. Please return to the hall as soon as possible for afternoon sessions. All participants are kindly requested to proceed for lunch, which is being served in the tent arranged right in front of this venue. You may use this space at your convenience. For our resource persons and chief guests, a separate dining arrangement has been made. May I request the hospitality team to kindly come forward, assist our dignitaries and guide them to their designated dining area. A few seats have also been reserved for our reverend priests. I kindly request the hospitality team to assist them as well. We will commence our next session shortly. May I kindly request all participants to please be seated. May I kindly request all participants to please be seated. We will now begin our next session. May I kindly request all participants to please be seated. We will now begin our next session.
May I kindly request all participants to move forward and occupy the seats in the front rows. Let us fill the gaps so that we may begin this next session smoothly.
Dear all, here we begin our scientific section 4. May I respectfully invite the chairperson, Sister Dr. Jovan Chungapura, and the speaker, Ms. Priya Varghese, to kindly come forward to the stage. Sister Dr. Jovan Chungapura is principal of TRADA, Kottayam, a respected institution for mental health education, counseling training, and psychosocial rehabilitation. Her leadership in academic training, community outreach, and value-based mental health education has nurtured numerous professionals in the field. Sister, we warmly welcome you. Ms. Priya Varghese, clinical psychologist at Breathe Mind Care, Tiruvalla, brings over 12 years of dedicated experience in psychological therapy, mental health counseling, and psychosocial support. She is trained in leading therapeutic modalities such as dialectical behavioral therapy, acceptance and commitment therapy, and emotional focused therapy, making her exceptionally well equipped to guide us in crisis intervention and long-term management of BPD and related disorders. Her clinical and outreach work, spanning adolescents, young adults, and families, has provided support, resilience building, and hope to hundreds of individuals. Ma'am, we warmly welcome you. Ms. Priya, you may kindly begin your presentation.
Good afternoon, everyone. Hope you all are here. We had a wonderful lunch now. Hope we all will be present here, okay? So in this session, we are going to discuss about psychological management, crisis, and long-term borderline personality disorder. You must be aware of borderline personality disorder, and the gold standard treatment is dialectical behavior therapy, right? So what is the features of this dialectical behavior therapy? This helps the patient to balance between acceptance and change. So what is acceptance? For example, if a client is having alcohol addiction and he or she is not ready to accept it, what will happen? The possibility of change will be less there. So DBT helps the client to accept and thereby going to a phase of change. It helps the client to be flexible instead of rigid. It helps to move the client from an all or nothing thinking. What is the other name of all or nothing thinking? Black and white thinking, right? Another name is dichotomous thinking. So what is the meaning of this all or nothing thinking? It means an extreme thinking, right? For example, if my friend is very kind to me today, I start liking the friend and see all the positives of the friend. And I ignore all the negatives and start thinking that this friend will be with me throughout my life. She will be my good friend. And suppose a slight conflict happens after that, what will happen? I start thinking like, oh, this friend is not good. She is manipulative. So all of a sudden, I go to an extreme negativity. So this is a difference. This is a problem a DBT client is facing. So we have to help them moving from all or nothing thinking then we have to help the client see multiple viewpoints. The client may be focused only on the positivity of the friend or the negativity of the friend. So we have to make the client understand that a situation is having multiple viewpoints, right? So when they think about multiple viewpoints, they start living a life which is meaningful, worth living, because they feel if they have a negativity, life is completely negative and they are not going to live a good life. So that extremes should not be there. We have to focus on helping them. Then comes the crisis management of borderline personality disorder. The paramount concern is assessing and mitigating the risk of self-harm or suicide. This includes evaluating the client's level of risk, identifying warning signs, using DBT distress tolerance skills, listing people the client can contact for support, noting professional resources, and ensuring the environment is safe. So when a client comes to us, we have to prepare an action plan. We should not take risk if we are aware that the client is having suicidal thoughts or non-suicidal self-harm or having an emotional vulnerability. So create a safety plan for beforehand. Use it during suicidal thoughts. For example, if a person is having suicidal thoughts, just go through the list of friends he can contact so that he can share her difficulties and there will be help from the friend. Or the list of therapists the client can contact. So review it after any crisis and make changes to the list. Then comes the validation part. Validation means acknowledging and accepting the patient's intense emotional experiences without necessarily agreeing with the resulting behavior. This reduces feeling of invalidation, which can escalate a situation. Validation means showing empathy and connection to the client. Acknowledging pain reduces the escalation in the client. For example, a patient Sarah calls her therapist in a state of panic, saying she is worthless and cannot go on after a minor argument with a friend. The therapist first validates the feeling. I hear how much pain you are in right now. And that sounds incredibly overwhelming. So if we don't validate this client, what will happen? The client's suicidal thoughts will be escalated. There is a natural tendency in the society or in families or even within clinicians that if a client shows a manipulative behavior or shows a suicidal behavior, they start blaming the client. They will say, for example, a parent will blame the client. You are manipulating. You are creating the situation so much worse. So these kinds of sentences after an escalating situation like suicide increases the chance of committing suicide and self-harm. So never ever invalidate the client. Maybe because we are busy with many clients in our clinical setting, we don't have time. So we may not have patience and time to listen to the client. So what we say, we will discuss it next time. So the problem will be the client is very sensitive to the micro expression of the therapist, because the client may see the therapist maybe in a parent phase or an authority phase. So if we don't invalidate them, if we start invalidating them, they start thinking that, oh, this therapist is also like my parent or someone in the past who created trauma to me. So when we deal with borderline personality disorder, there is high chance that we might fail at some points because we don't know which technique is applicable to each client. Through experience we can understand, but still there may be chances of maybe 20% or 10% chances that the client will not be happy with us. So make sure we give as much time as possible. The team has to be coordinated and cooperative when dealing with a borderline personality disorder. There is another term called self-validation. Self-validation means perceiving your own feelings, thoughts, and actions as making sense, accurate, and acceptable in a particular situation. Many clients, even therapists, we think that we are not good enough, or maybe we are not able to treat a client to 100% perfection. There is high chance that we ourselves blame us, or the client has a high tendency to blame themselves. So we should teach them how to perceive their own feelings and thoughts and acknowledge them, accept them, so that they will feel better in a stressful situation. So invalidation means communicates that other person's feelings, thoughts, and actions making no sense, are manipulative, stupid, and an overreaction, or not worthy of your time, interest, or respect. So don't invalidate the feeling of a client. Let's go to long-term psychological management of borderline personality disorder. The major technique is mindfulness. May I ask you, how many of you are mindful now? Are you thinking about something happened 10 years back in your life? Or are you thinking about the fight you had with your partner in the morning? So, how many of you are mindful right now? Can you raise your hands? Okay, some of you are mindful, some of you are not. But it happens, but the thing is, when it comes to borderline personality or emotional dysregulation in ourselves, we have to make sure we are mindful. Because if we start thinking about whatever happened in the past, there is high chance that our mindfulness will be less, and we will start suffering in the right present moment also. So are you all happy right now, or life is miserable thinking about whatever happened 5 years back? I hope all are present here, right? Hope no one is sleeping. Okay, so mindfulness means throw yourself completely into the present moment or activity. The primary reason to teach mindfulness is to counter emotional dysregulation, a core feature of borderline personality disorder. So are you ready to do a mindfulness exercise? So this is called 5, 4, 3, 2, 1. You have to name 5 things you can see right now. You don't have to say it aloud, just in your mind. 5 things you can see right now. For example, I see the light reflection on the floor. Only 5 items, not more than 5. Because when we ask the client, they may have a tendency to say 10 or 20 because they are not aware, not mindful that we ask for 5. Now, 4 things you can touch. The chair, your book. Are you able to touch 4 objects near you? And 3 things you can hear. The AC sound. Are you not hearing anything? Are you hearing your mind voice? No? No. Anything in the physical world, right? Okay, I know you can hear the sweet voice of your presenter, but focus on much more things, okay? So, 2 things you can smell. For example, I smell the slight scent of perfume on my clothes. Or think about your favorite smell. Now, 1 thing you can taste. If you have a chocolate with you, you can taste now. Or think about your favorite taste. I know you will say biryani if I ask you. How many of you like biryani? Nobody. Okay. So, next is distress tolerance skill. The goal is to help you get through an intense emotional crisis without making the situation worse, without self-harm, substance use, or rage. So the technique is temperature change. There is a skill called TIP skill. T stands for temperature. Change your body temperature immediately using cold water. This automatically slows the heart rate and calms the nervous system. You feel a surge of rage after a frustrating phone call. Have you had that today after a frustrating phone call? No, I think, no? Sometimes it happened to us. So what we can do is we can hold a bowl of ice water and plunge your face into it for 30 seconds. Or alternatively, we can hold an ice pack tightly against your forehead. So these techniques, when we describe to the client, we should encourage them to do it in the therapy session itself. Because most of the time, we advise them, you have to go home, do this when you have a difficulty. But most of the time, the clients, not only the borderline personality, every clients, they are not motivated to do it by their own because of the lack of motivation, depressive feelings, because of the lack of support in their environment. So make sure we make them do it in the therapy sessions itself. We have to demonstrate it. Then intense exercise. Engage in physical activity for a short period of time. You feel restless, agitated, and have a strong urge to use a substance after a fight with a partner. Do 50 jumping jacks or run up and down a flight of stairs 5 times until your body is physically exhausted. So we have seen similar things in many movies. When the hero is not okay, frustrated by something, he punches on the punching bag and relieve his stress. So try to be a movie actor or someone when you are in a distress. Then paced breathing. You are having a panic attack and your breathing is slow and rapid. Breathe deeply into your belly. Inhale for 4 seconds and exhale for 6 seconds. Focus only on the count until your body feels calmer. So, are you ready to do this? If comfortable, close your eyes. When you breathe in, count from 1 to 4 in your mind. And breathe out, count from 1 to 6. So, be mindful. Focus only on the counting part. Hope you are able to focus. This thing we can do during anxious situation or we are in a distress. Then paired muscle relaxation. For example, you are sitting in a CME, tensed and trapped. Are you feeling trapped right now? No? You are comfortable, right? So if you are in a meeting and you are tensed, then tense all the muscles in your arms and hands as tight as you can for 5 seconds, like this. Tense your hands and slowly relax it so that the muscle tension will be reduced and your mind will also get relaxed at that moment. Then accept skill. This is for distraction and focus change. A stands for activities. Engage in enjoyable or absorbing activities that require focus. For example, recently a client told me that he had a fight with the spouse. He was already in DBT, so he was aware that a middle path should be there. There should not be all or nothing thinking. And what he does was he assembled an IKEA furniture. So if he just suggest a client who is going through distress for the first time to do this, he will not do this because he is not aware that this will change his mood. So through practice only, the client will be motivated to do these activities. If the client is with us in a hospital, we can teach this thing. Or through a continuous training, the client will be ready to do some activities to deviate the mind. For example, cleaning the garage or play an online game. And C stands for contributing. Shift focus outward by helping or giving back to others. For example, had a fight with a partner and feels partner doesn't care me, and what I have to do is I have to engage in other activities like volunteering for a shelter home or cook a meal for a friend, because if I focus only on my partner, that will create a lot of stressor. Maybe because my partner itself is busy with his own work or any other stress. So better I deviate my mind. And once I deviate my mind, I will be able to understand the reality and logically deal with the situation. And then comparisons. Compare your current stress to times you have been in similar situations and you survived. And those who are less fortunate, most of the time, if we compare ourselves to people who are less fortunate, that could help us. But when in DBT, for the first time, if we say this thing to the client, he may get offended because he feels he is the person going through a lot of extreme stress, and if we say this thing, he may feel invalidated. So based on the client's mindset only, we have to give the techniques. Emotions. Do things that elicit different emotions. For example, listen to a music or funny video when you feel stressed. Pushing away. Imagine that putting the memory thought into a box, sealing it, and saying to yourself, I will deal with this tomorrow at 4 p.m. Then thoughts. Focus your mind on an activity that requires intense concentration. Work on a challenging Sudoku, calculate complex math problem. Then sensations. Use intense physical sensation to shock your system back to the present moment. For example, take a cold shower, snap a rubber band on your wrist, or eat a food with extremely strong sour or spicy taste. If you try lemon, what will be the sensation? It will create an intense sensation, right? If we are not mixing any water or anything, sweets or anything, then it will be an intense sensation. Have you tried wasabi? It's a Japanese dish made from wasabi plant. It's something like a chutney, green in color. So I have tried it once I went to Cochin. The thing is, I just put a very small drop on the tongue, and for next few minutes, I forgot the world, even myself, because it was too intense and very spicy. So these kind of different experiences could help us to change our mood, deviate our mind from the distress. Because especially in borderline PD, they don't have anyone to support. Maybe therapists are the only people for them to support them. So train them this way could help them. Then accepting the reality is one of the major thing. Suppose the client is having trauma, had a bad parenting. If he or she is not ready to accept, what will happen? The thing is, the distress will be high, the life will be meaningless and difficult to live. So better we have to teach them to accept the reality. Yes, we can use the techniques like half smiling. Have you tried this before? Half smiling technique means gently lifting the corner of your lips. Not a big smile, just a soft, slight one. Have you tried this? Suppose if we have to accept something in our life, we cannot change. No one can change. Only thing is we have to accept it. So what we should do is, or what we should teach the client is, we have to teach them half smiling. Can you try it now? Think about something. I don't ask you to think about the traumas because so just think about something. For example, I have anxiety. I think you are getting idea that I'm having anxiety right now. So if I have anxiety, I have to accept it. Accept it by smiling. This half smiling means I am accepting the reality and ready to change. Then we can do a posture like willing hands. The willing hands posture, can you do it now? Turn your palms upward, open and loose. Keep your arms relaxed at your side on your lap. Relaxed. No tightness should be there. You have to relax your hand. We should encourage the client to accept the fact that maybe he or she doesn't have a good parenting. So accept it like this. So you can also use these techniques when you are at home, not right now. So it should not trigger any traumas right now. So that is why trauma treatment means we have to be slow. We should not do it in 2 minutes or 5 minutes. Then how to regulate emotions? For that, we have to understand and name the emotions. observe and describe. For example, if I feel angry, I should be able to observe and describe it rather than just saying I feel bad. I should have a proper idea about what I am feeling right now, what is causing distress to me. So understanding that emotion, what that emotion is communicating to us. Fear tells you there might be danger. Anger tells you a goal is being blocked. So we should have understanding about our own emotions. Then how to reduce emotional vulnerability. When you are well rested and physically healthy, you are less likely to experience mood swings and intense emotions. So teach these techniques. ABC, please. A stands for accumulating positive experiences. For example, today I got triggered by my trauma memory. I have to focus on creating something new, some positive experiences. Like for example, if I go for a walk or spend time with my dear friend, that could accumulate positive experiences. Then encourage the client to build mastery in some skill or do a course, because most of the time the borderline personality cases, they are being blamed by everyone. They always hear that you are good for nothing, you have gained anything in your life. So to overcome that negativity, that blaming from others, the client has to build some skills, learn something new, and show the world that he can also build his life. Then cope ahead of time with emotional situations. For example, if I am having an issue with an auntie and I am going to a wedding function, that auntie is present there, so I have to plan ahead. She will come to me and blame me for whatever happened before 10 years. So I have to make sure I have to have escape plans. For example, if she come to blame me, I have to tell her that, oh, I have to call my colleague, it's an urgent call. Or I have to pick a photo with the bride and groom. So this way, we have to deviate. Okay? I know you are very good in these things, but still, okay? So then treat physical illnesses. Because in borderline PD, they don't treat themselves in a good way. If they have illness, they will neglect it because they feel, I am good for nothing, why should I treat myself better? So, but if the physical illness is there, the chance for vulnerability, the mood swings, anger, everything will be high. Then have a balanced eating. Avoid mood-altering drugs. Have a balanced sleep. Have a sleep hygiene. Avoid using phone at least 1 hour before sleep. We have to stop it before 1 hour. Then have a schedule every day. Sleep in a particular time and wake up at a particular time and get good exercise. Then how to change unwanted emotions. So for changing unwanted emotions, we have to check the facts and solve the problems. So ask yourself some questions. For example, partner has not replied for 2 hours. Interpretation may be, he or she doesn't love me anymore. So remember, interpretations are not facts. Then ask yourself, are you thinking in extreme all or nothing thinking? You may be feeling that she is leaving me. So question yourself, what is the possibility of the worst happening? It might be low. Partner has done this before during work hours and nothing bad happened. If the worst happened, could you cope? Yes, I have friends, therapists, skills. I would not collapse. So these kind of checking the facts and problem solving is really important. Then do opposite action. For example, if you are feeling sleepy now, what is the opposite action? Get up, right? So this is opposite action. If you have fear, what you should do? You should not avoid. Avoidance is the natural tendency we have if we have fear. If we have anger, we have a tendency to attack. If we have sadness, tendency to withdraw. Shame means hiding tendency. Jealousy means acting suspiciously, verbal accusations. So opposite action means break this cycle. Fear, if there is fear, approach people, places and activities. If there is anger, gently avoid the people, take deep breaths, be kind rather than attacking. If you have sadness, increase pleasant activities. So this pleasant activity scheduling you can see in CBT also. Then if you have shame, apologize and repair the harm. Jealousy, we have to stop spying, relax our face and body. Next is interpersonal effectiveness. This teaches how to get your needs met, maintain or improve your relationship, and preserve your self-respect. So, dear man skill for objective effectiveness, the goal is to maximize the chances of successfully achieving your specific objective. For example, getting a request met or having a no accepted. So, most of the cases of borderline PD, they don't show readiness to describe. They just walk away. Why? Because in their childhood, maybe they have tried to make their parents understand their situation and their parents were not ready to listen. So this gave a wrong understanding to the child that if something happens, I should walk away. If somebody says no to me, I should reject that person. So encourage the patient to describe the situation factually. Express your feelings and opinions clearly using I statement. For example, if I say my partner that you are creating problem in my life, what will be his response? He will get offended, right? So I have to use I statements. I am concerned about our relationship. I want this to work in a better way. So use I statements. I think someone is looking at their partner. So try the I statements. Then be assertive. Say it clearly. You don't have to fear anyone if you are telling the truth. Then reinforce or reward the other person. For example, the partner is ready to listen to you. Then give positive consequences or appreciate him for being supportive to you. So these kinds of things are really important. Then comes mindfulness. Stay mindful when you describe the things. Don't think about anything else. Only think about the current point. Then appear confident and effective. Use a steady voice, eye contact, and confident posture. And try to negotiate. For example, this time you may not be able to convince your partner. Next time you can convince. So try to negotiate. Offer alternative solutions. If this thing will not work, we can try another way. Then for relationship effectiveness, give skill. Goal is to maximize the chances of keeping or improving the quality of the relationship during the interaction. So if you want to improve a relationship, be gentle. Use gentle language and tone. Avoid verbal attacks, threats, sarcasm and judgment. So sometimes people think that if I show dominance, my partner or my friend will be listening to me. This is something like a wrong notion. So be gentle with them and interested. Act interested in another person. Listen to their point of view. Ask questions. Maintain focus. So we have to show interest in the other person. Then validate. Validate or acknowledge the other person's feelings, needs or opinion, even if you disagree. Because when one person is in distress, if we invalidate them, they will not come to us anymore. So even if we cannot accept whatever they are telling, just try to at least listen to them. This will improve the relationship. Then in an easy manner, use a light-hearted, calm and easy manner. Don't be overly intense or aggressive. So this could help the relationship work better. Then self-respect effectiveness skill, that is fast. The goal is to maximize the chances of keeping or improving your self-respect and integrity throughout the interaction. Fair. Be fair to yourself and the other person. Advocate for your needs while respecting their rights. So for example, if a friend, your close friend, asks you to say a lie to someone else, what you should do? Be fair to yourself. So to the other person is difficult because that is against our morale. So be fair to yourself. Avoid apologizing unnecessarily. Example, apologies for making a request or having an opinion. If you don't want to say that lie, you don't have to apologize it. You can say that, sorry, I can't do this. This is against my values. Then stick to values. Stick to your own values and beliefs. Don't compromise your integrity to get a short-term outcome. Then be truthful. Don't lie, exaggerate, or act helpless, making up excuses or minimizing your own competence. So keep your self-respect and teach the clients to keep their self-respect, because they lack all these skills, because they must be having poor social interaction or care from the family and the dear and near ones. So teach all these skills for a better living. Then can I ask you, how many of you are self-compassionate, are kind to yourself? Because most of the time, only two people are compassionate to themselves. 3, 4. Why are you not compassionate to yourself? You can show much more kindness to other people, but when it comes to ourselves, we can't. Why? Maybe because what? Because of the wrong understanding about ourselves, or maybe that is what we learned from our elders. We should be compassionate. We have to show compassion to others, not to the self. Most of the perfectionist personalities believe that if they show kindness to themselves, they will not do anything. They will be demotivated. So that is something like a wrong understanding. So be kind to yourself. So we all have an inner critic in ourselves. The role of the inner critic is to improve ourselves. But when we always listen to the inner critic and blame us, what will happen to us? We will definitely go to depression. We will lack all motivation. So the inner critic in borderline personality disorder is highly punitive and hostile. It says, you are a monster. You are worthless. This fuels intense shame in the client. Shame drives maladaptive coping behaviors like self-harm, splitting, impulsive actions in borderline personality disorder. So self-compassion or compassion-focused therapy helps the client to replace the inner critical voice with the voice of the compassionate self. For shame and self-criticism after a mistake, the client can say to himself that, I made a mistake, but I'm not a mistake. My value is unconditional. I choose to offer myself the same understanding I would give a dear friend. For managing the inner critic, the voice of my inner critic is an old, fearful voice that is rooted in pain, not truth. I choose to listen to my strong, wise, compassionate self instead. So, can you all take a moment, close your eyes, and talk to yourself in a kind voice, even if you have made a mistake, or even if somebody blamed you, that's fine. Being kind to yourself is something that is really important for a better living, for a better functioning. Okay, thank you.
Thank you, Ms. Priya, for the practical, compassionate and insightful session. May I now invite Sister Dr. Joan Chungapura to share reflections and lead the segment.
Thank you, Priya. You did a marvelous presentation. Thank you, Father Kodarathilachan, and also Bibinachan and Dr. Ruben, and others who invited me. I am very happy to be here. First of all, because Kodarathilachan is part of TRADA. Secondly, mental health ministry, one of the pioneers I happen to be. It is God's choice maybe. Now when Priya was presenting, I was thinking, all these techniques could be taught in the school. Somebody was asking question, how to prevent borderline personality going into a disorder. It starts as a style and then only it becomes a disorder. It doesn't happen to be a disorder from the very beginning. That need to be emphasized. So as social workers and counselors, we have a big role to prevent in school counseling with the teachers, with the parents, what Priya was telling and showing all these simple techniques. From the age of 8 onwards we can, so we can prevent. You are really, it's a good step. Okay, then another importance I noticed. I was talking to Father Kudarathil also. See, mental health doesn't give much attention. Even in Kerala, we give importance only to physical health. But will any person be happily alive without mental health attention? So this kind of a seminar is a big opening to have a focus on mental health, mental well-being. Mental health and mental well-being is not only preventing diseases or disorders, it is enhancing happiness and adjustment in life. So, actually what Priya was talking was all that. Because when we sit for counseling, we see from the age of 8, children with the symptoms of this narcissistic style, borderline style, everything is there already. Telling lies, stealing, bullying, all these are already in style. Don't wait for a disorder to happen, isn't it? Yes, that is another thing. Then let us have a holistic approach. That's what she did. A lot of lifestyle has to be changed. Not only medication and therapy, even parents and teachers and students need to be educated on lifestyle change. So that healthy lifestyle and a holistic approach. You see, nobody can accept any defect or disease when it occurs. It is not freely chosen. We all saw the causative factors. 2/3 are outside of the person. Parenting and genetic factor, environment, isn't it? Yeah. So we need to be compassionate to this person who is suffering. Instead of calling somebody as a bipolar or a borderline, we don't call anybody typhoid or diarrhea, isn't it? We don't. In the same way, in the mental health field, let us also talk about as a person suffering from even committing a suicide. We don't these days say, in Western countries at least, committing suicide. No, the person suffered from suicide. It was a death of suicide. You see, the language itself has changed, the attitude. The attitude towards mental health need to be positive and encouraging and accepting, isn't it? So this was very good in that way also. You touched a lot on lifestyle. The diet and the sleep habit and the recreation and the exercise. Maybe one more thing what we can accept is, whenever there is a vulnerability in a personality or life, she said, acceptance journey, it is not that easy to accept. If you give a spiritual perspective of self and life, it is easier to accept, isn't it? There is somebody who is in charge beyond me. There is somebody who created me for a purpose. Not only the mentally healthy as saints, even the mentally challenged and sick also are saints, isn't it? Yes. So give them a spiritual perspective about life and their own self. Yes? That will make it more holistic. And now we need to call it again. No total healing happens in any sickness or in any condition in life. Death is the only final healing. So why do we approach mental sickness as hopeless cases, lifelong cases, beyond cases? Never talked like that, isn't it? That at least as mental health professionals, we always have to give them a hope. Any reasonable way of adjustment and functioning is enough. Enough is enough. Good enough, isn't it? There is no perfection in life as such, as a human being. So that also is good, isn't it? So she has really covered in a nice way, in a holistic way, and also we also are really happy that this Cherian Hospital, KMC, has put up a mental health seminar, especially on addiction and borderline personality disorder. Many addictions from childhood onwards we can identify. Eating sweets, using mobiles, eating too much, telling lies, collecting things, we can already identify the style in the persons. So we can really help prevention and promotion. Thank you for that. Thank you. Do you have any questions on this subject?
ഞാൻ ഇതുവരെ നമ്മുടെ ഈ ഇൻസ്റ്റിറ്റ്യൂഷൻസുള്ള കുട്ടികളെ ഇതുവരെ പിടിക്കാതിരുന്നത് എന്നോട് പറഞ്ഞു നിങ്ങളെ പിടിച്ചാൽ നിങ്ങൾ ഓടിപ്പോവും. എന്തായാലും ഇപ്പം ലഞ്ച് കഴിഞ്ഞ് നിങ്ങളോട് ഉണ്ട്. സോ ഇൻസ്റ്റിറ്റ്യൂഷൻസിൽ നിന്ന് സ്റ്റുഡൻസ് ആരും നിങ്ങൾ തന്നെ സെലക്ട് ചെയ്തു. ഞാൻ പറയുന്നത് നിങ്ങൾ ഒരാളെ SP കോളേജ് ഉണ്ട്, ട്രാഡ ഉണ്ട്, ആരെങ്കിലും ഒരാൾ നമ്മുടെ ഇൻസ്റ്റിറ്റ്യൂഷൻസ് സ്റ്റുഡൻസ്. ക്വസ്റ്റ്യൻ വേണ്ട, നിങ്ങളുടെ ഒരു അഭിപ്രായം, നിങ്ങളുടെ ഒരു ഒപ്പീനിയൻ ഇവിടെ നന്നായിട്ട് പ്രോത്സാഹിപ്പിക്കുന്നുണ്ട് ഇവിടെ. അപ്പം നമുക്ക് തന്നെ ഒന്ന് പറയാമല്ലോ, വേണ്ട? ഓക്കെ, ഫൈൻ. പിന്നെ ഓൾസോ വി ഹാവ് Dr. Marisa Joseph. She's our what we call an early career psychiatrist. So it's very important for actually Priya and me, like, we're very close friends. But I got to see Priya in action. I got to see, like, our slides kandapam, how beautiful those slides are. നമുക്ക് അതിൽ നിന്ന് നമ്മുടെ കണ്ണ് പോത്ത് പോലും ഇല്ല. So today I got to see Priya in action. I understood why she's really good at what she does. So the other thing is, even as psychiatrists, we have to know DBT principles. എല്ലാം ചെയ്യണ്ട, but DBT skills, some things we do have to know. Allada, we can't be like a patient comes in crisis, you can consult a psychologist telling social work and a counselor or 5 days from now. You have to teach them certain things because rapport is important. So that's why it's very important, as you know, start early career psychiatry. There's nothing wrong with doing a DBT course. Absolutely nothing wrong with learning a few skills. Dr. Marisa, just your opinion about DBT, your opinion about the session.
Session approach through the much holistic way, so we can deal within practical ways through these methods.
Sorry, can you repeat?
A session was kind of a holistic way.
Okay.
By dealing with the practical approaches.
Yeah.
Practical approaches rather than theoretical.
Sorry, you want to hear the?
No, session you led was kind of that.
Okay.
അടിപൊളി സെഷൻ ആയിരുന്നു.
It was practical, that's what she said.
പിന്നെ ഡോക്ടർ ഫെമിന, ഓക്കെ, മാഡത്തിന്.
Thank you. First of all, I would like to thank you for such a wonderful session. And just like she said, the session was very informed, as it will be very easy to put it into practice. So as in our field of practice, each and everything you said and how to do it, and the step by step how to approach the patient and make them aware of their own difficulties, and that was such a very good practical session for us.
Thank you. She really deserves a lot of appreciation.
I'm CG Anthony, representing TRADA. The first time I was exposed to so much practical tips, one after another is coming.
Right.
So congratulations for that. My question is, in the initial presentation you have referred DBT, acceptance and change. Only that much acceptance and change, or something more in connection with DBT?
Yeah, because only if the patient can accept the faults or accept the whatever negativity or anything in having in life, they can change their life. So we have to encourage the client to live a life worth living, because they feel their lives are not worth, because they have heard a lot of negative comments from everyone throughout their life. Maybe at their 30s, they are hearing for the first time they can live a life which is meaningful. Maybe many people, they have never heard of living a worthful life because nobody has guided them. So maybe as therapists, maybe we are the first people who encourage them to live a best life. So DBT is actually, I think it's easy to preach, but difficult to teach. Because the skills are really simple. Washing your face, this is very simple for us. But doing it during the distress period, that is something really difficult. And even for clinicians, it's difficult. So teaching them a case who is having a borderline personality disorder is something much more difficult. But through practice, through different sessions, through validation, we can teach them these techniques.
Actually, besides DBT, there is MBT. Already Dr. Varghese Punu said that mentalization-based treatment. In that, these people are lacking empathy. They jump into conclusion and judgment about others' behavior, purpose, attitudes, motivation. They jump into conclusion. That is why they react very fast, very impulsively. They say any nonsense. They may even abuse the person or kind of hurt the person even. But in mentalization-based treatment, the person is taught how to reflect on one's own need, one's own values, one's own feelings, one's own thoughts, one's own wants. You see, the more they can reflect, self-acceptance is taking place. Once you accept yourself, to accept another is easy. So this mentalization-based technique is also there in the DBT. And also FPT, that is again transference-focused therapy is there. She already said in the beginning, a rapport is formed and a confidence is created in the client through the empathy, love, firmness, positivity and compassion and listening of the therapist. So there is a transference-focused psychotherapy is also happening there. Whatever they missed in their childhood, abandonment or neglect or any kind of abuses, they will react to the therapist, but the therapist will be acting in a very firm and even-tempered method. So that is another way of making the person to accept that they have difficulty in handling their emotions. Their reactions are rather impulsive and judgmental and critical because of the avoidance or the fear of avoidance or neglect or abandonment. They are really repeating. Again, another is schema therapy is said. That is system training, emotional predictability, presenting therapy. That is also at least 20 weeks of intense therapy is needed for making a person to accept a new method or a new habit of living their life in interpersonal skill. See, because of time limit, she could only take on interpersonal skill. It is the same skill, but somebody has to supervise and make them to interact in a peaceful manner. Then EFT is their emotional freedom technique. Then massaging therapy. In India, actually, we have massaging therapy, we have water therapy, we have mud therapy, we have vegetarian salad alone treatment. Everything that cools down the body and mind is helpful in borderline personality disorder treatment. So, it is a long-term attempt and she is handling the cases. Thank you.
Thank you, ma'am. May I invite our Reverend Father Dr. Alexander Kudarathil, MD KMC Hospital, to present mementos to Sister Dr. Joanne Chongapura. And Miss Priya Varghese as a token of our gratitude. Thank you, Father. Thank you, Sister Joanne. And thank you once again, Ms. Priya. This concludes scientific session 4. Dear all, here we begin our final scientific session. May I respectfully invite the chairperson, Dr. Anuj, and the speaker, Mr. George Matthew, to kindly come forward to the stage. Before we begin the session, it is my honor to introduce our chairperson for this final session. Dr. Anup G completed his MBBS from Government Medical College, Kottayam, and his MD in Psychiatry from Jimma Tirucheri, one of India's most prestigious institutions. He has been serving in the Kerala Government Health Service since 2012 with exceptional commitment to public mental health. He has been actively involved in community mental health program from 2013 and in palliative care since 2015. He also served as the nodal officer for the district mental health program Ernakulam during 2019 and 20 and was selected as one of only 16 psychiatrists nationwide for the early career psychiatrist leadership program under NIMHANS in 2020. An honor reflecting his leadership and clinical excellence. His areas of interest includes community psychiatry, addiction psychiatry, and palliative care. We also place on record our deep gratitude to Dr. Anup for graciously accepting to chair this session at short notice in the absence of Dr. Radhika. Thank you, Doctor, for your support and presence today. Ladies and gentlemen, please join me in welcoming Dr. Anup Ji. Mr. George Matthew, Director of GM Life Counseling and Care, Chengannur, is a distinguished family therapist and counseling psychologist with years of dedicated practice in psychological counseling, marital and family therapy, life skill development, and community mental health awareness. He has guided numerous individuals, couples, and families through relational difficulties, addiction recovery, and personality disorder challenges. His family-centered practical therapeutic approach has been instrumental in community-based mental health service and training. Sir, we warmly welcome you. Sir, you may kindly begin your presentation, please.
Good evening. And this is the last session, and the seats are becoming empty. Many people disappeared, and I know this is very challenging for me to take the last session. Everybody is tired, and many are looking at the watch and ready to go home. Okay, anyway, I will try to present the paper, the topic on family-based approach to borderline and addiction treatment. So when you look at this screen, and this is the outline, what I am trying to present. Okay, you see a picture here. This is a postgraduate doctor and living with a borderline. This has happened in the maybe within last 2 weeks. I'm just presenting this picture so that you may understand. And everybody was talking about the treatment. And there is another group of people, those who are living with them. They are going through immense suffering and pain. And then if you can read the next 2 slides, this is written by the daughter of the same person. and who witnessed her mother was locked inside and beaten badly, and all this injury you see is the marks of biting. It is not punching, it is a mark of biting. And you see the writings of an 11-year-old girl. And she is written like this: I felt like my whole world had flipped upside down. 1 second everything was normal, and the next it felt like the floor just disappeared under me. My chest got tight and my breathing went all weird, and my hands wouldn't stop shaking. It was like my body was scared before my brain even understood what was happening. This is the writings of this 11-year-old girl when I asked her to express her feeling in writing. And from this writing, I will proceed with my presentation. I felt frozen, like I wanted to run, scream, stop it, do something, but my legs wouldn't move. I just stood there, trapped between wanting to help and being terrified of what would happen if I did. I felt embarrassed too, even though I didn't do anything wrong. It was that awful feeling where you are like, why this is happening in my family? Why do I have to see this? And then you feel guilty for even thinking that, which makes everything worse. One more slide. I felt protective of my mom in a way that hurt, like I wanted to shield her even though I am not an adult. And that made me feel even smaller because I couldn't fix anything, no matter how much I wanted to. I felt numb at times too, like everything was happening too fast and too loud, and my brain just shut down and to survive it, almost like watching a nightmare from outside my body. Later, I felt this long, deep ache in my chest. Not just sadness, but that tired kind of hurt that stays with you even when everything goes quiet. I kept replaying it in my head, wondering if I could have done something, even though deep down I knew it wasn't my job. Okay, this is the story of an 11-year-old girl. After witnessing the brutality of his father, who is also a postgraduate doctor, and who is suffering from borderline personality, unfortunately, this child was brought to me for therapy to help with the interpersonal trauma. And I am trying to help her. So, with this story, I am trying to present the importance of family therapy. The people, those who live with them, those who may intensify their addiction or borderline personality disorder, or may aid in recovery. So family therapy is essential because both addiction and BPD are relational disorders in significant ways. Addiction affects family trust, communication, boundaries, and role. Whenever a person is addicted with alcohol or affected with a borderline personality, this affects the individuals, those who are living with them. That also affects their mental health, the way they handle or respond to the situation. And that is why I presented the picture and also the write-up by that girl, little girl. People is deeply influenced by the attachment patterns and emotional instability and relational triggers. And they are always fluctuating between the moods, different attitudes. When both coexist, the family system becomes strained, chaotic, or emotionally exhausted. So sometimes the borderline personality may intensify the addictive behavior. Sometimes both, when they are together, the people, those who are live with them, they suffer most. Therefore, treating the individual alone is insufficient family involvement improves the outcome, the treatment outcome. Okay, from this one, before dealing with the therapy goals and how it helps, I am moving into something that is not normally diagnosed as part of in the psychiatric treatment. Okay, but it is there when the therapist and the counselor, when they work with addiction and addiction recovery, and also with the borderline, you will see that this terminology, codependency, and we just heard from Dr. Joanne Chungapura. I heard this terminology from her for the first time when I listened to her on addiction at Trada. Okay, what is codependency? Codependency is a common relational pattern seen in families of individuals with addiction or BPD. It involves an excessive reliance on the affected person to maintain a sense of identity, purpose, or emotional stability. Codependency, the people, those who live with people, those who are affected with addiction, and they try to, adopt a different kind of personality and behavioral patterns. Family members may revolve their lives around the individual's needs, crises, and moods, often losing sight of their own well-being. The key characteristics include, there is a big list I added, mainly the purpose is to have a better understanding of the feelings and how the family members or those who are associated with the addicts or BPD patients affected, and the understanding will help us. Okay, the characteristic pattern, I am not going to read all the details. The law is self-esteem and self-worth are tied to the others' well-being. They lose themselves, their identity, their dreams, their ambition, their personality, everything. Exaggerated sense of responsibility for others. Then the other one, caretaking and rescuing behavior, even when it is unhealthy. The difficulty setting or enforcing healthy boundaries. Okay, all these PowerPoints will be shared, I think, so you can, you can listen. So the boundary is very important for a family. Every functional, every healthy family knows where to draw the boundaries. People pleasing and seeking approval and validation. Fear of abandonment or being alone. This is another issue. This is not talking about the BPD patient or addict. This is talking about the people, those who are living with them. And then they neglect their own needs, identity, and self-care. Then there is emotional dependency and enmeshment, and on whom they are depending. They are depending on the addict or the BPD patient. Control or over-involvement in the other's life. They try to interfere and try to restrain, try to restrict, and that increases the problem. Poor communication and suppression of honest feelings. And they cannot express, they cannot communicate. Then emotional reactivity. Once they are exhausted, then you will see that they are outbursting, getting irritated. Emotional reactivity, guilt, resentment, and burnout. Then difficulty in trusting oneself, decision-making problem. I come across with many people, many partners, even to this person. Okay, you had seen the picture. I asked that. This person met me in 2021. And last week, she contacted me to help the child after having all this severe injury, and her leg was twisted and ligaments were torn, and she was unable to walk for nearly 2 months. and there is physical, emotional injury, and also the trauma inflicted on the child. I asked her a question, why you stayed so long instead of responding to situation? And she said, I thought I can change him. I can help him to come out of it. Okay, we talked about the acceptance. As long as the addicted person or the BPD patient not accepted the reality, it is almost impossible to change. Okay, without acceptance. Okay, but the people will take the responsibility to, and they lose their identity, their capacity to make decision. Then, because of repeated exposure to this kind of experience, hypervigilance and constant anxiety and other crises, anxiety about the issues they go through, obsessive focus on the other person's problem. They forget about their problem, how much they suffer, but their criteria is the other person. Confusion between love, pity, and responsibility. Then difficulty with the intimacy and healthy emotional connection. Okay, then I will go to, switch back to the core goals of family therapy. Okay, we had seen that different therapy, even the dialectical behavioral therapy, different therapy, and I borrowed the principles from 5 or 6 different therapies. The main purpose is to improve. You had seen that how the family is affected and how the family is in the loop and they cannot come out of it. So the main purpose of the core family therapy goals for those who are addicted and BPD is mainly to improve communication and replace blaming, shouting with expression of one's need. Then teach assertiveness without offending, provoking, without irritating, how to communicate what they wanted to communicate. And non-reactive dialogue is encouraged. Then second goal is to strengthen healthy boundaries. Avoid enabling addiction. Second one, reduce unhealthy dependence or emotional fusion. In family counseling, there is an emotional fusion, and that is, the clients are encouraged to work on that to reduce. Then build emotional regulation skills in the family system. Families learn to respond rather than react. Usually because of the stress-causing situation, everybody is ready to react and respond. Reduce triggers for the emotional dysregulation. And emotional dysregulation is one of the, dominant characteristic traits in the BPD. Repair trust and reduce conflict. Create safe relational patterns. Teach conflict mediation and forgiveness process. And then the fifth one is to break the crisis relapse and the conflict cycle. Family therapy stabilizes the environment, reducing triggers for the relapse and BPD episodes. I had shown a picture, and at the same time, I also work with another BPD client, and she's a BPD, and she married to another BPD who is also using cannabis. So last August they got married, and her condition is also almost the same as you had seen in the picture. But she cannot go away because of the abandonment anxiety. That is another condition that is manifested or that is seen in the BPD patients. They cannot leave a relationship even though they know this is going to be damaging, destructive. Okay, that is why just to give, I didn't go through all the detailed list. That list will be shared. That is what I know. Okay, how the family therapy helps when both disorders coexist. We were talking about the BPD and the addiction when they exist together. When addiction and BPD coexist, the interaction between both disorders damage the family. You know the chaos you had seen. More fight, and when somebody triggers, then there is more emotional dysregulation. Sometimes to control that or to deal with that one, people may use substance or alcohol. Substance use, broken trust, and triggering abandonment fears, then emotional storms. Okay, when it is used when it is both exist, it helps to reduce the chaos and emotional overload. BPD episodes often lead to emotional storms. Addiction, relapse lead to crisis. Family therapy helps everyone maintain stability. And it also helps to reduce enabling and codependency. Now we talk so much about codependency. Family learn not to cover up with the person's addiction. That is part of codependency. They try to cover up, they try to excuse. And sometimes they know that it's very destructive to the family, destructive to the children, those who are with them. But even then they try to cover it. They try to protect the person, those who are affected. Not to rescue them from the consequence. Not to reinforce the emotional manipulation. Then the third one, address the trauma and the attachment wounds. It is found out that in both conditions, maybe there are childhood trauma or attachment ruptures that resulted or that led to the addiction or the borderline personality disorder. So family therapy brings healing, conversation, accountability, and trying to repair. Mainly the family therapy working with the individual to identify how they contribute, how they aggravate to the addiction. Usually the people will question, they try to block, they try to prevent. But as a reaction, when I was going through the training and at the TRADA, and the first thing said, don't try to check on a person who is trying to stop addiction. If somebody is coming late, and don't try to go and smell whether they have taken alcohol. That is long back. I learned that with any behavior, we should not encourage or provoke the person to continue with their. There is a advertisement of an agarbatti. That agarbatti says to pray. There is a reason, any reason. The same way, the addict may use that any reason to continue with their behavior. Okay, reduce relapse and hospitalization rate. Family therapy can help the families or the individuals, those who are affected. And the studies show that family-based program reduce relapse, decrease self-harm incident, because the family become a place where they are accepted, they are being heard. This is not a provocative or encouraging situation. Improve emotional functioning. Okay, then we will switch to the different therapy approaches. Okay, we heard about the dialectical behavioral therapy. That is also the family adapted version is also included in my presentation, but I'm not going to do that one. In the structural family therapy, it's mainly talking about creating a structure. So the main focus will be on the boundaries, hierarchy, and because in addiction and also in BPD, there is a chaos. There is also over-involvement. There is no boundaries observed. There is enmeshment. In family structure therapy, the clients are taught to deal with that. And then key intervention, strengthening the parental caregiver subsystem, reducing the enmeshment too close or too engagement. Okay, you are doing it, you are not changing. So you do whatever you want and keeping a distance. And restructuring unhealthy alliances. The outcome is more predictable structure, reduces emotional storm and substance use triggers. This is a little background about the structural therapy, and then I'm moving to the Bowen's family systems therapy. It's mainly about the identity, establishing differentiation of self. And BPD, emotional reactivity and intergenerational pattern of addiction. This therapy is best used. The key intervention, helping the family members not to absorb each other's emotion, reducing triangulation or a child caught between the parents. And whenever there is a fight in a family, what happens? The father will take one child with him and the mother will take another child on her side, and they try to communicate in between each other so that they think that the conflict is reduced. Actually, the conflict is not reduced, but the possibility of interaction is reduced. That is called the triangulation. That actually increases the problem between the family members. So the family systems approach used to improve the relationship between the couple. Less reactive environment, that also helps the stability, less crisis, reduce relapse patterns. Okay. Then emotional focus, family therapy. And there is sometimes the people are affected or addicted to certain behavior as a self-medication. There are different approaches. I hope that is all discussed here. Or sometimes it is a substitution satisfaction. That is a recent way of looking at the addiction. And sometimes the trauma, the childhood pain and the attachment issues, and they may use this as a means to overcome the pain. So this emotional focused family therapy is used to deal with attachment wounds, emotional bonding. And this is mainly for the BPD's deep fear of abandonment, addiction in the example I used, the second example, the girl who got married in the August, and actually she had 4 relationships before, and all 4 relationships ended within 4 or 5 months. And the present partner, she got married in October, and they lived together for 1 year just to try whether it will work. Even then she knows that it's not going to work. And she had a deep, rooted pain, abandonment, anxiety, and even she knows that it is not going to work. She tried to stay in the toxic, abusive relationship. The main intervention methods are used for repairing the attachment ruptures, teaching the family how to offer the safe environmental presence, and then reducing, the criticism, shaming, judgment. We talked about so many exercise and practical skills in the previous session. And the result, person with the BPD feel more secure when it is not criticized, shamed, when the judgment is avoided, and possibly fewer episodes of outbursts and uncontrollable reactions. And addicted member feels supported instead of attack, more motivation of sobriety. Okay, then we have the behavioral family therapy, and there are certain techniques used, and this setting the house rules, what should be done, what should not be done, and what are the plans that can be used to prevent the prevention, and reinforcing sober behavior positivity, and how to deal with a plan for emotional dysregulation, and the outcome, possible outcome, better self-control, reduce relapse frequency, increase family cohesion. And then DBT, dialectical behavioral therapy, adapted for families. And the mindfulness already discussed, distress tolerance, emotional regulation, interpersonal effectiveness, So as a result, families stop responding to the panic or anger, fewer escalation, fewer self-harm, relapse episodes, improved empathy and understanding. I will conclude with a small one sentence. You know, when you deal with a person, he is only a symptom of a sick family. If you want to treat a person, it is better to treat the family, because sickness of the individual mostly come from the sickness of the family. And that is the foundational principle for the family therapy. When it is introduced in the US, and when the people were treated and sent back to their families, they found that the people are experiencing relapse. Then they understood it is not the family, the individual, but family also needs the support. So when we deal with borderline personality or addicted individual, it is to deal with the family so that the family will support them. Otherwise, the family will encourage on their behavior. Okay? That is it. Thank you.
Thank you, sir, for the practical, insightful and deeply valuable session. May I now invite Dr. Anupji to share his reflections and to guide the session.
So thank you for this opportunity to be part of this conference, which is unique in all sense that it includes all the mental health professionals from different aspects to be a part of this conference, in which, as Manju Madam previously told, like stalwarts in psychiatry like Sharma sir and Varghese Punus sir, the person who inspired me to take up a psychiatrist career, represent. This terminology, emotionally unstable personality disorder or borderline personality disorder, is quite commonly known to all of us as mental health professionals, particularly after our MBBS in psychiatrists. You encounter, even if you have not gone to a psychiatry ward too, in your entrance examination, you typically see a young girl who came to the ward with wrist cutting and multiple unstable relationships diagnoses. Naturally, it comes to mind about a label of borderline personality disorder. And another memory that I brought back to my memories of my UG and PG life, where I was fortunate to work as a medical officer in health service under training in Thrissur before taking PG. But I still remember the resident used to tell me, like, this addiction and borderline personality, they will keep coming to you in those things. There was also sorry to be like, not jokes apart, but there was also a saying like, send this patient to your psychiatrist who don't want to flourish, you don't want to flourish, that this patient will spoil their name, etc. Jokes apart, but it was about the chronicity of the conditions that we see. And as a postgraduate, we encounter the terminologies like chronic, fluctuating, then relapsing, remitting, unstable, emotional dysregulations, and a lot of terminologies. These are a lot of we patients who test our skills actually to be of a psychiatrist, to be non-judgmental, empathetic, etc., and balancing our transference, counter-transference, etc. And when I came to health service, where the resource setting is limited, where we need a multidisciplinary team to effectively provide support to these patients or these clients, we often sometimes practice confrontation psychiatry, where you confront them, sometimes you leave them, the patient or a client leaves us. Taking the biopsychosocial model, that the many common terminologies like invalidation, rejection sensitivity, and emotional dysregulations comes in this borderline personality, whereas, as I mentioned, this enabling behavior, codependency, relapse triggers, and motivation and treatment retention, this comes in substance use. So, in the biopsychosocial model, the social parameters, the family is of particular importance. The stress triggers, family dynamics, parenting, attachment patterns, etc., expressed emotions. So, all these are significant things in this. And most of the case, like an unwritten rule, you often get a dysfunctional family, lot of things. So many often I see I still remember our case discussion in postgraduate days. Like my professor used to say that this patient, okay, have features of personality disorder. But what do you see about the parent? The parent may be like a more potential candidate for diagnosis of this label. So I was also wondering about this family therapy. Considering a setting in our, we often see more in the Western textbooks, but considering the setting in our Indian settings, where it is a collectivistic approach rather than an individualistic approach in Western settings, so how it differs. And Sir has spoken in detail about the family interventions, be it of different names, systemic, behavioral, structural, or community, multidimensional, multiple. So all focus on this, the family, the dysfunctions or corrections and the management in this family. We have to see as a family as a whole and the family aspect also in this management, because that has got a significance to the individual also. To conclude, before that, to the postgraduate trainees, what I want to say is that it is important equally, particularly psychiatrists, like it is equally important to learn the basics and the skills of therapy rather than just being on a neurobiological and psychopharmacological perspective. And now the fashion or the dicta of the rule is like integrated therapies. Be it use different conditions. Now the current focus is integrated therapies where the good points of various different therapies are taken together and merged so that address a holistic approach. And coming to the presentation, Sir has covered the aspects of family therapy, the key interventions and targets. And thank you once again for the wonderful presentation. And it is open to discussion. So any questions, please?
First and foremost, thank you all of you for staying. Almost 65 participants have stayed back. It's a big thing. That itself is a big validation for us. Thank you. Next, we have our counselors on it. Reverend Father Sam and Appayade friend. So, just an opinion about the topic.
രാവിലെ മുതൽ ഇത്രയും സമയം ഇവിടെ ഇരുന്ന എല്ലാവരെയും ഡോക്ടർ പ്രത്യേകം അഭിനന്ദിച്ചു. ഞാനും അത് തന്നെ പറയാറുണ്ട്. വളരെ നല്ല ഒരു അറിവാണ് നമുക്കിവിടെ നിന്ന് ലഭിച്ചത് എന്നുള്ളത് ഞാൻ അതിയായി സന്തോഷിക്കുന്നു. പ്രത്യേകിച്ച് ഞങ്ങളെപ്പോലെ പ്രായമുള്ളവർക്കും അതുപോലെ കുട്ടികൾക്കും ഒക്കെ എല്ലാവർക്കും ഒരുപോലെ പ്രയോജനപ്പെടുന്ന നല്ല ഒരു അഡിക്ഷൻ ആൻഡ് ഓർഡർ പേഴ്സണാലിറ്റി ഡിസോർഡറിനെ പറ്റിയുള്ള നല്ലൊരു ക്ലാസ് ആയിരുന്നു. റൂബൻ അതിന് ഓർഗനൈസ് ചെയ്തതിൽ പ്രത്യേകം സന്തോഷമുണ്ട്. ഇവിടെ വരുവാനും കാണുവാനും. സിസ്റ്റർ ജോയന് വളരെ നാളുകൾക്ക് മുമ്പോട്ടെ പല ക്ലാസ്സുകളും ഞാൻ അറ്റൻഡ് ചെയ്തിട്ടുണ്ട്. ഡി അഡിക്ഷൻ മേഖലയിലും പ്രവർത്തിച്ചിട്ടുണ്ട്. ട്രാഡയിലും പല പ്രാവശ്യം ഞാൻ വന്നിട്ടുണ്ട്. വളരെ സന്തോഷം എല്ലാവരും ഒന്നിച്ച് കാണുവാനും ഇവിടെ വരാനും ഇടയായതിൽ സന്തോഷമുണ്ട്. ഇനിയൊരു അവസരം കിട്ടിയാലും തീർച്ചയായിട്ടും വരുന്നതാണ്.
റെവറൻഡ് ഫാദർ ക്രിസ്റ്റോ, ഓൾമോസ്റ്റ് about the ടോപ്പിക്കിനെ പറ്റിയും സാറിൻ്റെ ഒരു
താങ്ക് യു സോ മച്ച് സാർ. കാരണം ഫാമിലി തെറാപ്പി ഒരു വളരെ ഇമ്പോർട്ടൻ്റ് ആയിട്ടുള്ള ഒന്നാണ്. ഒരു കുഞ്ഞ് വളർന്നു വരുന്നത് തന്നെ ഫാമിലിയിൽ നിന്നാണ്. അപ്പോൾ ചൈൽഡ്ഹുഡിലുണ്ടാകുന്ന ഇൻഫ്ലുവൻസസ് ആണ് പലപ്പോഴും വളർന്നു വരുമ്പോൾ പല ഡിസോർഡേഴ്സിലേക്കും ഒരു കുഞ്ഞിനെ കൊണ്ടുപോകുന്നതും അത് ഒരു കമ്മ്യൂണിറ്റിക്ക് ഡിസ്റ്റർബൻസ് ആയി മാറുകയും ചെയ്യുന്നത്. അപ്പോൾ ഫാമിലി തെറാപ്പി എത്രമാത്രം ഇമ്പോർട്ടൻ്റ് ആണെന്നും അതിൻ്റെ എല്ലാ വശങ്ങളിലൂടെയും പറഞ്ഞു തന്ന സാറിന് വളരെയധികം സന്തോഷമുണ്ട്. ഞാൻ കൂടുതൽ കാര്യങ്ങൾ മനസ്സിലാക്കുവാനായിട്ട് സാധിച്ചു. അതുപോലെ തന്നെ ഈ തെറാപ്പികളൊക്കെ എങ്ങനെ അത് വളരെ സിമ്പിളായിട്ട് അപ്ലൈ ചെയ്യാമെന്നുള്ളതായ ട്രിക്സ് പറഞ്ഞു തന്നതിലും ഒത്തിരി സന്തോഷം. ഇങ്ങനെ ഒരു ഓപ്പർച്യൂണിറ്റി ഒരുക്കി തന്ന ഡോക്ടറോടും ഇതിൻ്റെ ഉത്തരവാദിത്തപ്പെട്ടുള്ളതായ നന്ദി അറിയിക്കുന്നു. താങ്ക് യു.
ആർക്കെങ്കിലും കുട്ടികൾക്ക് ആർക്കെങ്കിലും ഇപ്പം ക്വസ്റ്റ്യൻസ് ഉണ്ടോ? കോൺഫിഡൻസ് വന്നോ ഒരു ക്വസ്റ്റ്യൻ ചോദിക്കാൻ? ഇനി ഓടിപ്പോയാലും പ്രശ്നമില്ല, സെഷൻ കഴിഞ്ഞു. ഓക്കെ. അപ്പോൾ നമ്മുടെ റോസ്ലിൻ ഉണ്ട്. ഷീസ് റെപ്രസെൻറ്റിംഗ് ഡോക്ടർ ജോബീസ് കരിയർ, സൈക്കോളജിസ്റ്റ് ആണ്. സോ ഷീൽ ആസ്ക് എ ക്വസ്റ്റ്യൻ. റോസ്ലിൻ ഷീ വാസ്, നമുക്ക് ആക്ച്വലി ട്രാവൽ അറേഞ്ച്മെൻറ്റ് ചെയ്യാം, പക്ഷേ അത് കഴിഞ്ഞിട്ട് പിന്നെ സം കോംപ്ലിക്കേഷൻ ഉണ്ട്. റോസ്ലിൻ പറഞ്ഞു ഞാൻ നടന്നാണെങ്കിലും കുഴപ്പമില്ല വന്നോളാം. പക്ഷെ എന്നാലും ഭാഗ്യത്തിന് നമ്മുടെ വർഗീസ് പിന്നു സാറിൻ്റെ അയലോക്കമാണ്. സോ സാർ ഗ്രേഷ്യസ്ലി അഗ്രി ടു ബ്രിങ് ഹർ. ഷീ ഈസ് വെരി വെരി ഇൻട്രസ്റ്റഡ് ഇൻ ദിസ് സെഷൻ. സോ അതുകൊണ്ട് എന്തായാലും ഒരു ചോദ്യം കാണുമെന്ന് പ്രതീക്ഷിക്കുന്നു.
Hello, good afternoon, good evening. ഇങ്ങനെ ഒരു വണ്ടർഫുൾ ഓപ്പർച്യൂണിറ്റി ഞങ്ങൾക്ക് തന്നതിന് റൂബൻ സാറിന് താങ്ക് യു. ഞാൻ ഓൾറെഡി ഒരു ക്വസ്റ്റ്യൻ പ്രിപ്പയർഡ് ആയിരുന്നു, ബട്ട് നോട്ട് ഷുവർ. ഓക്കെ, ബിക്കോസ് BPD and substance use often occur together. Emotional dysregulation tends to intensify the risk for addictive behaviors and self-injury behaviors from a therapeutic point of view. How can CBT or DBT can be applied in a structured way, helping clients understand their patterns, manage their emotions, and അതേപോലെ നമ്മൾ ഈ തെറപ്പി ചെയ്യുമ്പോൾ വിതൗട്ട് ഗെറ്റിംഗ് ഇമോഷണലി ഡ്രെയിൻഡ്, ഹൗ ഡു വി ഡു ദാറ്റ്?
So the speaker ആണ് question is basically ഈ തെറപ്പീസ് ഒക്കെ ചെയ്യുമ്പം ഒരു സൈക്കോളജിസ്റ്റ് ആകുമ്പം ഇങ്ങനെ ഇമോഷണലി ഡ്രെയിൻഡ് ആവാതെ കുറേ സെഷൻസ് ഉണ്ട്, 6 മാസം 9 മാസം. ഹൗ ഡു യു മാനേജ് ദ തെറപ്പി? ബിക്കോസ് ഇത് വെരി റെലവൻറ്റ് ഫോർ നമ്മുടെ സാർ, ബിക്കോസ് ഒത്തിരി പേഷ്യൻസ് സാറിന് നമ്മൾ വരാറുണ്ട്. ഹി സെസ് സെഷൻസ് ഒക്കെ 2 hours 3 hours 5 hours ഒക്കെ ചിലപ്പോൾ സെഷൻസ് പോകുന്നത്. സോ ഇറ്റ്സ് എ വെരി റെലവൻറ്റ് ക്വസ്റ്റ്യൻ ഫോർ ആർ ജോർജ് മാത്യു സാർ. എങ്ങനെയാണ് സാർ മാനേജ് ചെയ്യുന്നത്?
There is a concept called self-care, and if we are not taking care of ourselves, we cannot care for others. So we have to find the ways to, rejuvenate and keep ourselves mentally, physically active. There are activities depending on what you like. Okay, I go for a morning walk, or even usually I go for night walk. When I finish the session by 11 o'clock, even at 10 o'clock or 11 o'clock, I go for walk. And maybe beginning of this year, I was going to gym, then watching movies, do something. Or even I have a therapist to supervise me. And as part of my PhD program, he is from US, and once in a month, he connect with me and we talk about my own concerns. And even therapists also need therapy. Okay, we have another group of therapists, and so we come occasionally connect and even discuss. So self-care, in everything together, it is self-care. So until and unless, otherwise we will experience emotional exhaustion, burnout experience. After some time, there was a mental health conference during the COVID, and it is arranged from Singapore, and then two people in the mental health profession, they said they are almost started taking medicines because they came to the burnout experience. They are into depression because nobody come to you with a positive experience, only negativity. And you have to sustain your energy. You have to sustain your positivity, and you cannot supply continuously. You have to recharge. So there is a subject that we study as part of it is called self-care. There are so many ways to do that one. That will help. Thank you.
Okay, last ചോദ്യം will be from our sister Prashanti. Madam പാലയെന്ന് വന്നു, വെരി enthusiastic ആയിട്ട് വന്നു. Really glad that you came. മാഡത്തിൻ്റെ ഒരു ഒപ്പീനിയനും ഒരു ക്വസ്റ്റ്യൻ.
Thank you very much for calling us, me and Sister Carmeli, Dr. Sister Carmeli. We came together. It was very interesting and encouraging topic. We interested. That's it.
അപ്പം നമ്മളെങ്ങനെ ഈ സെഷൻസ് വൈൻഡപ്പ് ചെയ്യുവാണ്. സ്പെഷ്യൽ താങ്ക്സ് ടു ഡോക്ടർ അനൂപ്. രാധിക ആയിരുന്നു ടു ചെയർ ദി സെഷൻ. രാധികയുടെ ഫ്ലൈറ്റ് ക്യാൻസൽ ആയപ്പം ജസ്റ്റ് ഒരു തലേദിവസമായിട്ട് ചോദിച്ചപ്പോൾ തന്നെ ഹി അഗ്രീഡ്, നോ ക്വസ്റ്റ്യൻസ് ആസ്ഡ്, ടോപ്പിക് എന്തുവാന്ന് അറിയേണ്ട ഒന്നും വേണ്ട, ഹീൽ കം എന്ന് പറഞ്ഞ് പിന്നെ നമ്മളായിട്ട് സാറേ എല്ലാ പ്രസൻറ്റേഷൻ ഒന്ന് നോക്കുന്ന പറഞ്ഞ് അങ്ങോട്ട് വിടുമായിരുന്നു. സോ റിയലി താങ്ക് യു സർ. നെക്സ്റ്റ് ഐഡ് ലൈക്ക് ടു ഇൻവൈറ്റ് അവർ സീനിയർ തെറപ്പിസ്റ്റ് ആശിഷ് Samuel to present the mementos to our speaker George Matthew and our chairperson Anup ji. And with that, I'd like to invite our clinical psychologist, Srija Sampath, to give the final vote of thanks to the delegates and speakers.
Good evening, everyone. As we come to close of today's enlightening sessions, it's my privilege to express our heartfelt gratitude on behalf of the Department of Psychiatry and De-Addiction at Dr. K.M. Cherian Institute of Medical Sciences. Today's CME on addiction and borderline personality disorder has been meaningful crossroads, bringing together distinguished mind and compassionate hearts dedicated to the mental health care. First and foremost, I would like to thank our distinguished speakers, Dr. Radhika, Professor Dr. Varghese P. Punnus, Dr. Suma Udupa, Ms. Priya Varghese and Mr. George Matthew for sharing their valuable insights and expertise. Your thought-provoking presentations have deepened our understanding of addiction and personality disorder and inspired truly meaningful discussions. A sincere thank you to our respected chairs, Dr. PSVN Sharma, Sister Dr. Joan Chongapura, Dr. Manju Pidambaran, Dr. Jayshankar, Dr. Anu, for skillfully guiding the sessions and ensuring their smooth flow throughout the day. Our heartfelt appreciation goes our beloved Managing Director, Reverend Father Dr. Alexander Kudarathil, whose visionary leadership continues to illuminate the path of the institution. Thank you, Father, for your guidance, courage, and tireless commitment to make this CME successful. We are also deeply grateful to Dr. Ruben John for warm welcome and for setting the tone for today's program. Sir, your vision and guidance made this CME possible and meaningful. Behind every successful program lies a dedicated team, our organizing committee, technical crews, and hospitality staff. Thank you all for your commitment, creativity, and tireless effort that made today's CME seamless and memorable. Finally, thank you all our delegates and participants for being there today and for making this academic gathering truly meaningful. We hope the knowledge shared today continues to guide our work and inspire us in our professional journeys. Once again, thank you all and have a wonderful evening.
Thank you, Dr. Srija, for your heartfelt words. Thank you for being part of inPSYght 25. Today we move toward better care, deeper understanding, and a future of stronger hope.
Dear participants, we will be serving coffee and snacks immediately after this program. We warmly invite all participants to join us and share the time of fellowship. Thank you once again for your gracious presence and active participation throughout this national seminar, inPSYght 2025. On behalf of the Department of Behavioral Sciences and De-Addiction, Dr. K.M. Cherian Institute of Medical Sciences, we extend our heartfelt wishes to each one of you. May the knowledge shared today inspire your clinical practice, enrich your academic journey, and strengthen our collective commitment to mental health care. Wishing you all continued growth, compassion, and excellence in your professional path. Thank you and warm greetings to you all.